Hello. Good morning, everyone. Today, on the 17th of September 2023, we are here at IMO Kozhikode with a hybrid session of the Suicide Prevention CME. And now we are entering the inaugural program. We have been joined by a lot of delegates from all over India today. As we start, we have the inaugural session. We have the welcome address. And starting with the inaugural program, I'm inviting the delegates for the day to the podium. Dr. Mohan Sundaram, the chairman of the organizing committee and the president, Calicut Psychiatric Guild. Good morning, sir. Dr. P. N. Suresh Kumar, the convener of the organizing committee, on the podium. And then we are joined by Dr. Raju Balram, the president-elect, Calicut Psychiatric, president-elect, IMA Kozhikode. And joined online, we have Dr. Jayaprakash KP, the president, Indian Psychiatric Society, Kerala chapter, and Dr. Varun S. Mehta, chairperson, Indian Psychiatric Society, the suicide prevention section, and Dr. Anis Ali, secretary of the Calicut Psychiatric Guild. We start our inaugural session, inaugural program, by the welcome address by our convener of the organizing committee, Dr. P. N. Suresh Kumar. I welcome you, sir.
Very good morning, respected seniors, my colleagues and friends. Every year, World Health Organization and International Association for Suicide Prevention is observing September 10th as World Suicide Prevention Day. The purpose of observing this day is to make people aware that suicide is a preventable health hazard. By timely identification and proper management, many of these suicides can be prevented. Carrying this message, today, we, the Indian Psychiatric Society, the Suicide Prevention Section, and the Indian Psychiatric Society Kerala State Branch, Calicut Psychiatric Guild, and Indian Medical Association Kozhikode Branch, jointly organizing a CME on suicide prevention for primary caregivers. Our beloved President of IPS Kerala Chapter, Dr. K.P. Jayaprakash, is inaugurating the CME. I welcome you, sir. I think this will be his first official program. I also invite the President of Calicut Psychiatric Guild, Dr. Mohan Sundaram, for presiding this function. Dr. Varun S. Mehta is the chairperson of Indian Psychiatric Society's Suicide Prevention Section. He will be proposing special address here. I welcome you, sir. Dr. Raju Balram, he is the president-elect of IMA Kozhikode, He is also giving felicitation in our CME. I welcome you, sir. Now it is my duty to welcome the eminent speakers for our CME. We have Dr. Krishna Prasad. He is the additional professor of psychiatry from NIMHANS. I welcome you, sir. Dr. Shubhangi Parker. She is the professor of psychiatry, Vedanta Institute of Medical Sciences. She is from Maharashtra. I welcome Dr. Shubhangi also for the CME. I welcome Dr. Varsha Vidyadharan. She is the Associate Professor of Psychiatry, Calicut Government Medical College. I welcome her. Dr. P.N. Suresh Kumar, he is the Director of Chedana Central Institute of Psychiatry, Kozhikode. Welcome. Then we have, after the morning session of CME, we have a panel discussion here. For the panel discussion, the panel discussion is being moderated by Dr. Harish M.T. He is the professor and head of the Department of Psychiatry of Calicut Medical College. I welcome you, sir. In the panelists, we have Dr. Varun S. Mehta. He is the professor of psychiatry, Central Institute of Psychiatry, Ranchi. We have Dr. Dayal Narayanan. He is the associate professor of psychiatry from Government Medical College, Kozhikode. Then Dr. Shankar Mahadevan. He is the director of Shankar ENT Center, Kozhikode. We have another panelist, Dr. Sri Krishna Kumar. He is the editor of Madhrumi Arogya Masika. And Sri Umesh A. He is the Assistant Commissioner of Police, Special Branch, Kozhikode City. I welcome you, all of you, for the panel discussion. Last but not the least, I welcome all the delegates, including the psychiatrists, non-psychiatric doctors, psychologists, social workers, volunteers in mental health field, all the members of our guild, Calicut Psychiatric Guild, and the students in mental health field for this CME. I hope this CME will be very fruitful for all of you for identifying the suicide tendency in the people you are managing in your day-to-day care. Thank you all.
Thank you, sir. And for the presidential address, we have Dr. Mohan Sundaram, who is the chairman of the organizing committee and the president of the Calicut Psychiatric Guild. Welcome, sir.
Good morning, everyone. Dr. P.N. Suresh Kumar, convener. Dr. Soheb Raj, organizing committee convener. Dr. Raju Balram, who are all present here, and all the dignitaries who are online for this special CME session. Speakers, eminent speakers and panelists for this meeting, and all the delegates. I wish you all a great day, because today we are observing the Suicide Prevention Day, though a week later, by organizing this CME for primary caregivers. I thank the Indian Psychiatric Society for entrusting Calicut Psychiatric Guild to organize this meeting with Indian Medical Association and IPS Kerala. And also I appreciate the organizers, in spite of the epidemic crisis in Kozhikode. We have been able to organize this as an online meeting. Now, coming to the suicide and suicide prevention, I will not take much of your time, but then you all know, like, it is an emergency medical care for preventing suicide, where not only the medical professionals but non-medical professionals non-psychiatrists, psychologists, so psychosocial workers, health workers, community care workers, all are collaboratively addressing this issue, and only by the joint efforts of these various sectors we can sort of like to a great extent prevent prevent people dying by suicide. We all know mental disorders, substance abuse disorders, personality disorders, and even people with distressed life states, situational problems, personality vulnerabilities are all prone to suicidal action. So, like it is our duty to understand the earliest signs of a patient's intent for suicide, a medical patient or a non-medical patient or a normal person. As I told, at vulnerable situations, any normal persons are prone to suicidal act. We all know that Kerala is one of the largest reporters of suicides in India, almost double the prevalent rate in all over India. And also, like we know, mental disorders score high in suicides rates. So for prevention, it is a collective effort of doctors, non-medical professionals, and as I told, health workers, and their awareness to early detect the warning signs, and also crisis helplines, which will be very useful and are the solace for those lone people who could not share or would not share their distress. So thinking in that way, like this CME, I'm sure will address all the various aspects of the occurrence and the prevention of suicidal act. So I hope all of you will be enlightened by our speakers and the sessions, and I wish the program a grand success. So thank you very much for being here, and also thank IPS and IMA and IPS Kerala for this. Jai Hind.
Thank you, sir, for the lovely address. Now, we'll be joined online for the inauguration by Dr. Jayaprakasan KP, who is the President of the Indian Psychiatric Society Kerala chapter. He'll be inaugurating the ceremony with his inaugural address. I welcome you, sir.
Dear colleagues, dignitaries joined online and offline all over India. My dear friends, thank you for inviting me to this suicide prevention program. And in fact, as Dr. P.N. Suresh Kumar pointed out, this is my first official program. After assuming the office of President of Indian Psychiatric Society, Kerala State Branch, I think I am audible. Am I audible?
You're audible, sir.
Okay. So, in fact, the September 10th, the Suicide Prevention Day, was our conference day, and we had a speech by Dr. C.J. John on the eve about the suicide prevention in Kerala. It's a well-known fact that Kerala tops in the suicide rates in India for several years. But recently, Kerala was pushed to the position 4. But even then, among the bigger states, Kerala comes to first after Chhattisgarh, maybe. These Chhattisgarh is not that much big state. In India now, Andaman Nicobar tops the suicide rate, then Sikkim, Chhattisgarh, and Kerala. Tamil Nadu and Telangana, I think, is closely behind. But the thing is, many times statistics don't reflect the reality. For example, suicide, several studies have pointed out that suicide rates in India are undercutting because of the lack of registration of death and medical certification of deaths. Global Burden of Death study in 2018 found that India's system of death certification covered only 22.5% of deaths. And that is 43% in Tamil Nadu and 3.4% in Bihar. So death itself is very much underreported in many parts of India, and suicide is also. I will draw your attention to two community studies, one in Vellore and another in Trivandrum. Dr. C.R. Soman, almost a decade back, undertook a study in Trivandrum urban and rural areas in the community to find out the rate of suicide in the community, real rate of suicide. It was found to be equivalent to the reported rates. A similar study was conducted by some other at Vellore, Tamil Nadu, and the reported rates were found to be very much lower than the real rates. In fact, the real suicide rate around Vellore was threefold than that was reported. So underreporting of suicide due to cultural factors, stigma and social factors is rampant. But Kerala, because of its own unique nature of the social system, social customs, and maybe some kind of trust with the medical system and law, and also distrust among oneself, among the family members. Once suicide occurs, somebody will accuse that later that it's a homicide or something like that. Any unnatural death goes reported, and the reported rates you can trust this is the real rates. So this disparity is there. Even then, I'm not underestimating the importance of suicide prevention programs in Kerala, and we have to. This is something which we have to address seriously. See, my only point is you can compare apples with apples. Apples and oranges are different. Apples have their own problem, oranges have their own problem. So with this opening note, I'm not taking much of the time from the speakers because there are eminent speakers and I would like to listen to them as far as possible. With this note, I congratulate the Calicut Psychiatric Guild and IMA in organizing this program, and also Dr. Suresh Kumar and Suresh Kumar PN and other organizers of the program in organizing such a program in a timely manner. And also thank you for inviting me for this program once again. And I declare that the seminar, the program, CME program is inaugurated. Thank you.
Thank you, sir, for your thought-provoking words. And now, since the ceremony is open, I would invite for our special address, Dr. Varun S. Mehta, who is the chairperson of the Indian Psychiatric Society Suicide Prevention Section. I welcome you, sir.
Good morning. Am I audible?
You are audible.
Okay, thank you. Good morning, everyone. First of all, my regards to the state of Kerala and the Kozhikode district who's battling the Nipah virus at the moment. At the onset, I would like to thank the IPS Kerala State Branch, the Calicut Psychiatric Guild, for giving the specialty section of suicide prevention opportunity to do a CME. In fact, the idea of doing it with IMA came from a mentor, Dr. Lakshmi Vijay Kumar, and we were very glad that we've been able to have it with you. In fact, we were struggling with our dates. We really could not finalize the dates, considering that the whole of September is actually filled with a lot of activities around. And we were able to finalize the date thanks to active efforts and coordination by Suresh Kumar sir. But unfortunately, we had to shift it to online mode. Nevertheless, I'm really glad that we are having it. I was actually, when he first called, I thought that we probably have to cancel it, but I'm really glad that we are able to do it. Also, thanks to Dr. Arvind Brahma sir, Dr. Vinay Kumar, President-elect, OP Singh sir, and Aleem sir for being with us and for agreeing to be part of our activities and encouraging and supporting us all the time. A special mention to Dr. Sujit Sarkar, who's been inspirational in having us, having me, in fact, and kindling my interest in this area of suicide prevention. The speakers, in fact, quite eminent, and in fact, Krishna Prasad sir and Shubhangi ma'am readily agreed. And I'm really glad to have them, and I hope that it can benefit each and every one of us. Thank you, and thank you for giving the opportunity to be there in the inaugural address as well. Special thanks to the organizing committee and Suresh Kumar sir and everyone on the dais. Thank you, sirs. Wish you all the best. Thank you.
Now we have the felicitations by the President-elect, Indian Medical Association, Dr. Raju Balram, Indian Medical Association, Kozhikode branch. Welcome. I welcome you, sir.
Respected Dr. Mohan Sundaram, Dr. P. N. Suresh Kumar, Dr. Jayaprakash KP, Dr. Varun S. Mehta, Dr. Anis Ali, Zoeb Raj, ladies and gentlemen, esteemed members of the Indian Psychiatric Society. I stand before you today with deep gratitude for the Indian Psychiatric Society and its tireless efforts in organizing this crucial continuing medical education event focused on suicide prevention. This initiative couldn't have come at a more crucial time as we confront the pressing issue that affects not only our society at large, but also our very own colleagues, which being the alarming increase of suicide rates among doctors. Not too long ago, the Indian Medical Association Kozhikode woke up to the horrifying news that a husband-wife doctor couple had committed suicide. In a world which often emphasizes physical health, it is easy to overlook the immense mental and emotional burden that our healthcare professional bears. COVID-19 has been an example of the limit to which the healthcare professional can be stretched, and it can be mentally agonizing. The need to address the mental health of doctors is not just a moral imperative, it is a necessity for our healthcare system's resilience and sustainability. A recent study found that doctors have a higher risk of suicide compared to the general population. Burnout, fatigue, and a sense of helplessness can lead to severe mental health issues among healthcare professionals, and ultimately it jeopardizes patient care. The Indian Psychiatric Society, by organizing the CME, is not only acknowledging this critical issue, but is taking concrete steps towards addressing it. By providing a platform for education, awareness, and discussion, you are helping to destigmatize, to acknowledge the fact that you have a problem, and seek help for mental health issues, which is an essential help for doctors and the population alike. Through knowledge sharing, research, exchange of experiences, we can better understand the risk factors, warning signs required for suicide prevention. We must together create a culture, support and empathy within the medical community, where seeking help for mental health concerns is encouraged and normalized. In conclusion, I extend my heartfelt thanks to the Indian Psychiatric Society for organizing this vital CME on suicide prevention. Your dedication to improving mental health and addressing unique challenges is commendable. Together, we can make a difference and ensure that the medical community not only heals others but is also cared for and supported in times of need. Thank you for your commitment to this cause, and let us continue to work collaboratively towards a brighter and mentally healthier future. Thank you.
So again, we have come to the end of the inaugural session and to the vote of thanks. Has Dr. Anis Ali joined us online? So if you could, I'm not able to actually find you online, sir. If you could just message me. ഓൺലൈൻ ഇല്ല, ഞാൻ മെസ്സേജ് അയച്ചിരുന്നു. So coming to the end of the inaugural session, for the vote of thanks. So again, since the inception on the conceptualization of the program, we had actually planned a physical program, and although we have actually taken it online to the current Nipah issues at Calicut, we have had a lot of viewers currently participating from all around India. I thank all the viewers of the program who are actually flag bearers of actually taking suicide prevention all the way. I thank you all. And we would, and to the program, we would be joined by speakers from Dr. Krishna Prasad, who is from NIMHANS, and Professor at NIMHANS, then Professor Shubhangi Parker, Dr. Varsha Vidyadharan, and Dr. P.N. Suresh Kumar, the renowned speakers who would be joining us. And again, there will be chairs for the following sessions. We have eminent chairs, Dr. P. Ashok Kumar, Dr. Sushil Kakkan, Dr. Sheba Nainan, and Dr. Rajmohan Velayadan. The chairs for each of the sessions, I thank all of you. And followed by, and today for the inaugural session, we have been joined by the president of the Calicut IPS Calicut chapter, Dr. Jayaprakash and KP. I thank you, sir. I'm very thankful for you, for your valuable time. And we started out with the inaugural, the presidential address. President of the Calicut Psychiatric Guild, who has been instrumental in helping us with the setting up the program, Dr. Mohan Sundaram. I thank you, sir. The convener for the program, Dr. P.N. Suresh Kumar, has been instrumental in setting up all the programs, all the schedules. I thank you very much, sir. Then we have, after the inaugural scientific session, we are followed by a panel discussion. I thank all the panelists, including the moderator for the day, Dr. Harish MT, who is the professor and HOD of the Calicut Medical College. The panelists, Dr. Dayal Narayanan, Dr. Varun S. Mehta, Dr. Shankar Mahadevan, and Mr. Krishna Kumar, and Mr. Umesh. I thank all of you for your kind participation. And again, for ending today's vote of thanks, a special thanks and mention to the organizing committee headed by Dr. Mohan Sundaram, President of the Calicut Psychiatric Guild, and the Secretary, Dr. Anis Ali. I thank all of one and all of you and the kind viewers, and I request you to spread the word, because we are also telecasting live on YouTube channel. I thank you all once again, and we are entering the scientific session now.
Speaker slide. Chairperson ആരാ?
Oh, we have been gracefully joined by the. We are grateful, and we are gracefully joined by the Secretary of the Indian Psychiatric Society, Dr. Arvinda Brahma, saying a few words on the special occasion. I welcome you, sir.
Uh, Thank you very much. IPS, this suicide prevention section is doing a program this time in virtual mode. I think this is very important because uh, we all know that suicide is a public mental health problem, and Indian Psychiatric Society is always planning how to we can prevent this suicide, because you know the way in these days, especially the student suicide has increased to a great number. We are talking more about farmer suicide and others, but in the recent days, student suicide has reached to a great extent. So I think IPS has a very special role in it, and we are already planning that school mental health program committees, college mental health committee, and this suicide prevention committee, they should work together in a collaboration, and maybe we can come out with some suggestions that we can talk to the at the government level also. Very recently, I had a talk with the Secretary of the Ministry of Social Justice, and they have also shown their interest that they want to work in collaboration with Indian Psychiatric Society. Important, it's good that you have not cancelled the physical one, rather you have gone for online. I think we'll have a good participation here, and so many audience you're broadcasting in YouTube. So this technological help is definitely helping us, and that will help to increase the public awareness also, which is very important, especially the issue like suicide. So once again, I'm welcoming all the audience present in today's program, and best wishes. Over to you. Thank you.
Thank you very much, sir. Your talk was insightful, and thank you very much for your kind words. And we have been grateful enough for your participation. Thank you, sir. Now, and over to the first session. We and the scientific program proper. Over to the first session. Our first session would be gatekeeper training in suicide prevention. The first speaker is Dr. Krishna Prasad, who is the additional professor of psychiatry at NIMHANS Bangalore. Dr. Krishna Prasad is the additional professor of psychiatry at NIMHANS Bangalore. His areas of interest include psychiatric rehabilitation, emergency psychiatry, geriatric psychiatry, and gatekeeper training for suicide prevention, vocational rehabilitation of the homeless and mentally ill. He has had 86 articles published in the peer-reviewed journal. I welcome you to the scientific session, sir. The session would be chaired by Dr. P. Ashok Kumar, who is a consultant psychiatrist at IMHANS, Calicut. I welcome both of you, sir. And I welcome Dr. P. Ashok Kumar. Dr. P. Ashok Kumar.
Good morning, everybody. Uh, to begin with, I thank the organizers for inviting me to chair this session, and also compliment the organizing committee for conducting the program despite the unexpected Nipah outbreak. And we know that suicide rates are increasing, and we had about our suicide rate in 2021 was about 12 per 1 lakh, and the modes of suicide and though the form of the suicides may be fundamentally same, we find different people adopting different methods. Now we find that even people who are sitting at home are trapped by loan mafia, and recently we have found in Kerala that many people are resorting to suicide when they are checkmated by the nefarious designs of the loan mafia. Under these circumstances, the discussion on the topic assumes high significance, and Dr. Krishna Prasad, who is associated with gatekeeper training, is an eminent speaker. I would request him to start things, and I don't. Okay.
Over to Dr. Krishna
I would
Prasad.
request. Okay.
Thank you, Dr. Ashok, for. Shall I share the screen or? Yeah. Is the screen visible?
Yeah,
sir?
please do. Yes, it is visible, sir.
So.
Can you actually present? Yeah. Thank you, sir.
Is it visible now? Yeah. Yeah, so at the outset, I would like to thank the organizers, Indian Psychiatric Society, Kerala State Branch, the Calicut Psychiatric Guild, and the Indian Medical Association, Kozhikode branch, for inviting me to present about gatekeeper training for suicide prevention, with which I have been associated for the last 10 years. My acknowledgements while making this presentation are to my teachers, Dr. Prabha Chandra, who was instrumental in starting this at NIMHANS in 2013, and Professor Senthil Reddy, and to my colleague, Sister Padmavati, staff nurse, who has always been supportive of this program, and to my director, Professor Pratima Murthy. Now, before I talk about gatekeeper training, I thought we need to contextualize it in terms of the magnitude of the problem and understand in what context are we looking at gatekeeper training. So we have at the one end, we have the completed act of suicide, and for every suicide, there are at least 15 to 20 suicidal attempts. And behind these suicidal attempts, there are suicidal thoughts, and there are people who are at risk for suicide. So roughly there are around 200 people with suicidality for each suicidal attempt that we see. If we look at what are the different sources of information as far as suicide or suicidal behavior is concerned, we have very hard data that comes from the National Crime Records Bureau. We have some data that are available from local community surveys, and there are a few large-scale epidemiological studies that have been done in India. And then there are some hospital-based records and some verbal autopsy or psychological autopsy reports that provide us some sources of information. But as Dr. Jayaprakash already mentioned, there is a lot of stigma that is associated with the suicide and attempt, and there is a likelihood of gross underreporting of suicide and suicide rates. And there is always a difficulty when you look at community-based studies about determining intent in the case of disease. So there are issues surrounding the reliability of statistics as far as suicide is concerned. If we look at India regionally, in terms of the WHO Southeast Asian region, we seem to be having the highest suicide rates per lakh population, whereas the regional average is around 13.2. Ours is much over 15. This data that is presented here is from Lancet Public Health publication, and we know that 18% of the world's population live in India, and 42% of the population is aged between 15 and 39 years. In this context, it is important to understand that India's contribution to global suicide deaths is 1 of 3 women, and for men, it is 1 of 4. Whereas in the West, more men compared to women end their lives with suicide. The men to women ratio in India is 1.34. And suicide is the leading cause of death in India for those who are aged between 15 to 39 years. And there are certain states, particularly the southern states, where the suicide rates are much higher. And we don't know whether this has to do something with the socio-demographic index and the socio-economic index of these states. This is the NCRB data from 2021. Again, if you look, the southern states, particularly Kerala, Tamil Nadu, Puducherry, and the Andaman and Nicobar Islands, and certain northeastern states like Sikkim have very high rates of suicide when compared to the all India average of 12 per 1 lakh population. The most common methods of suicide in our country are hanging and poisoning, and these two seem to be consistently so for the last several decades. Whereas in the West, the most common reason for suicide is mental illness. In our context, it is more often, at least in several, the data that is available with the National Crime Records Bureau, is that it is in the context of family problems, it is in the context of interpersonal issues, it is in the context of marriage, it is in the context of failure in exams. So mental illness per se, probably at least documented as an immediate cause is far and few. A range of factors modulate suicide, both at the population and individual level. And when we look at training gatekeepers, we need to understand that there are both population level factors and there are individual level factors. So we very often hear about very proximal factors being, as mentioned, even in newspaper reports as the reason for suicide. But it is important to understand that most suicides are multifactorial, and there are several distal and developmental factors that are responsible besides the immediate precipitating or the proximal factor that is there. Now, this is an interesting model that has been proposed, and this probably summarizes the population risk factors and the individual risk factors that are there. So rapid changes in social structure or values, the economic turmoil, social isolation, lack of social cohesion, all of these could be important population risk factors. And family history of suicide and genetics may be distal or predisposing factors, whereas there are several developmental or mediating factors such as chronic substance use, high impulsive aggression, high anxiety, personality traits. All of these may be mediating factors, whereas what we see immediate are the proximal or precipitating factors such as acute substance use, behavioral disinhibition as a result of mental illness or acute stressors or life events, leading to hopelessness, suicidal ideation, suicidal behavior, and suicide. There are environmental factors such as the way media reports suicide, the access to means to suicide, and poor access to mental health care, also which will be modulating the risk for suicide. There are several existing barriers to suicide prevention. There is high stigma and poor awareness about suicide. There is limited evidence for effective prevention strategies, and human resource deficiency has been emphasized several times. And the scope of problem, it is highly variable even across a country like India, which is, you can see the stark difference across several states in India. And there are lack of identified key stakeholders and the government policies that are in several times focused on health service. And there is limited research as far as prevention is concerned that probably does not apply to the larger population at times. WHO has proposed 3 levels of intervention and prevention. One is at a community level, or which is universal. One is for vulnerable population, for example, those with mental illness, and indicated prevention strategies for suicide attempters. Of the several strategies that the WHO has proposed in terms of suicide prevention, you would look at the list. WHO looks at suicide prevention in terms of live life. That is, each of these stands for a certain term. For example, leadership, interventions, vision, and evaluation in the context of lessening means of suicide, interacting with media, forming the young, and early identification. So it is in this context that gatekeeper training is one of the different strategies that is used at suicide prevention. Of course, there are other important strategies that WHO considers are important, such as reducing access to lethal means, responsible media reporting of suicide, creating community awareness programs, school-based suicide prevention programs, training general practitioners and frontline staff, treatment-related issues and psychotherapy, follow-up of individuals with recent suicide attempts. So these are the different approaches that the WHO proposes as important for suicide prevention. This is a systematic review of suicide prevention strategies that was published in the Lancet. And if you look at this review, there is no single strategy that clearly stands above the others. And gatekeeper training is one of the strategies, and gatekeeper training has been carried across and studied in school staff, suicidal callers, mixed populations, youth helpers in schools, counseling staff for veterans in the US, general population, children and adolescents. So the level of evidence that is there, at least according to this systematic review, is of one that is at level Oxford criteria evidence level 1 or 2 that is available for gatekeeper training. Now, if you compare this with the prevention strategies surrounding pesticide, you could notice that at least this study states that the evidence for pesticide regulation, changes in pesticide content or pesticide storage, is much lower than gatekeeper training. Now, India warrants prevention strategies at all levels, but our resource limitations warrant a special approach with a broader scope, and that should focus on positive mental health and well-being. And importantly, there are many stakeholders in suicide prevention which need to collaborate and work together with intersectoral and transsectoral collaboration. Dr. Lakshmi Vijay Kumar, in her article in the Indian Journal of Psychiatry, has emphasized that gatekeeper training is one of the important means of preventing suicide amongst several other factors, which also includes reducing alcohol and substance use consumption. The National Suicide Prevention Strategy, which was released in 2022, also emphasizes the importance of gatekeeper training amongst the several strategies, and it looks at gatekeeper training as a long-term strategy to build capacity for psychosocial support for persons with mental disorders and substance use disorders. And the key stakeholder it emphasizes is the Ministry of Health and Family Welfare. And it is asking the government to train gatekeepers, which include health workers, the Ayush workers, school teachers, police personnel, to be trained in suicide prevention. Now, who are gatekeepers? There could be two different categories of gatekeepers. One is a gatekeeper who is at the community level. So that is people within the community who are likely to encounter at-risk individuals. For example, teachers. It could be in the context of West clergy, or it could be workers who are working with you. At a professional level, who are the people who can serve as gatekeepers? It could be health or other professionals who may encounter at-risk people through their worker role. Now, there are several models of gatekeeper training that have been provided across the globe, and some of them are quite popular. For example, the QPR model, which is acronymized very similar to the CPR that is there in medical terms. So QPR is basically responding to acute psychological crisis in the context of suicide. So that is question, persuade, and refer. So this looks at suicide attitudes, improving the gatekeeper's knowledge, improving their self-efficacy, critical thinking, and judgment in the context of acute crisis. Other programs such as the Applied Suicide Intervention Skills Training, or the ASSIST program, has been provided across several countries. Again, the focus is on identification of people who are at risk, connecting with them, understanding their problem, and assisting them. Most of the gatekeeper training programs have looked at either providing very brief 60 to 90 minutes to up to 2 full days of training. The theory that underlies gatekeeper training is that the focus is on improving the knowledge about suicide in these gatekeepers. When we say knowledge, it is both declarative knowledge and the perceived knowledge about suicide, depression, the resources that are available. Beliefs and attitudes about suicide prevention, that is to improve the knowledge and beliefs that suicide is preventable, and also whether it is important or appropriate to intervene. We often see there is reluctance to intervene, so to focus on this aspect is also one of the motives of conducting gatekeeper training. So basically, there may be a perception that it is not their responsibility or it is inappropriate to intervene for suicide. Stigma may be an important factor that needs to be addressed. Self-efficacy, the comfort and competence in asking somebody about distress and suicide also is something that needs to be focused in gatekeeper training. There are other models also that have looked at attitudes about the intervention, subjective norms that are there, the intention to perform a behavior and perceived behavioral control. All of these have been looked at as theories that probably underlie the gatekeeper training. What are the competencies that are required for gatekeepers? Now, for a community gatekeeper, it may be only enough to identify and refer. Whereas for a clinician or a psychologist, it may be important that one does a risk assessment, one formulates the case and provides treatment. For crisis line workers or for helpline workers, it could be important to provide identification and crisis intervention. So the competencies that are required for gatekeepers actually need to be tailor-made for the individual gatekeeper population that you are looking at. When people have conducted gatekeeper training, they have looked at how to evaluate the outcomes in terms of the training itself. So there are certain scales that have been devised, and of course, some of them have been very recent, like the gatekeeper behavior scale and the willingness to intervene against suicide. So these have been looked at as means of examining whether these training programs have been effective. So some of the scales, at least the gatekeeper behavior scale, looks at three broad domains. That is preparedness of people to provide the gatekeeper work and gatekeeper behavior, the likelihood of doing so, and their self-efficacy. What is the efficacy of gatekeeper training? The efficacy is known in terms of it improving knowledge, and to some extent, even up to 2 years when it was followed up, it looks like that there is the knowledge aspect of gatekeeper training that is maintained. Self-efficacy probably is the most enduring gatekeeper training outcome. Attitudes, there is weak short-term benefit. Behavioral intention, there is moderate evidence for endurance. And in terms of actually suicide prevention behavior, only for referral, that is referring to somebody in the context of a suicidal person, the level of evidence that is there is moderate. Some important considerations when you look at studies that have been done as far as gatekeeper training is concerned is that the frequency with which people will encounter suicidal persons, at least in the community, there is a low base rate. So it is difficult to look at these outcomes when you are looking at gatekeeper training. And there may be little opportunity for newly trained gatekeepers to use their knowledge effectively. So there may be a requirement of booster training. Some of these training programs have used role play or spaced learning as approaches to improving outcomes. Now, since with the availability of technology, using video applications or smartphones, web-based interactive practice opportunities are there. And in some of our training programs, we have even provided online mentoring and monitoring for master trainers. One important issue that we have encountered, at least when we have been asked by several government agencies and non-governmental agencies or universities, is the wish to be trained versus have to be trained. So there are certain people who are asked to be present, not so voluntarily, and then the outcomes are much different when compared to people who voluntarily come to register themselves up for gatekeeper training. Now, I will just provide you a brief overview of what we have been doing in terms of the gatekeeper training program at NIMHANS. Our aim has been to primarily improve skills for suicide risk identification, risk stratification, and facilitating immediate intervention when faced with somebody who is in distress. The objectives are crisis intervention and referral. We have been conducting 4 to 8 hour training program, which looks at improving knowledge, skills, and capacity building. We have used role plays as an important means of interaction and active participation of the gatekeepers with the use of case vignettes, and also we have used video-enabled learning besides didactic lectures. So, we have also looked at providing signposting and resource mobilization besides what I have stated as the content of the program. So we also focus a lot on communication skills in the program besides developing an understanding of suicide, sometimes clarifying myths or demystifying the issues surrounding suicide, delinking it in our context from mental illness. and facilitating self-help strategies. And in the process, sometimes we have had gatekeepers who themselves have come out and spoken about their suicidal attempts in the past. So in our training, we tell them that a gatekeeper is somebody who keeps a watchful eye and sounds the alarm, provides some immediate intervention, particularly referral for further evaluation and treatment. Some of the key facts that we focus in the training is that suicide is preventable. Of course, we encounter people who say that suicide in many contexts cannot be prevented because it is impulsive. Many people we also state that many people experience suicidal thoughts during their lifetime, but probably do not end their life by suicide. And some of these may be myths that might need to be clarified, that most people thinking about suicide are unsure about wanting to die. People may have myths that people who are determined, they will definitely end their lives. So we also educate about the easy to apply techniques, and these can probably help overcome these thoughts and urges. And one important factor that we emphasize is that suicide thoughts are often intense and severe, but they are very short lasting and they can be overcome. So we also discussed briefly about what is the difference between suicide and self-harm. Often we have encountered people talking about people who make suicidal attempts as having attention-seeking behavior. And in this context, we explain to them that even people with self-harm attempts can have the risk for death, and that cannot be ignored. And it is primarily a coping mechanism, and though it is more about staying alive than taking one's life. So we explain to them the difference between suicide and self-harm. We also talk about what are the warning signs of suicide. And predominantly, warning signs are a cry for help, and people show warning signs for days, weeks, and even months. And it is about looking for these warning signs and identifying them for those who are contemplating suicide. And warning signs can be easily identified if one knows what they are, and they can be missed as they don't appear to be directly related to suicide. So there are several verbal warning signs that we discuss with the participants, like talking about wanting to die, talking about feeling hopeless or having no reasons to live, talking about feeling trapped or in unbearable pain. We also talk about behavioral warning signs, such as looking for a way to kill oneself. Sometimes other verbal signs, such as talking about being a burden to others. Substance use and the sleep related problems, withdrawing or feeling isolated, showing excessive rage or talking about seeking revenge, being extremely anxious or agitated, so these could be displaying extreme mood swings. All of these are discussed as important warning signs that should not be ignored. Then we come to what are the risk factors that are associated with suicide. Risk factors probably are more distal factors that are important in the context of suicide, yet important to understand in stratifying the risk for suicide. So most important risk factors that we discuss are previous suicide attempts, the presence of mental disorders, particularly the co-occurrence of mental and substance use disorders, family history of suicide, impulsive traits, relational, social, work, or financial losses, easy access to lethal methods. Also, we educate them about the relationship between chronic physical illness and terminal illness, the barriers that are there to access mental health treatment, including unwillingness to seek help because of stigma, the influence of significant people, family members, peers who have died by suicide, sometimes celebrities, all of these through either direct personal contact or inappropriate media representations. Now, the various, how does the suicidal thoughts, what is the spectrum, what is the stages through which the suicidal thoughts move? It can move from having simple death wishes, thoughts about wishing to be dead or not living anymore, wishing to fall asleep and not wake up, to suicidal ideations where the content may be thought of a method to kill oneself, but without a specific plan, or maybe with the specific plan. People can also come with suicidal attempts. So then we talk about the intent and the lethality of the recent attempt that was made. We encourage the use of a mnemonic to remember the risk factors and the warning signs. We have used borrowed one from the American Association for Suicidality, that is ISPATH WARM, where I talks about ideation, substance use, purposelessness, anxiety, a sense of feeling trapped, hopelessness, withdrawal, anger or agitation, recklessness, mood change, or mood swings. Another important source of discomfort is about asking the suicide question when we are training people. So people find it extremely hard to ask the suicide question. So we teach them that it is okay to ask indirect questions like, do you feel like harming yourself? Do you feel like getting away from all of this? From what I understand, do you mean that you want to kill yourself? Or even sometimes direct questions such as, have you been thinking of killing yourself? Do you want to be dead and away from all these? But we emphasize that people may be more comfortable if we ask a normalizing question, such as, sometimes when people are feeling disturbed, they think of suicide. Is this something you are thinking? We tell them that probably universalizing distress or normalizing distress can allow people to open up more freely. We also provide certain tips for asking the suicide question, that is the necessity to be persistent. And if there is a doubt, to ask the question, a direct question even. And also to provide time and space to the person in distress, talk about their distress and thoughts, to give plenty of time. We also teach them how to ask about the frequency of thoughts and whether the thoughts are fleeting or fixed. An important factor that is ignored sometimes is the necessity to look at protective factors, that there are supportive families, friends, and colleagues that can be a major that can be reasons to live. Stable interpersonal relationships, easy access to psychological help, absence of mental disorders, and certain cultural and religious beliefs that discourage suicide. All of these can serve as protective factors. So we talk to the participants that risk factors and warning signs should be understood in the context of existing protective factors also that are there. So we teach them how to assess the degree and seriousness of a suicidal plan, how detailed is the plan, when, where, how, and what is the method that the person is contemplating, and what are the protective factors that have stopped the person from acting on these thoughts so far. As far as the interaction with the person in distress, we emphasize that the most important aspect of this is respect and understanding, being non-judgmental, using reflective questioning. This is emphasized in the process of role play, active listening, and the use of normalizing questions. So we tell them that it is important to be aware of feelings. Many people at some time in their lives actually think about suicide. Most decide to live because they eventually come to realize that crisis is temporary and death is permanent. So people who, on the other hand, people who are having a crisis sometimes perceive their dilemma as inescapable and feel there is a loss of control. And they may experience thoughts such as can't stop the pain, can't think clearly, can't make decisions, can't sleep, can't get out of the depression, can't get someone's attention, can't seem to get control, can't see a future without pain, and can't make the sadness go away. So we tell them that you should focus on the person, encourage free communication, allow them to express their concerns, and be understanding, listen attentively. We ask them to give sufficient time to the person, approach with respect, show care when inquiring, understand the problem, and most importantly, the person in his or her context, provide privacy, and be empathetic and non-judgmental to understand their viewpoint. So some practical tips are provided for intervention, that is being direct, talking openly and matter-of-factly about suicide without being judgmental, not to lecture on the value of life. We have sometimes seen participants emphasizing the need to lecture on the value of life, not to dare him or her to do it, show interest and support, not to become shocked or because that will distance the person in distress from the gatekeeper, not to swear to secrecy and rather seek support with the consent of the person in distress, offer hope that alternatives are available instead of simply offering a glib reassurance. So also we encourage them to take help from other resources such as the helplines also. So basically we teach them the pause and lift strategy, that is asking the person in distress to postpone and promise not to act on suicidal thoughts till help is taken, to provide physical proximity to near and dear ones, Those with low and moderate risk to look at hobbies that provide pleasure, look at physical or mental activity to distract themselves from the distress, engage in any task or work with others. We ask them to seek help from helplines, follow up with the care providers and support, look for someone to share their concerns, and trusting oneself that this will be overcome. We also teach people to roughly stratify the risk into high, moderate, and low, and how should they respond if somebody's risk is low. For example, if somebody's risk is low, the response should be to provide outpatient referral with some of the strategies that we have taught them. And to somebody where the risk is high, we strongly recommend that there should be vigilant supervision, and admission or removal of access to methods should be given primacy. For a moderate risk, we encourage them that to err on the side of caution, develop a crisis plan, and look at possible referral to a mental health professional. To date, we started the program in February 2013. We have trained more than 10,000 people so far in the community, from PHC doctors, psychologists, nurses, social workers, ASHA workers. We have a large community of lay counselors and community members and community leaders who seek the training. In the recent past, police personnel from specific states in the context of suicides in their workforce, and also the paramilitary forces in the context of suicide in their workforce have approached us to provide gatekeeper training. Several universities and teaching institutes have asked us to provide gatekeeper training. Just to briefly look at, though we have done this training program for the last 10 years, we have unfortunately not published this. But if you look at the domains of the gatekeeper behavior scale, at least for the 233 participants where this is summarized in this table, you look at the preparedness, the likelihood to discuss the psychological distress and support, mental health services and support, and self-efficacy, their own perceived self-efficacy in motivating someone to seek help seems to have improved with the training. To conclude, gatekeeper training enables non-specialists to identify and respond to suicidal behavior. It holds promise as a part of a multifaceted strategy to combat suicide. The other strategies should not be ignored, and it is paramount that this is one of the strategies amongst the several that are important to combat suicide. And GKT programs, at least from the limited evidence that is there, seem to have some positive effect. Knowledge, attitudes, appraisals, self-efficacy, and skills should be monitored in a gatekeeper training program. It is also important to understand that there is a need to conduct high-quality RCTs with pre-specified outcomes for improving our understanding of the effectiveness of a standardized GKT program. Thank you very much again to the organizers for providing me the opportunity to present. Back to you, Dr. Ashok.
Sir, I would request you to unmute. Ashok, sir.
Am I audible?
Hello? You're audible.
Yes.
Hello? Am I audible?
Yes.
Yes, sir. Now you're audible, sir.
Yeah. Thank you, Dr. Krishna Prasad, for finishing within time, keeping in time. And it was an exhaustive presentation, which has come out of your experience, of 10-year experience, and preparing about 10,000 gatekeepers in various stratas of society. This is a rich experience, and you could impart this, your experience, share your experience with the audience. And I would just like to ask some doubts, whether is there a follow-up program for this gatekeepers, and what is are you getting feedbacks from them, and also whether they themselves have some problem with the caregiver burden and developing dependency from.
Yes. Yeah, some of the challenges for us have been to keep a systematic follow-up of all the gatekeepers that we have trained. but at least there is some understanding from some of the lay counselors who have actively come back to us, relating their experiences in the community in the context of people that they have helped. So we have had people who have spoken about positive experiences of preventing suicide to people who have lost people to suicide and themselves come to us in distress. And then there are people who themselves have had psychological distress subsequently and have sought help. So from the one end to helping people, to the other end to losing people, and at the same time seeking help for themselves have been some outcomes that we have seen. Systematically, I think there is a need for us to measure outcomes, and I think since the last 5 years, we have ingrained the gatekeeper behavior scale as a part of our training. And of course, we are looking at systematically evaluating this in terms of its long-term effects and outcomes. There are select occasions where we have provided booster training to people and some advanced training to people also, where further nuances about how to ask questions, how to respond to specific difficulties using their own live case examples that they have brought into the discussion have also been conducted.
Now the topic is open for discussion. We are inviting questions and comments from the audience.
If anyone is interested to speak, they can actually raise hands so that we can. Dr. Varun, we will unmute you. Yes.
Good morning, sir. This is Dr. Varun, sir. Am I audible?
You are audible.
Hello. Am I audible?
You are audible, sir. You are audible. You can go on.
Sir, I would like to ask regarding the context of referral, and depending on the community gatekeeper which we are training, would the referral pathway differ within the organizational structure? And secondly, also regarding the aspect of certification, is it necessary for the trainers to have a kind of certification? And what about those who are taking the training? Do we certify them as gatekeepers? Because to my understanding, whatever certification that are there, they're quite costly. And if we have to certify as a part of organization as well, the participants do have to pay in some money. Your thoughts about it, sir? Thank you.
So please unmute, sir. Dr. Krishna Prasad.
An important concern that you have expressed, we have been providing them certificates as a means of encouragement for their participation. But of course, there is no specific accreditation that is provided. It is a nominal fees that we have been collecting to cover the expenses of conducting the program. But of course, in the West, there are several institutes. For example, the QPR Institute itself offers courses which are quite costly, and it is with some degree of certification and accreditation that it provides. So similarly, in several other countries, certification is provided. So I think in our context, we have used it as a means of encouragement. But of course, it should not be formally considered as an endorsement of somebody's skill set providing formal mental health services.
Currently, we are joined by.
Does that answer your question, sir? And I seem to have forgotten the first bit in the process of unmuting myself.
Dr. Varun, your first part of your question. Dr. Varun.
I'm sorry. I was waiting for the host to unmute myself. Sorry. Unmute me rather. Yes. So actually the first part was the question was regarding the referral in the institutional mechanism. So like when we were speaking about, say, to teachers versus when we are speaking to the police officers regarding the referrals. So there is a channel of escalation within the institutional mechanisms as well as referral outside the institution, like for the mental health professionals. So how does that be tailored? Because it might be difficult for us to know about the exact organizational structure at all the places. So how do we take care of this aspect of trainings? Thank you.
When we have been asked to look at, say, for example, the couple of police forces and the paramilitary forces that we have trained, we have it had become necessary for us to understand the organogram and also the nature of services that are available in those forces for us to understand who we have to train as gatekeepers, and also what should be the referral pathway. For example, some of the forces, one of the forces that we recently examined had only one psychiatrist in the force, and it had started a psychological course for at least 200 force members. Now, each of them with different levels of educational background and training. So some of them were probably forced to attend these courses because the force had experienced multiple suicidal and fratricidal deaths. So the motivation there to attend would be different. They also, some of the paramilitary forces also have a system called as a buddy system. But again, there are challenges in terms of the buddy, because sometimes a North Indian is paired with a South Indian, and they basically don't understand the other person either culturally, or the language is not understood. So again, all of these factors are important to understand when you are tailoring a gatekeeper training program for a certain organization. So for the community members, we provide them a list of mental health organizations that are available locally, and encourage them to find out more mental health professionals around them. Of course, all of this is not formalized, and a directory that is all exhaustive is not available to provide referrals.
Over to Dr. Ashok, the chair for the session.
Thank Dr. Krishna Prasad, the organizers, and the audience for the meaningful session. Thank you.
Sir, I think there are some online questions. I am not sure if...
No, since we are running out of time and we are actually going to the next session, I will request, we'll be taking this... yeah. We are joined by Dr. Dipayan Sarkar, who is the convener for the Indian Psychiatric Society Suicide Prevention Section. I request Dr. Dipayan to actually say a few words on this occasion. Thank you, sir. If Dr. Dipayan could actually unmute. Yeah.
Hello.
Go on, sir. Some connectivity issues, I guess, with Dr. Dipayan. So.
Yes, sir. Hello. Good morning, everyone. Am I audible, sir?
You are audible, sir. You can go on. Sir, is it okay, sir? Dr. Dipayan, since we are unable to actually hear you online, can we go to the next session, I guess? Can we go to the next session, Dr. Dipayan? I think it is inaudible. So, For the next session, the topic for the next session, we are starting our 11 a.m. session. Physician suicide in India, the time to act. Our speaker for the day is Professor Dr. Shubhangi Raghunath Parkar. Madam is currently the Dean and Professor of Vedanta Institute of Medical Sciences, Dahanu Palkar. She is the ex-Dean and ex-Dean of Academics at ZGS Medical College. She has been awarded the BC Marfati Awards for IPS for the best research thrice and 5 times winner of the A.B. Shah Awards. And for the chair, we have Dr. Sushil Kakkan, who is the professor and head of department, KMCT Medical College, KMCT Institute of Behavioral Sciences. And over to the chair, sir, Dr. Sushil Kakkan. Sushil, if say if we could unmute Dr. Sushil. Yes, sir. Go on, sir. You're audible.
Hello, am I audible? Hello?
Yes, sir, you are audible. You are audible. Please go on, sir.
Good morning. At the outset, let me thank the organizers for inviting me for chairing this session. We have a very important session coming up since it deals with physician suicide. In fact, if you go through the literature, you will find that risk of suicide in doctors is 2.5 times more than the general population. It affects both old as well as young. And since it affects young as well, it is all the more alarming because it affects our young residents and interns. So it's important that we examine what are the contributing factors, warning signs, all this. In fact, suicide is only a preventable tragedy. Only if we have a very clear picture about all this, we will be able to do something about it. I'm sure we have a very eminent speaker for this in Professor Shubhangi Parkar. With these few words, I invite Madam to deliver her talk.
Thank you. Thank you, Kerala friends. I hope all of you are fine with the kind of calamity which has come in. And I'm very happy to join on the very important topic in this particular session. May I share my slides right now? Yeah.
Yes, madam. Please share the slides. Yeah. You can actually start presenting. Right.
Okay.
Start with the first slide and you can actually present the slides, ma'am. Thank you.
Okay. My topic is very important, that is physician suicide in India, time to act. So we will
Madam, yeah.
Yes. Okay.
Yeah.
High doctor suicide rates have been reported since ages 1858, yet more than 150 years. The root causes of this suicide remain unaddressed, though by and large we know many of the reasons. Physician suicide is a public health crisis. If last 2 years we kept hearing from most of the states about the miserable suicide by doctors. So, extents of the problem, India is home to approximately 1 million doctors, which is the largest globally. The risk of among the doctors is 2.5 times higher than the general population. Some of the studies report even higher than that, that is 5 to 7 times higher. In the United States, it is said that yearly nearly 400 physicians die by suicides. Suicide ideations among the medical students ranges from 1.8% to 53.6%. All of us, those who are attached to medical institutes are always worried about this. Among the healthcare professionals, the rates are comparable for males and females. 60% suicides were by females in the Indian study. Even undergraduate medicals and dental aspirants are at risk. I have seen, because I am near the biggest oncology center of the country. The suicide rates are higher even in oncologists. In 2018-2019, out of the student suicide, 55% occurred in the month in which the results were declared. And this reflects the tremendous pressure of academic performance on our budding doctors, that is our students. Regional studies in India, as studies are not many, but suicide rates are higher in the South Indian states compared to the northern states. This was also reflected in the study by Kishore et al. I mean, I really like to go through his study, quite extensive, in which out of the 30 suicide, 57% were from South India. Specialties where a higher rate of suicide is seen are anesthesiology, general medicine and psychiatry. But there are some more. There are orthopedicians also involved in this. Intensive care specialists also involved in this. 57% resorted to hanging. 26% used lethal injections. 17% jumped from a building, and there is a one jumping from the train. During the COVID-19 pandemic, which was a very, very stressful period and demoralizing period for medicos, the most commonly used methods of suicide, were hanging and jumping from height. And that is by generally healthcare professionals. I have seen that even in Mumbai. Okay, Australian studies where poisoning has been the most common method. In USA, suicide by firearm was the most common method adopted. As an outpatient, doctors have 80% lower risk of suicide compared to occupation as farmers, but higher risk compared to teachers. Suicide ideation among medical students is high, as we have seen. Okay, how common are mental health problems among physicians if we are thinking about suicide? Because we know in general by scientific research, mental health illnesses or symptoms are associated with suicide. So in physician, we see the full spectrum of mental disorder, right from the depression, common mental disorder, to major mental disorders like bipolar and schizophrenia. A range of issues that affect their well-being, such as, this is a very additional issue, burnout, are associated with substantial suffering, physicians leaving the profession or reducing their hours, and moral distress. The most common mental disorder reported among physicians are depression and anxiety. Increased risk of suicide, with 2019 systematic review and meta-analysis calculating an overall standardized mortality rate of 1.44 of suicide among physicians. Female physician appears to be particular risk, with 2020 meta-analysis reporting female physician had a suicide rate that was significantly higher than women in general population. Access to legal means and the knowledge, which is very important. It's not just legal means, but the knowledge to effectively use such means. That means, the counting of the tablets, which are lethal, is one of the most important reasons for the increased risk of the suicide in physician. They are generally accurate in terms of, how they can utilize the poisons or the prescription medicines. Okay. What are the major barriers to seeking help in terms of the suicide? Physicians with mental health problems might be more reluctant than non-physicians to seek help for a variety of reasons, include fears regarding confidentiality, the potential consequences for their career, medical registration, that is the issue generally in the international scenario, a belief that they can manage any symptom by themselves. This is risky. Most of the people I have seen, right from the interns to resident doctors to professional colleagues, that sometimes they come to understand that there is a problem, there is a psychiatric problem, there is a depression, but when you prescribe, they probably believe that I would manage now that I know it is depression or it is anxiety disorder or whatever it is. So they have this kind of belief, which is actually the face of denial. A high prevalence of self stigma as well as fear of discrimination in the medical community, which is a very important factor we need to consider when we think about prevention of suicide, in medical colleagues, that is physician. A link between area of specialty and risk of suicide. Anesthetists, psychiatrists, general practitioners, and general surgeons might have higher rates of suicide than other specialists due to these specialists having higher rates of mental ill health. Greater access to high lethality means more barriers to seeking help, and this higher access to high lethality means is a very important in terms of when we talk about anesthetist suicide. Okay, and more barriers to seeking help. Being a doctor, there is perceived stigma is much high in medical profession, and a combination of these and other factors. A different pattern. Research suggests that between 5% to 20% of doctors across a range of high income country consume alcohol problematically. It's a very, very important finding which we see in our country, in our institutes, in our colleagues. Compared with the general population, physicians might consume alcohol at a similar rate or perhaps at a higher rate. The use of prescription drug, benzodiazepines, minor opiates, which was higher than general population estimates and often self-prescribed. Anesthesiology as a specialty pursued as a being at a high risk, and we know obvious reasons. In the past 10 years, studies have reported a different pattern with the highest prevalence of hazardous alcohol consumption among dermatologists and orthopedic surgeons. So these are some new findings popping up. A least studied subject, generally, the information that is available from the newspaper reports, okay, suicide in India perceived as a stigma to individual and family, and that's the reason why, people who get sensitive about the diagnosis, okay, generally they don't want to come forward when they feel suicidal ideation, when they have the plan of the suicide, and that's the reason why we really need to be alert about the clients, especially our medical clients, including our students, to find out what's happening. Gender aspect is important. Female doctors, 60% had a higher suicide compared to male doctors, may be related to gender issue in the socio-cultural context which we normally see in the general population. In India, more female students than male had suicidal ideation. Suicide rate of women doctors in the United States was twice that of other working women. Need to address the risk factor at earliest among female doctors, which is very important. And there are definitely the sensitive areas like broken love affairs, performance anxiety, family pressure, interpersonal aspects. So we really need to be aware of these issues. Multiple status. Okay, 67% of Indian doctors who committed suicide were young and below the age of 30 years. Study correlates with global findings. Depression and suicidal ideation among medical students because of multiple stressors, which are professional as a student and personal life, because that's the age, where there is no adult wisdom. It's a more near adolescent, and the stress level is pretty high in last decade compared to the previous decades. Post-graduation may also have additional stressors for individuals, such as financial burden, which I see in my institution and I've seen before in KM hospital too. More professional responsibility, and many get married to start their families. So the risk factor associated with all these issues gets multiplied in post-graduation phase. Reason among medical students, depression appear as the common reason. not interested in MBBS. I see many of them now. Ragging and bullying, exam anxiety, exam failures, marital discord, family problems at home, and that's quite important for us to take into account. Broken love affair. This is the age to have love affair. Hence, there are many broken love affairs and academic pressure together. Harassment as a reason for suicide. I think we have seen in the papers. The case definitely was from Mumbai. There was a caste problem. Then we have seen the case. I'm going to come to that. The recent case reports which really shaken up the medical community, and then unidentified reasons. In unidentified reason, generally the issues are related to the sex are there, related to gender discrimination are there, but we really need to understand, okay? Patient deaths hurt doctors a lot, even when there is no medical error. Doctors may never forgive themselves for losing a patient. Okay, suicide is the ultimate self-punishment. In my career, I have seen at least 3 doctors. One of them committed suicide. 2 we could save is because of something wrong happened to the patient while in the process of the treatment, and the guilt level was pretty high. So we really need to look at this particular factor. Okay, malpractice suits are very important globally. Okay, they kill doctors. Doctors who do illegal things kill themselves. Doctors are publicly shamed in court, on TV, and in newspapers. I think we have the example of Dr. Sharma in Rajasthan was delivering a baby in private hospital when her patient passed away in labor. And I think the media and even the police behavior was extremely pathetic. Okay, and when punished or fired for inefficiency or low productivity, doctors may choose suicide. Okay, so Rajasthan gynecology suicide shades light on harassment of doctors across the India, and we see that in the media, which is a very important factor, and that's the reason why there is appeal that doctors community and the organizations should come together strongly. Okay, inhuman working conditions. Many doctors cites inhuman working condition in their suicide notes. Long hours of working, and this is very important, because I have seen in Mumbai our resident doctors or junior residents work for a long time because of the overload of the people, harassment by seniors, or unlimited demands by seniors. There are issues like there was a case report which I have seen from Delhi, where the politicians handled these cases very roughly, very inhumanly, and humiliating the doctors. Caste discrimination is another issue. In Mumbai, we do have huge pressure from what we call as a corporators, because they get their patients, and once they get in, they want everything should be done at a standard level, and that becomes an issue for our doctors. Okay, the risk factor for physicians: depression is a general risk factor. Emotional exhaustion, which we really need to identify ourselves, and the friends should identify this. Low self valuation, untreated mental illness very often, and especially depression if it remains untreated, schizophrenia if it remains untreated, it is a really a risky factor. Marital status and impaired intense workload, general health conditions. I have seen quite a few examples, who had suicidal ideations plan and attempted suicide because of the illnesses like tuberculosis and MDR tuberculosis and access to lethal methods. So these are absolute risk factors. I would be absolutely about lack wisdom and ours, distance from family because they are away, and many of them are first time exposed to this kind of atmosphere away from the family. Sleep deprivation during the working time, which is an important factor now identified with suicide, financial hardships, examination stress, inhuman ragging sometimes, caste-based discrimination and regionalism, where students and the urban students groups, and they are there is really a sort of shaming with some of our students. I mean, I used to be more soft with the rural students who have come out of Mumbai, out of Maharashtra, because they go through this, and since they don't know the manners, of throwing their image most finely, as in comparison to urban, so they do suffer. Okay, the place of the work, which is a very important consideration. Or rooftops, they shoot or stab themselves in hot chapels, or physicians often choose to die where they have been wounded. I have seen quite a few students dying in their hostel rooms. Okay, so this is a very important aspect which we really need to understand. Factor, both this is a risk factor and protective factors, and finding out ultimately what is the risk level. Okay, the access to healthcare, because they are in the setup, experience in the conflict resolution, family and community support perhaps is a very important, especially those doctors who practice in their cities. I'm not talking about the student. Religious or other, I think resilience is a way today when we think about prevention of suicide. So spiritual practices, physician self-awareness, gratification in work. The people may have to work hard, but if they're doing something which give them pure joy, that probably is a very important feeling to be satisfied with oneself. Accepting personal limitation, which is very important. I mean, as a teacher, I always like to talk about this to my students, learning how to better balance and prioritize, the aspects of the life. Solutions, many potential solutions to the problem. Intervention on the individual level to large-scale initiative designed to effect systematic changes. Physician mental health should be priority. We must know that, and health also should be priority. This is very important. I think many of us are teachers, asking maybe very frequently to our students, what are they eating? I do that. What are they eating? Have they taken enough fruits? That kind of health care, and with the mental health, sometime asking them that whether they had hectic emergency, had they got good sleep. These are very, very important questions which we should ask even before we start our round. Okay, rounds. Should be taught to recognize signs of depression as well as risk factors, and ask them to get ready if they find it. Information in medical school and residency training curricula is very, very important, and through continuing medical education, which is a very important aspect. Implementing lifestyle habits is very important. And that's the reason why in KM and now in Vedanta, I do take the or organize the lectures on the lifestyles, on the eating habits, on the practices like yoga. So now it is yoga should be there in each medical school, and so that's what we have done. We had started the yoga OPD in KM, the first yoga OPD of the country, and people used to go. I mean, all healthcare professionals used to go routinely, to do yoga there. So implementing lifestyle habits to mitigate symptoms of burnout, very important. I mean, it may not be depression, it may not be common mental disorder, but burnout is equally bad. In fact, it is more bad. Okay, regular physical exercises, make it a point that they do it. So, developing sport complexes, or, I think we have done that. We, right from the Buddhiball, chess, to badminton courts, everything should be probably organized and teachers should be part to it. Meditation and yoga, maintaining a healthy social life. Meditation and more broadly mindfulness has gained popularity in recent years. Mindfulness, which derives from the Zen Buddhist tradition, I practice Vipassana. So I do status also contains sometimes these particular messages which many of my students see, okay, and contribute more generally to resilience. I think this is very important for us as a mature professionals, and also giving this training to our students. Okay, loneliness is a very important issue. And when I talk about loneliness, remember that the people who have the symptoms of mental illnesses or the diagnosis of the psychiatric diagnosis, the loneliness is much more because it comes as a part of that illness and it comes as a part of the stigma. So it is prevalent among physicians and trainees, implicated in burnout, plan social events with the aim of improving collegial engagement. I started film clubs in KM, GS Medical College, and now in Vedanta. So we see together some of the activities we do. You see, the college where I am there is almost in the rural, but we have the students who play guitar, who are good singer. So we organize those kind of things just to come together, okay? Create space for processing stress and patient care and wellness clinic. That's a very good idea, basically. Then talking psychiatric clinics, though we are psychiatrists and we should be taking the leadership in this also. Change is important today. Changing the stoic culture of medicine will require top-down efforts. The first step is acknowledging and accessing the problems, okay, especially mental health problems and the problems in infrastructure, okay, in the working hours. Implement changes to strengthen the physician community, to raise awareness and broadcast the benefits of seeking help for depression and suicidality. I think it should become a practice. Students should land up with us and telling that feeling little blue or feeling uncomfortable, feeling restlessness, that dialogue needs to be, strengthened in the institute and with our colleagues to encourage help seeking and non-discriminatory policies requiring disclosure. Like I don't think we have to keep writing about when we give certificates. I feel so many of our students feel terribly restless when we write that certificate, which probably is an official deal. So what kind of choices we have, when we write certificate as a depression or any kind of thing, they feel disturbed about it, okay? And call for change, interventional investigations and outcome research is required to identify and validate methods to ease the burden of physician burnout, depression, and suicide, and urgent need for development and dissemination of these best practices and necessary cultural shift, because we are not gods. I think we are human beings as a physician, and we are not moral ideals. We are also human beings. So this is where we really need a cultural shift. Mitigating symptoms of burnout is very important. So communication skill, adjusting workflow, addressing clinician concerns, monthly provider meetings, flexible scheduling, support for striking a sustainable work-life balance, stress management workshop we can take at a different level, self-care behaviors. I would tell you that the one important thing happened in municipal corporation hospital, which we are major. There were two suicides with tuberculosis, and then our IS officers who are our bosses, they asked what can be done, because I found in KM, they and other hospitals, the workload is high, so they don't even eat their breakfast. So what we have done, a very simple thing, we were doing all other things, but we started free breakfast in the medical college. which is still running, and made it a point that it reaches to all of them, because we were really worried of, having tuberculosis, MDR tuberculosis in students, and then they resorting to suicidal behavior. So that is a very simple step which is still working today, and that gives, a feeling of confidence by our colleagues and our doctors in us as an administration. So some of these issues are extremely important, and small changes will bring in a lot of healthy atmosphere. Okay, suicide prevention lifeline, that is also we started in Hitagus in 2014, the first mental health helpline, we started, which for the people, because at that time not just medical but student suicides were more in the city of the Mumbai, and that really has given a good idea. Education on suicide prevention, I think in undergraduate we must do this. Okay, peer support programs, contact with family and friends matters a lot. Okay, physician wellness is a priority. Okay, as members of a moral community that was we think, physicians have obligations not only to their patient but also to themselves, each other, and society. Okay, I mean, we cannot neglect ourselves. If we neglect, we definitely are not capable of looking after the society. Okay, training programs need trainees who are thinking about how we can improve the system we train and working, especially make them human based. So we have also started in GS Medical College a whole department of medical humanities and the programs which are done, to improve upon the human strength, empowered human values, and even make good doctor. And these are run by our students. Okay, they are the one who plans this program. They are the one who suggests. So we call Prakash Amte. We call so many such people who could give a lot of wisdom and lot of maturity to the students. Okay, the most important patient we have to take care of is one in the mirror, and this is a very important issue. So we really need to be human to ourselves first, and this is a very important, and those kind of programs probably will give us a huge empowerment to improve the life of our students, to improve the quality of life of our colleagues, and perhaps contribute in the resilience and positive mental health component to most of our colleagues. Thank you very much.
Over to the chair, Dr. Sushil. Please unmute, sir.
Hello, am I audible?
Yes, sir, you are audible.
Thank you, madam, for your informative talk. It's quite alarming to find that 67% of the doctor suicide belong to less than 30. Very alarming indeed. In fact, as you mentioned, one of the major problem always is stigma issue. Even in doctors, they tend to not to take help following suicide, thinking all those things. So confidentiality issues continue to be a major problem. Now, one of the hallmark of this program is we are combining with IMA. In fact, non-psychiatric professionals have a big role to play in managing suicide cases, because many of these cases who have this kind of issues go through them as well. Not only that, many following suicide attempt reach general doctor, non-psychiatric professionals, and it's needless to mention that prior attempt is a very important predictor of future attempt. And also, many of these non-psychiatric professionals have very close contact with various policy makers also. So their help is very important in managing these issues. Thank you once again, madam, for a very illuminating presentation. Now the paper is open for discussion. Questions are invited. Hello.
Any questions? You can actually raise your hands and we'll be unmuting you from here. You can please raise your hands.
Good morning, ma'am. This is Varunia, ma'am.
Yes, Varun.
Ma'am, yes, ma'am. Actually, there were a couple of queries that I had. So, ma'am, recently we concluded a conference of a state branch in which the topic was of student wellness, and Professor Pratap Sharan was one of the speakers there, and he spoke about like how AIMS has a wellness center there. And I know from my own experience at KEM in the first year, we had a program called Shidori. Now,
Yes,
I'm not quite sure if it is still
it is
there.
there.
So,
It is
what I
there.
wanted to know. Okay, that's great, man. So we've realized like among our students, like say even among the PG trainees, one is that strangely all of us are very illness oriented. So getting the talk on wellness becomes is not quite well received as we would want to actually. So to my understanding, I always feel it was much easier said and done, and I always saw a lot of barriers right from the top to the below in implementing a wellness program within the confines of an institute, be it a mental health institute or even a general hospital. Ma'am, what are your thoughts about it, and
Yes.
like what are the ways of handling these barriers, ma'am? Thank you.
I'm glad, Varun, you are speaking about Shidori. See, the Shidori program was developed for all the years, all the phases. Okay, and each year we have tackled the issue which are very close to the students. Basically, the first year it was a communication skills at their level. It wasn't even patient. Okay, then we have got communication skill in the second level in relation to doctor-patient relationship, then the healing technology, and the other issues like reading skills. Okay, these are very, very, very important aspect about studying. So in each year there used to be the three modules which we used to give: Shidori 1, Shidori 2, and Shidori 3. And in Shidori 1, that is, I think that's the first institute we started mentoring programs. Okay, and in that mentoring programs, we not just involve the first year teachers, but all the teachers, and then we have given freedom. See, this is a very important because, and what we have done to prevent suicide, there is a great time duration of 15 to 16 years. Recently it happens, the 16 years we have not seen a single suicide in students, simply because we have empowered our wardens, and we have selected the facilitator from the student batches who were bright students and who were competent personality. And then that particular network, has worked so efficiently. I remember the students were brought at night time also, that because the student is feeling restless, or that particular student facilitators identified that there is something wrong, and that's the way we could intervene, we could start prevention. So I think it should be, as a part of the policy management of the institute, and everybody should be a part of it. I remember one fine day, a security of the KM caught a student who probably was getting engaged into jumping from the window, and this security became a very, very alert. So I think this alertness, this networking of the awareness should be at each level, which is a very, very important. And we have to take maybe we do take some films, some good film, but we try to get student together, and we really have to spread that this is the concern which we have, and peer also should have this concern about their friends, in the mind. So unless and until we do it, otherwise people are reluctant. I mean, who would like to go in the medical college and talk about suicide and discuss about it? So we should have the efforts from our side, and it should be, especially the medical humanity department has done later wonders. I mean, most of the students are engaged in lot of activities. There are competitions, there are slogan competitions, there are elocution competition. I think it probably gets the whole atmosphere, in terms of the warmth and in terms of the commitment, which matters a lot. Yes, Varun?
The chair.
Any more questions?
You can raise your hands. someone has messaged whether madam.
I think we have had a very wonderful session. Thank you, madam, for sharing some of your practical experiences as well. I must congratulate the organizers for including this particular topic, as this is continuing to be a problem in our fraternity. I think we are running short of time, so over to organizers. We'll wind up the session.
Thank you, sir. Thanks to the speaker too, Madam Shubhangi Parker. And now I think we are again joined by Dr. Dibayan Sarkar. I would ask her to actually, you can unmute. He is the convener of the Suicide Prevention Cell of the Indian Psychiatric Society. Over to you, sir. Please say a few words on this occasion. Thank you.
Thank you, sir. Thank you very much, sir. Actually, nice flow, so nothing much from my side. I just want to thank the and Kerala State Branch from on my behalf and on behalf. They are very well. They're speaking very well. I must congratulate them, and we do. Thank you again very much. So over to the organizers. Thank you, sir.
So over to the next session. So I think, can we please unmute the speakers, Dr. Varsha and Professor Sheba Nainan, who's going to be the chair. So this. So the next topic is going to be suicide in women, the reasons and the way forward. The speaker for the day, the next speaker is going to be Dr. Varsha Vidyadharan, who is the Associate Professor in Psychiatry at Government Medical College, Calicut. She has been working at Calicut Medical College for years. She has significantly contributed for suicide prevention, a handbook for community gatekeepers, published first in 2009, and received the early career psychiatry fellowship in 2015 at WPA Regional Congress at Cochin, Kerala. She has a lot of articles published in the various state, national and international journals. And for our chair, we have Dr. Sheba Nayanan. She is the assistant professor at Telemanus, Imhans, Kozhikode, and the senior consultant in geriatric psychiatry. Over to the chair. Unmute it. Unmute it, madam. Yes, Nayanan. Unmute it. Illa. Dr. Shiva, I believe. Dr. Shiva. We have tried unmuting you. Dr. Shiva. Over to Dr. Shiva, the chair.
Good morning, everyone. I would like to first thank you, IPS Specialty Section, Calicut Psychiatry Guild, and Kozhikode IMA chapter for organizing this very important CME on suicide, and also for giving me this opportunity to be here today. Suicide, as we know, is a global public health problem. Asia accounts for 60% of the world's suicide. So at least 60 million people are affected by suicide or attempt suicide in Asia every year. So how Dr. Krishna Prasad rightly pointed out that 1 in 3 women have some form of suicidal behavior, as reported in the 2016 data. Female suicide behavior in terms of morbidity and mortality is more and could be associated with likely reasons like gender vulnerability, psychopathology, and psychosocial stresses. Suicide prevention propaganda should be raised further, there should be more strategies to address this. Without further ado, I would now like to invite Dr. Varsha Vidyadharan to stage and take on the presentation.
Thank you, madam. Am I audible?
You are audible, madam. You are audible. You can go on.
Okay. Thank you, Sohaib. At the outset, let me express my sincere gratitude to Indian Psychiatric Society Suicide Prevention Team, Indian Psychiatric Society Kerala State Branch, IMA Kozhikode, and Calicut Psychiatric Guild for this opportunity. So we have been hearing the previous topics, the silent epidemic which is going on, and the importance of this very relevant CME during the current times. Now, what is special regarding women when it comes to suicide? Let us see in next couple of minutes. So we know that this is a global public health problem, of course, and here we have the real statistics which have been already discussed. 1 million individuals, 10 to 20 million attempt suicides, and profoundly affected family as well. So our own Asia accounts for 60% of the world's suicides, and on the whole 60 million people are affected either by suicide or the attempted suicides in Asia every year. Now, among the global suicide rates, when we take up the split rates, we can see, as we know, this is described in 1 lakh population, this comes to around 11. Now, the global burden of disease has been increasing with respect to suicide as well. Now, on the whole, when we take the global view, we can see that the rates are higher among males, but one of the common cited exception is China when we review the literature. But again, there are fluctuating data regarding the statistics over there. Now, anyway, one thing is sure, as we have earlier pointed out, this is number one cause of mortality in young girls between 15 to 19 globally. And the most consistent findings in suicide research is that women make more suicide attempts than men, although men are more likely to die in their attempts than women. Now, when men die by attempt by suicide 2 to 4 times the rate of women, the attempts made by women is definitely more. So, if we take both the mortality and the morbidity together, the weight of the disease burden is definitely more in the female. Now, here we have the statistics across the globe, and this is based on the Human Developmental Index as well. And we have the data from the South and Central America, Asia, Central Asia, Europe, and the other parts as well. And this is split according to the male and female stats as well. Now, coming on to the Indian data, here again, suicide is the leading cause of death in 15 to 29 age group, and this exceeds the road traffic accidents and maternal mortality as well. Now, last decade, we noticed a gradual declining trend in suicidal rates. Subsequently, there was an increasing surge in suicidal deaths as per the reviewed literature. Now, the suicidal rate of women in India is again lower than that of men. The male-female ratio, which has been gradually increasing, again, this gradual increase of ratio denotes that less women are committing suicide in India. Now, when we come to the socio-demographic factors behind this, now we can see that suicide rates tends to increase with age. Girls outnumber boys below 14 years, and young women below 30 years are at high risk of committing suicide. Suicide occurred at younger ages in women than in men. Now, the male death rates at 15 and older were generally consistent. The female death rates peaked at around 25. And at the age 15 to 29, suicide was the second leading cause of death in both genders. And this is nearly as common as transport accidents and maternal deaths as well. Now, is marriage protective or not? This has been again a controversial area of discussion. Now, what does suicidology says? They say that being single, that is, are they never married, separated, or divorced, it act as a risk factor for suicide. But in general, marriage appears to be less protective against suicide for women than for men. The life and marital circumstances of women may make them vulnerable for suicidal behavior. Now, stresses may include arranged or early marriage, young motherhood, low social status, domestic violence, economic dependence. Now, the various social, cultural, religious constraints may discourage women from employment, careers, financial, and social independence, and encourage them to remain within their unhappy marriages in dependent living arrangements with extended family. So, all these are the socio-demographic factors cited as the reasons. Now, coming on to the methods attempted by the women, they tend to use self poisoning for suicidal acts, overdose with lethal pesticides, and die. Now, in developed countries, over the counter medications which often have lower lethality are seen, hanging, firearms when used most commonly by women, and drowning or poisoning by men, drowning or poisoning by women. Now, self immolation is one of the most common methods of suicide by women in India, Sri Lanka, Iran, and Middle East countries. Maybe it is due to the previous Indian concept of fire as a purifier, the practices of sati and joha, which previously existed as a part of our cultural scenario, the easy accessibility and familiarity of kerosene at home. Now, is it only due to mental health issues in women as well? Now, apart from the mental health issues in India, many psychosocial factors are also the reasons behind family and marriage related issues, various illnesses, including malignancy, poverty, unemployment, daily wage laborers, migrant, marginalized populations, students, and persons engaged in farming care. So, all these are cited as reasons. Now, we know that among the clinical risk factors, again, depression is a common risk factor, and this is having more chance in women as in men. Previous suicide attempt, lethality of the attempt, lower number of reasons of living with less protective factors are again a clinical risk factor. Now, eating disorders, they have a more risk for women, and again, personality issue, especially the cluster B group coming with the borderline personality, PTSD, and comorbid diagnosis with major depressive disorder and anxiety, history of multiple psychiatric admissions, and again, comorbid medical conditions, including lethal, chronic life illnesses, attribute as clinical risk factors. Now, menstrual cycle is also linked with a non-fatal suicide attempt risk factor. Now, these phases have estrogen serotonin correlations, as we know very well, and this is associated with premenstrual symptoms, and these can have a toll on the suicide attempts, especially. Although pregnancy is usually cited as a protective factor, this can again be reduced, especially in mothers aged less than 20, and especially those pregnancies are unwanted, who had stillbirth or miscarriage, and especially those with postpartum psychosis. Sevenfold increase or 17-fold long term chances are observed in few literatures. Again, the risk of miscarriages and abortion is told to be an increased vulnerability to suicidal behavior. Now, when suicide attempts was observed, the premenstrual time period was told to be increased chance of having the attempts. That is, the time period was found to be risky. Now, again, various social cultural factors associated with women who are unable to have fertility, various conceiving issues, childhood adversities, including physical, emotional, sexual abuse, and domestic violence, including wife abuse, when they are abused, shamed, and powerless wife, and they actually shift the burden of humiliation from themselves to their tormentors, and they thereby they actually give a permanent solution in the form of taking toll of their own lives. Now, when various countries were studied, in China, one child norm was found to be having an enormous pressure on wives to give birth to highly preferred male child. And again in India, dowries continue to be have a toll and as a risk factor. And when dowry expectations are not met, the young brides were found to be killed and compelled to commit suicide. And again, the attempt was found to be more by burning as well. Now, we have already discussed, although pregnancy is protective factors, when the children are young and mostly dependent, again, when it is found that having a child less than 2 year old significantly decreased suicidal risk for women. Now, when they have a good family support, good social networking with good social skills, they were found to have using good social telephone helpline, visiting family doctors, discussing their problems with others, having better opportunities to access social and health services. These were found to be having protective factors. The choice of less lethal means to suicide again increase the chance of survival, again acting as a protective factor. Now, when it comes to suicide prevention in women, now the main obstacle when it comes to the prevention aspect is the belief that this is a male problem because the completed attempts are more in men, and there is an overemphasis on individual factors and the underappreciation of social, economic, and cultural factors in female suicidal behavior. But we can observe that there is a significant progress in the prevention of female suicidal behavior, and there is a paradigm shift which is again required towards this area. Now, the more education, economic security, and empowerment, this definitely should be an integral part of suicide prevention strategy. Now, the strict enforcement of the prohibition of forced marriages, dowry, child marriages, reducing intimate partner violence, all these are options cited in prevention of suicide in women. Now, additional strategies would be to reduce the media portrayal of women dying by suicide due to interpersonal conflicts and to enhance women's ability to cope with interpersonal and intergenerational conflicts. And at this point, I would again mention the concepts of Werther effect and Papageno effect, because we know that sensible reporting like Papageno effect and over sensational reporting like Werther effect is again crucial in prevention strategies as well. Now, when it comes to the socio-demographic characteristics of women who have been died by suicide from 2014 to 2020, what does India have to say? Here we can see that although women have higher education, they have actually good suicidal rates, although they are married or not, variations are not that keen. Now, on the whole, we observe the statistics. We can see that even though people are getting more educated, financially secure, and independent, this is not that much reflecting on the suicidality reduction rates. And these are basically from the Indian Insights strategy reports as well. Now, here we have the comparison of suicidal death rates from 2014 to 2020 by the level of education. And here we can see no matter they have gone to higher education, again, there is a high chance of suicides as well. Now, this is the data depending upon their marital status and based on their grouping of states from 2014 to 2020. And here we can see that although married or not, again, statistics have significant rates. Now, here we have the suicide death rate per 1 lakh women based on the various states from India. And the red marked states are the suicide rate more than more than 15 and above. Now, the orange mark states are between 9 to 11.9, and here we can see the Kerala state as well. Now, blue nevertheless is less than 3, and that is significantly less in the India map. Now, here we can see developing countries, developed country, India, less developed states, more developed states, occupation of women who died by suicide, and grouping of states accordingly. So, in salaried employees, students, housewife, daily wage earners, all are actually committing suicides. Now, here we can see that even though they are economically independent, it is not that protective factor as we usually believe. Here we can see the uh, death for suicide in women from 2014 to 20, economic reasons, examination, family problems, health, love affair, unhandling issues, marriage, personal, social, or other issues. Abuse or rape issues, all are cited to be the reasons of death by suicide, as cited as the causes among women. Here we can see the means of death by suicide in women. This is from 2014 to 2020, and consumption of poisoning, overdosage of pills, self-immolation, all are cited to be a reason among the statistics. So, coming on to the prevention, we have seen from ma'am earlier the various prevention strategies and from sir as well. Now, the global goals in prevention is to reinforce the leadership, partnership, and institutional capacity in each and every country, and increase or enhance the capacity of health services to provide suicide prevention strategies, develop community resilience and societal support for suicidal prevention, and reduce the stigma associated with the suicidal behaviors. And I would mention the bold attempt by Mental Health Care Act is again supportive for us in this area as well. And strengthen the surveillance and evidence generation is also a global goal. Now, the immediate prevention strategies, that is in the next 1 to 3 years, what are the efforts that which we should begin immediately and achieve outcome in 1 to 3 years? Advocacy for responsible reporting of suicide by media, reduction in easy access to pesticides and insecticide. And one of the interesting approach that I came across was the with like something that happened in Maharashtra, Vidarbha. They like while going through the literature, I came to know that they have something like pesticide banks there, where the pesticides are accumulated by evening into these banks, and the farmers take up in the morning, because they noticed that these attempts were more commonly done during evenings and nights when they were bothered about the financial and other crisis. So any attempt during in this area is welcome approach. Augmenting cadre of qualified mental health, providing support to those diagnosed by mental health illnesses, including especially substance abuse and other rampant areas. Now, building help seeking behavior for mental health problems by removing stigma and myths associated with them. Because we know suicide is an area which has a number of myths, because people who tell won't do, people who have done earlier won't do, when discussing about that will make the situations worse. So, we need to break all this stigma, children won't do. So, strengthening suicide preventing efforts, targeting these stigma, and targeting prevention efforts, women, all these are, and again the farmer capacities, restriction strategies, strengthening self-injury, harm, suicide data collection at national and state level, all these are immediate prevention strategies. Again, intermediate prevention strategies, which is outcome to should be achieved in the next 4 to 7 years, leveraging policy level and addressal of underlying psychological issues such as addiction disorders, especially advocacy for the provision of psychosocial care for patients with chronic and terminal illnesses, integrating mental health services to general health care, training and capacity building helpline workers, volunteers on handling suicide related 100 calls because everybody is on online. So we can make use of the apps, telephone helplines, so that crisis help can be sought out immediately. And strategy for suicide prevention and reducing workplace stresses, as ma'am has earlier pointed out in detail. Now, long-term prevention strategies means effort should begin immediately and outcome should be achieved in next 8 to 10 years with advocacy for suicide prevention, destigmatization of mental disorders among multiple stakeholders, increasing availability of alternate methods of pest controls and other agricultural aspects. Now, again, building capacity for psychosocial support, providing psychological first aid and gatekeeper training programs and psychosocial support for those who have attempted suicide and those who have bereaved by suicide, and a mandate focus on overall stress-free physical and psychological development of children, adolescents in general, as well as life skill training mandate in along with the academic curriculum. Now, when we focus on the prevention strategies, what are the challenges? Yes, we have a lot of challenges. Prevailing stigma regarding mental health issues and myths about suicide, limited skilled human resources in the area of mental health and suicide prevention, coordinating and collaborating with multiple stakeholders with different priorities. Now, so concluding, we know that suicide rate among Indian girls and women continues to be twice the global rate. Suicide accounts for most deaths in 15 to 19 years age group compared with other causes of death. Hanging is the most common method of suicide, followed by pesticide poisoning, medicine overdose, and self-immolation. In addition to depression, alcohol use disorders, and other substance use as risk factors, several social and cultural factors appears to be risk factors as well, and absence of a national suicidal prevention strategy, inappropriate media reporting, legal conflicts in the interpretation of suicide being punishable, and inadequate multi-sectoral engagement are major barriers to effective suicide prevention. A scaffolding approach is useful to reduce suicide rates, like interventions provided at the right time, right intensity and duration, can help navigate situations in which a person might be susceptible to and at risk of suicide. Now, we have insights as well because the Indian National Crime Report Bureau data do allow for some insights into suicides, death in women in India. We need more qualitative research grounded into robust sociological methods for a deeper and contextualized understanding of suicide, along with research to facilitate better decision making to prevent these deaths among Indian women. And on the whole, we need to focus on this multidimensional area, that is, right from the academic failure to childhood, the minority stress and academic areas, and the other stress from the adolescence, and the marital, interpersonal, mental health, and other significant stressors in adulthood, and the empty nest, elderly issues, depression, demanding symptoms, poor protective factors in older adults, handling the intergeneration conflicts, interpersonal problems, marriage, marital conflicts, domestic violence, handling physical illness, chronic pain, and elder abuse, focusing on depression treatment and prevention, focusing on family history of suicide, handling coping skills regarding the financial insecurity, handling chronic stress, absence of social support, how to address that area, and the community-wide discrimination, how we can handle that regarding the gender or caste or various other discrimination. So we have a wide variety of risk factors through which we need to act upon to prevent the prevention, especially in women. Only then we can prevent this global rise or the rise from Indian trends and focus on the prevention strategies. So that is all from my side. Thank you for the opportunity again. Over to the organizers.
Thank you, Dr. Varsha, for that really enlightening talk. And as Dr. Varsha has just said, in Asia, China seems to have a very high rate compared to the rest of the countries. Also, more so the age group between the age of 15 to 19, specifically up to the age of 30 years, there is also an increased risk of suicide there. Suicide attempt is associated with an increased disease burden. Male to female ratio, although is higher in the males, it tends to be higher in younger women and is associated and an increased cause of death as well. Marital status, although not, it's debatable whether it's entirely protective or not based on circumstances and individual cases as well. Dowry, pregnancy, postnatal period are high risk factors for suicidal behavior and attempted self-harm behaviors. There needs to be very much and more work associated with prevention programs, implementation of these programs, workshops, awareness classes. And also we see that there are higher rates in Kerala as well. Just one question from my side, Dr. Varsha. We've talked about elders having possible higher rates of suicide. And do we have any data with regards to dementia and associated suicide or self-harm behaviors?
Ma'am, I need to work through that area. As you very well know, we have a number of statistics. I found one or two papers that there are higher incidence, but the exact prevalence percentage, let me check and get back to you.
Thank you, Dr. Varsha. I now open it to the audience to see if there are any questions from the side of the audience.
Audience can either ask in the chat box so that we can unmute you, or you can raise hands so that we can unmute you for your questions. We are pretty much well ahead of our time, so we are open to questions, everyone. Thank you.
I think there is one question which is for you, Dr. Varsha. Do you have any data on female farmer suicides in India?
Sir, the female farmer, farmer suicide data, I could only get male farmer statistics. Although they say that from the Maharashtra-based studies, the prevalence is more. I couldn't get the exact percentage. In fact, I searched for that. The percentage was mainly described for men in that study. Let me check and get back to you as well.
Okay, thank you. Thank you, Dr. Varsha. And also, why do women have twice the suicide rate compared to the rest of the world? I don't know who the person is, but this is a question from the chat box.
Yes, that is maybe due to the multiple risk factors that I have earlier mentioned. That is the social, religious, cultural, economic factors associated. So we have less protective factors here, and that might be the reason as per the literature, and that is what we observe as well.
Thank you. I don't see any other questions in the chat box. I don't see a raised hand in the audience as well.
One question, ADS, you can clarify. What do you mean by ADS? Predisposing factors.
Is the question, does ADS predispose to? I'm not very sure.
So there is Dr. Varun Mehta who's raised his hand. If the organizers would kindly unmute him, please.
Yes, I'm unmuted. Thank you, ma'am. I'm unmuted. Thank you. Thank you so much. There's one doubt, and I know that you've spoken about all the risk factors specifically related to the gender based. Among the adolescents, so say among the age group, which we say 15 to 29, or the younger ones actually, which are the ones, the risk factors that particularly stand out among female, among the many? Which are the ones, say, if I have to say in a hierarchical order, what would that be like in the literature that you've reviewed?
Thank you.
Among the clinical risk factors, it is again depression and anxiety part. Again, regarding the social factors, they have cited the academic stress as one thing, and again the interpersonal relationship strains, and again the workplace zone issues. So these three are commonly cited among the apart from the clinical risk factors. Substance use is said to be a predisposing factor as well.
So one question that was raised was, are housewives attempting suicide more? If so, why? Other than the other professionals. Thank you.
We have seen the statistics. I had presented in one of my slides. Actually, it is neck to neck. This is prevalent in all populations. I mean, all groups, be it in housewife, be it in working population, daily wages, or the high class individuals. But definitely a good percentage is seen in housewife. The reason cited are the less support system, the more financial dependency, the work burden, and the less amount of protective factors. So all these four are cited to be the more risk factors in those age group, those group.
Over to the chair.
I guess there's no further questions. I guess you've covered everything, Dr. Varsha. Thank you once again for that really wonderful talk, and thank you to all.
Thank you, ma'am. Thank you, everyone.
A big thanks to our previous speaker, Dr. Varsha Vidyadharan, and our chair, Dr. Sheba Nayanand. Thank you very much. And now we are on to the next session. The next topic is going to be suicide prevention helplines. What to expect? The speaker for the day would be Dr. P. N. Suresh Kumar, who's the director of Chedana Center for Neuropsychiatric Rehabilitation at Malaparamba, Kozhikode. He has had an international award, 29 national awards, and 10 state awards. He has got 18 publications internationally, 73 national, and 31 state publications. He is a pioneer and has done a lot of research in suicide and suicide prevention. And the chair for the session would be Dr. Rajmohan Velayathan, who is a professor of psychiatry, Department of Psychiatry, KMCT Medical College, an avid speaker in international forums. And over to you, the speaker. Over to the chair for the day. Yeah, the chair.
Thank you. Thank you, Zod. And wonderful work from your side, anyway. At the outset, I'd like to thank the organizers, Indian Psychiatric Society, IMA Kozhikode, for this opportunity to chair a session which is being done by one of my teachers. Suicide helplines have been there for a pretty long period of time. It was an Anglican priest called Edward Chadwara who actually in 1953 started Samaritans, which was the first suicide helpline, and he founded the Befrienders Worldwide, which actually led to the setting up of suicide helplines across the globe in 32 countries, and our own suicide helpline is under the Befrienders umbrella, started in 2001 by the IMA Kozhikode branch under the leadership of Suresh sir as Tanal. And suicide helpline do have their own role in preventing suicide, and early studies from Chandigarh actually showed that it actually decreases way back in 2003, decreases the number of suicides. And as Varsha had pointed out, now apps are the thing in focus, and apps have undergone a lot of research per se. And recent demand study said that around 492 apps are available in Google Play, and 43 of those apps do motivate a lot of people to actually contact suicide helpline numbers. But despite all this, as Dr. Krishna Prasad had cited the Zalzman-Zohar study in 2016, which talks about the Oxford evidence on the different aspects of suicide prevention, it shows that all the suicide helplines actually have got only a level 4, level 5, level 3, level 4 evidence. So we have things which are there to prevent, and these are actually the first contact preventers for suicide. So we need more robust data to show that these actually work, and we need to know what are the lacunae which actually prevent an active suicide network from functioning. And I can't imagine any other person other than Dr. P. N. Suresh Kumar sir, who has been at the forefront of suicidology and suicide prevention activities for more than 2 decades, very close to 3 decades, to enlighten us on what to expect from suicide helplines. Sir, I welcome you, and it's a great pleasure welcoming you to the talk.
Hello, am I audible?
Yes.
Thank you, Dr. Rajmohan. Good afternoon, everybody. So the topic delegated to me is, can I share my slides, please? Not here. Okay, thank you. The topic directed to me is suicide prevention helplines. What to expect? Straight away, I'm going to the topic. WHO says that suicides are preventable with a timely, evidence-based, and often low-cost intervention. So that is why the suicide prevention helplines have come out. So there are a lot of practical barriers for people with suicide ideation to seek help. Maybe the geographical limitation, people may be staying in remote areas. There are psychological barriers also, such as negative attitude towards help seeking, the stigma attached towards mental illness, stigma attached towards suicide attempt and suicidality, and moreover, the fear of involuntary hospitalization. Suppose a person with a suicidal ideation comes to a hospital, whether he will be hospitalized. So all these barriers will make it difficult for people with suicidal behavior to seek help. Suicidal ideation actually varies in intensity. It could be mild in intensity, it could be moderate, or it could be severe. Slides? Okay, yes. Slides visible, no? So, suicidal ideation can be of various in intensity, from mild, moderate to severe, and the transition from suicidal ideation to suicide attempt, it can happen within days or hours or within minutes. Therefore, see, that moment the person has the feeling of suicidal ideation, if he gets timely intervention or timely help, many of these suicidal attempts can be prevented. That's why several suicide prevention centers offer helplines for people with a suicidal ideation to provide that momentary immediate support for all these people. These helplines actually seem to reach high risk population. In fact, studies have shown that number of suicide attempts among the helpline users, that is twice as high compared to general population. So definitely it shows that people with a suicidal ideation or people with a suicide attempt, they are seeking help through this suicide prevention helpline. What are the suicide prevention helpline? See, this suicide prevention helpline service, they provide services to people in community, people who are in distress, people who have got crisis, no? So they are getting service through these suicide prevention helplines, particularly people who are at risk for suicide or they are contemplating about suicide. See, as the previous speakers spoke about the
I believe the slides have not been presented clear. We're just waiting for the expert. Yes.
I hope the slides are visible.
Yes. Yes.
Okay. See, the suicide prevention helpline services, they offer non-judgmental. That means without any bias, without any prejudice, they give non-judgmental sort of counseling or befriending. And all these interactions are absolutely confidential. The secrecy is kept. They don't have to reveal their identity and personal details. And through this non-judgmental and confidential sort of interaction, people are providing, the staff in the suicide prevention helpline, they are providing emotional support for the people in time of their crisis. And when individuals feel unable to cope up with their challenges in life, they are getting non-judgmental and confidential emotional support through these suicide prevention helplines. Can you change the slide, please? Yes. Now, these suicide prevention helplines, either it can be through telephone or it can be direct services also. There will be face-to-face listening also. Often, these helplines are referred to as telephone counseling services. It is also known as hotlines, distress line, and telephone emergency services. In recent years, there has been a rapid expansion of services, these sort of services, using new technologies, using internet chat services, text messaging interactions from mobile phone, etc. So these are the different modalities by which this suicide prevention helpline, they are providing service. Then, what is the importance of telephone helpline service for suicide prevention? See, in reality, people's need for regular contact and caring is ideally met by other people around them. Usually, they are getting caring and emotional support through by their parents, siblings, friends, teachers, colleagues, etc. But see, for some people, maybe because of the geographical limitation, as I told you earlier, because maybe they may be living in remote, inaccessible areas, or transportation facility may not be available, or there may be other types of isolation also, such as chronic physical illness or mental illness. They may not have the opportunity for interaction, or they may not be able to receive caring connection or the feeling of belongings. So this caring connection and feeling of belonging, these are essential for an individual to maintain a desire to live. So if it is not there, like the emotional support, caring connection, if it is not there at a time of crisis, the person may become suicidal, or they may contemplate or think about attempting or committing suicide. See, these helplines will alleviate the person's distress. So that will it will alleviate the distress a person is experiencing. It will reduce the intensity of such feelings, and many of these helplines, it will enable problem solving, like that will promote positive coping strategies. Then, and at the same time, it will also provide practical actions in response to personal problems. It may be like a psychotherapy, supportive psychotherapy, maybe a befriending, or just like counseling. So these people with the suicidal ideation, they will help problem solving methods. They will get practical solution when they approach the suicide prevention helplines. Many persons who are suicidal, actually they do not seek help from face-to-face health services, maybe because of the barrier or stigma attached to the mental health, suicide, etc. Or they may not even seek the support from friends or family interaction. When they are not seeking support from any of these sources, and when they are facing a stressful situation, there is definitely a chance that the person may resort to committing suicide. So there comes the importance of suicide prevention helplines. See, some people in distress, they may receive mental health care from a mental health professional. But sadly, unfortunately, maybe because of lack of time, probably in a busy OPD, maybe because maybe other people or their relatives or their friends may be there with them. So they may not be able to open about their suicidal ideations, etc. So that is also a barrier for seeking help for people with a suicidality. So here, the confidential services, the people in distress without any identity or without revealing any personal details, they are being offered helpline services. So that will help them to overcome the barrier of stigma surrounding the suicide and mental health problems. See, what are the core characteristics of this helpline service delivery? This helpline service that will provide a compassionate, emotional, non-judgmental, without any prejudice, without any bias, empathetic, a respectful listening to any person who calls to this helpline. Just like a friend, they can unburden their feelings, their stress to the person they are listening to. So these services, some of these services may focus on more structured, collaborative problem-solving approach. That's why I told you earlier, they may be doing a supportive psychotherapy. Some people, they may be providing even insight-oriented psychotherapy. But most of the time, it will be the present problem-based supportive psychotherapy. That is what most of these helplines are doing. In a suicide prevention helpline, the so-called staff or the volunteer, they are supposed to ask specific suicide risk questions. They are supposed to ask questions to assess their suicide, whether the person is suicidal or not. If the person is suicidal, how much is there the risk for suicide? That these specific questions should be asked in these helplines. And the staff will explore the options that will orient towards countering suicidal behavior. During the routine interaction, they will explore the options, whether there are any counter protective factors that may prevent the person from committing suicide. So actually the staff will focus on the protective factors so that we can prevent the person from committing suicide. And most of the time, in the interaction, they will emphasize on emotional support and non-judgmental listening. Most of these helplines will operate 24 hours a day. That means 365 days per year. Most of these services have a service delivery model that will ensure that the service is absolutely free of charge, or the cost will be just of a local call through technologies such as telephone, email, online chats, text messages, or social media platforms. These centers will be staffed by trained volunteers. Trained volunteers are actually lay people. They are getting training in identifying the suicidality, assessing suicide-related questions, and for giving emotional support without any prejudice. They are getting training by trained professionals. Some of these centers will be manned by paid mental health professionals. There may be psychiatrists or psychologists or psychiatric social workers who are trained in suicide prevention strategies, or sometimes it may be by paid para-professionals. One of the key factors in this suicide prevention helpline is anonymity. Anonymity is always maintained. That means the caller, they do not have to reveal their name or personal identification. It is not necessary, but exceptionally in some centers, the staff or volunteer, they will adopt a name or pseudonym. This is to ensure the continuity when a caller, the first time or second time, when the caller contacts the center to get the particular person, he has to have a name. Or this particular volunteer, to call the caller back, suppose there is some problem, the caller is suicidal, to assess the suicide risk and again whether the person is safe or not, he has to adopt a name or pseudonym. The volunteer has to adopt a name or pseudonym. Otherwise, total anonymity is maintained in helpline services. Then I told you that the total information that is passed by the caller to the staff, it is absolutely confidential. The staff will not note down or will not record the details of the caller, except in emergency situation due to safety concern. If the person is highly suicidal, then we may have to convey the information to the relatives or to the people concerned. We may have to pass the information. Otherwise, the total information that is passed by the caller to the center, to the volunteer concerned or to the staff, it is absolutely confidential. Here, in the telephone helpline, each call that considers as a single session, every call that will consider as a single session, and there is no fixed time limit. See, what all things the caller has to unburden, want to say, without any time limit, the staff would listen, the volunteer would listen, without any prejudice. That is the underlying the importance of helpline services. In some cases, as I told you earlier, suppose the caller is highly suicidal, there may be a follow-up call to check the safety of the person and well-being of the person. Totally, the interaction is not judgmental. They will listen to the caller's problem without any prejudice, without any bias, and that way they will offer emotional support and connection. Connection is very important. The emotional support and connection, these are the key elements that will strengthen the caller's sense of belonging, and that will strengthen the caller's the desire to live. So the emotional support and connection, these are the key elements in this helpline services. Another important thing in this interaction is there is no, in all these centers, there is no any religious or political or ideological affiliation. The volunteer or staff doesn't have any religious, political or ideological affiliation. Without any prejudice, they will listen to the caller's problems. At the same time, the volunteer will routinely do the safety checks, whether the person is mildly suicidal, moderate, the suicide risk is mild, moderate or severe, whether the person has got only suicidal ideation, whether he has a plan, if there is a plan, whether at what time and what method he is planning to adopt for committing suicide. So all these we have to routinely ask in the interaction. So that's why the staff in the Suicide Prevention Helpline Center, they are adequately trained and supervised to ensure their competency to deal with all these important factors. And sometime if the caller is, if the volunteer or the staff is not able to provide adequate preventive services, if the risk is much more than a primary like a first aid care, then if he needs further care, further support, then the staff is trained to refer the person to other sources like a mental health professional or a hospital. Whenever it is appropriate, he has to refer the person for appropriate care. Then see, most of this this telephone, not only telephone helpline, most of this suicide prevention helpline that is complemented by other services, such as there will be a drop-in center. That person can, even physically they can come to the center for a face-to-face help. And of course, there will be outreach programs also in community, like Suicide Prevention Day, World Mental Health Day, then International Day Against Drug Abuse, Illicit Trafficking, and most of the days will be observed judiciously. And other than that, also we will have various outreach programs, mental health awareness programs, suicide prevention awareness programs in communities. All these helplines will have a website. This is for accessing self-help group, and they will get lot of information, suicide prevention help information from these websites online. Then they will also respond to text messages, SMS. They will respond to emails, online chats. There will be discussion forums. So there are various other modalities also for suicide prevention services. Then there will be self-help and other information in different formats. These centers will have leaflets about suicide prevention information. There will be videos, CDs, DVDs. There will be online self-help programs. Then see, especially in Kerala, we have now lot of natural calamities. So we have got a post-disaster support, like to help people who are succumb to these natural disasters, who have witnessed such natural disasters like hurricanes, flooding, earthquake. So we are the helplines will provide post-disaster support, and there are other outreach programs also in community. That is to provide education, then training about suicide prevention. There will be training, then awareness about mental health to the community gatekeepers. As Dr. Krishna Prasad already talked, these centers will provide training to the gatekeepers. The community gatekeepers are mainly general practitioners, health workers, family workers, school teachers, police, firefighters. So for these people, we are giving training to regarding suicide prevention, various strategies. Then these centers will provide information about their services at suicide hotspots. There are many locations where suicides can happen very frequently. There are certain railway stations, railway track, certain bridges, cliffs. In such places, very frequently the suicides can happen. So these centers, they will put signs and suicide prevention posters. They will display their helpline number also. So that is one other sort of service done by the suicide prevention helplines. They will also provide help and support to persons buried by suicide. They are known as survivors. So suicide prevention helpline will provide support to the survivors also. That too, most of the time they will be doing in group sessions. Then they will provide information and support to persons who know someone who is suicidal or who has attempted suicide. So by giving information and support to the persons, they know someone who is suicidal. So that particular suicide can be most of the time can be prevented. Then again another important the help which we are providing, the suicide prevention centers providing, is advocacy, guidelines or information to government to develop various suicide prevention strategies and programs. See, when we look at the helpline caller profile, actually the studies say that helpline attract people of all ages. But the statistics show that the highest number of telephone contact is between the age group of 25 to 50 years. They are the people usually seeking the telephonic contact for suicide, for helping to alleviate the suicidality. In fact, when we look at the chat and text calls, it is less than 18 years. So slightly younger age population is using chat and text services. Some studies have found that female callers are more often than males using telephone helpline services. Then what are the range of issues in people they are seeking this telephone helpline services? When we look at the data collected by Australian crisis line workers, Lifeline Australia 2019, the study shows that most frequent cited issues are mainly family and relationships, then health and disability, then lack of sense of self in the community, feeling they are losing the sense of self in the community. These are the main issues raised by the people seeking help in this Australian crisis line. Then data collected on callers to Samaritan hotline done by Pollock et al. In 2010, almost the issues are similar. The common reasons are mainly mental health problems, self-harm, relationship problems, relationship breakdown, family problems. These are the main issues for all these telephone call helpline seekers. Now, see the staff and what about the staff and volunteers? Staff or volunteer of this suicide prevention helpline. See, they should have definitely an empathetic and non-judgmental listening skills. In fact, they are trained to have an empathetic and non-judgmental listening. This is what the training they are getting. They have to establish rapport with the caller. Definitely, they have to assess the suicide risk in all calls routinely. They have to assess the suicide risk. So the interaction of these volunteers or callers are very different from a general therapist, like a psychologist is doing counseling in a counseling setting. So the interaction between the staff, the volunteer and a caller in a suicide prevention setting is different from a general therapeutic setting. Then they have to go through rigorous assignments, including responding to crisis messages, not only telephonic interaction. They have to be trained in micro skills, non-verbal communication, paraphrasing. They have to make sure that they are listening to the caller's problem. So they are getting adequate training for that particular aspect also. They have to train them. We have to train them to read between nomenclature, syntax, etc. Even one full stop or one asterisk mark itself sometime may be important for a person with a suicidality. So the staff or the volunteer will get adequate training to read in between lines when a suicidal person is posting lines, etc. Now they are trained to assess if the caller falls under active or passive suicidal ideation. If a person is planning to commit suicide, if we get the message or information like that, then the concerned staff should immediately ask whether he has a plan, how the person has plans to do that act, etc. We have to get the details first of all we have to establish rapport. In a non-judgmental way, we have to elicit all this information from the caller. If there is a plan and he describes it, our aim is, volunteer's aim is to counsel the person against it. Also, if there is a plan and if he is describing the plan, the volunteer has to request the caller to pass his phone to a family member so that the person will be in contact with the family member to comfort the person concerned, to comfort the person. So we are establishing an emotional comfort zone between the caller, so-called caller, and maybe with his a good supportive family member or a colleague or a friend like any other person. So this is very important if suppose a person is highly suicidal. Suppose he doesn't have any family member or friend around, then the staff has to contact the nearest mental health institution, or sometime he may have finally resort to calling police to help that person concerned. So that is why we call, even though the service is absolutely confidential, if the person is highly suicidal, then we may have to pass the information to the people concerned. The main purpose of the helpline is to buy time. See, most of the time, suicide attempt or suicidal ideation is only a momentary feeling. Suppose the person is getting the timely help, then that particular ideation or attempt can be prevented. So, the main purpose of this helpline is to buy time and to listen to the caller without any prejudice. So, here the basic training for the volunteer that include improving active listening skills, understanding grief and bereavement, and identifying the caller who is suicidal or who is not suicidal. That is the most important thing. Then see, all these staff or the volunteer in the center, they need refresher training. Refresher training is actually based on case by cases. Every day they will be seeing cases either through telephone line or physically. So they will be learning by seeing cases by cases, and the routine discussions also will be there in the center. Their approach was correct. What they have not done, what could have been done to help them. like there will be discussions also among the volunteers. So all these are actually part of the refresher training. So the training is actually a mix-up of theories, suicide prevention strategies, and a mix-up of practical experiences, so that the counselor or volunteer, they feel comfortable in catering to the caller's emotional needs. Now, what is the impact of this telephone or suicide prevention helplines? See, research has consistently shown that suicide prevention helpline that will definitely reduce the psychological pain, anguish, hopelessness, and suicidal ideation. But unfortunately, we don't have any high quality evidences. Why? That is mainly because of the ethical consideration. See, we cannot have a control group to study the impact of suicide prevention helpline. We cannot give a helpline service to one group, and we cannot ignore, we cannot deny the suicide helpline for people in distress. So we cannot keep a control group to see what is the effect of helpline and what is the effect of people who are not provided helpline. So such sort of, because of the absence of control group, we cannot have any high quality sort of case control studies. And it is very difficult to measure the effectiveness in preventing suicide also. As I told you earlier, we are keeping the anonymity. We are not keeping the identity or personal details of the callers. So once after a telephonic interaction, we are not able to call them back to see whether the person is absolutely safe or whether the person has committed or attempted suicide. We don't have the way to assess the impact of the telephone helpline sort of interaction. Only in certain cases we can do a follow-ups. Otherwise, because we don't have any complete details, we don't have any good quality data to assess the effectiveness in preventing suicide. So in vast majority of studies, the studies based mainly on observer rating. It is based mainly because of the observer satisfaction or the online caller satisfaction. And most of the time, people are not using any validated scales. So we don't have any high quality evidence of the impact of telephone helpline services. Anyway, the research provides some encouraging results. Various studies have shown that suicidal individuals do actually contact crisis lines. People who are in distress or highly suicidal, they are actually contacting suicide prevention helplines. That is what various studies are showing. A study of outcomes achieved for telephone callers to a crisis line in USA showed that the intent to die was reduced by the end of the call. Then another study in Australia that examined telephone callers to a youth crisis line, there was a measurable reduction in suicidal ideation during the call. Then a recent study in UK, a telephone crisis line, it was found that it is effective in reducing suicidal and self-harm ideation. Mishar et al. Found that 35.2% of the calls made to a crisis line in USA, that was for persons with a suicidal crisis. That's what I told you, that persons with a suicidal crisis, they do actually call these telephone helplines. Two studies tested the effectiveness of a chat-based helplines and found a positive effect on visitor helplessness and suicidal ideations. So in fact, all these are encouraging results. Now, what are the pitfalls of all these suicide prevention helplines? See, as we all know, suicide prevention helplines cannot alone prevent all suicides. It can only give a first aid sort of suicide prevention strategy. If the person is highly suicidal, definitely they have to refer the person to higher centers. And many of the people with the suicidal ideation, or they will not contact this helpline. So this alone, this sort of helpline alone is not enough to prevent suicides. It can act only as an initial step in the process of preventing suicides. Further management is essential. So there should be a concerted effect from government and other stakeholders. It is necessary for suicide prevention. And then the staff working in suicide prevention helpline Most of these people, because they are every day seeing people with a high suicidality, so they are in high stressful situation. They will be always worrying whether the person, whether he will commit suicide today or tomorrow. That sort of idea thinking will be always daunting this sort of volunteers and staff. So they are always in a high stressful situation. Unfortunately, most of the staff or volunteers in these centers, they are not qualified in mental health. They are all lay people. They are not qualified in psychology or psychiatry. Only thing, they are trained. They may be getting a few days or a couple of weeks training to identify the people with the suicidality. So they are not actually fully equipped to deal with these people. Then they have to undergo rigorous training to able to speak to callers experiencing suicidal and to help them. They are getting training, but still we don't know that sort of training is whether it is adequate or not. Most suicide prevention helplines, even though I told you that most of the centers will run 24 hours a day, but in practice, in real world, most of these helplines will not run 24 hours a day. A systematic review of the effectiveness of crisis line services found that suicidal urgency decreased in only 16% of the users, while 76% showed no change and 8% seemed to have deteriorated during the conversation. This is a systematic review of various crisis line services. So this systematic review is not that much encouraging. Now, see, I am coming to the end of my presentation. See, the most important suicide prevention helpline all over the world is through Befrienders Worldwide. My chairperson has already talked about Samaritans International. It is otherwise known as Befrienders International or Befrienders Worldwide. Actually, it was evolved from Chad Bara, who was a priest. He was befriending people in crisis, in distress in his own church. So this concept evolved in UK. So the primary aim of these centers is to relieve distress and to reduce the number of deaths by suicide. So the basic principle of all these centers, Befrienders Worldwide, is to recognize the importance of being listened to in confidence, in anonymity, and that too without any prejudice. And to value that a person has the fundamental decision about their own life. The person has the decision whether to continue his life, to take his own life. That fundamental decision is of himself. Befrienders centers have no political, religious, or sectarial affiliations. Their experienced volunteers will select further volunteers. They will train them and they will supervise other volunteers also. Individual member Suicide Prevention Center will support other centers and they will be sharing information each others. So all over the world there are 349 emotional support centers in 32 countries, reaching an estimated 7 million people each year. See, under the wild umbrella of Befrienders International, we have got our organization, that is Befrienders India. Befrienders India was actually started by Dr. Lakshmi Vijayamar. It was registered in 1992 under the name of Sneha in Chennai. So it's a nodal body which coordinates the activities of national helplines and other member centers. There are many centers in India spread across India. You will get all the details from Google, from the net. In Kerala, I can say that there are 5 centers, befriending centers. Befriending means in these centers there is a person, there is a volunteer, just like a friend who will listen to the caller's problem in a non-judgmental, in a non-prejudiced way. As a friend, he will listen to the person's problem. We have got 5 centers in Kozhikode, Cochin, Kodungalur, Thiruvananthapuram, Idukki. We have got in Calicut, our center's name is Tunnel. Tunnel means shade. We have got telephonic and physical. We have got chat-based services, mobile, internet services. All these services are provided in Tunnel in Calicut. All these centers will offer volunteer befriending through personal, telephonic, and postal interactions. So, my suggestions are: national suicide prevention strategy should include crisis lines as one component to help people in distress in an accessible and immediate way, regardless of the geographical barriers. Alongside mental health promotion, prevention and treatment of mental and substance use disorders, other intervention for the prevention of suicide, crisis lines should play an important complementary role in suicide prevention. So, thank you for the patient listening. Thank you all.
Over to the chair. I'm sorry.
Thank you, sir, for that exhaustive review of what to expect from helplines. You have actually covered a lot of area, from barriers to communication for a person attempting suicide, to the core characteristics and key elements of a helpline, to the types of services and modalities or mode of delivery of services, to the staff responsibility, attitude, skills, to strategies the staff has to explore, to the complementary services like dropping centers or outreach programs or information educational services, to advocacy, to issues that they have to deal with, to pitfalls in data and pitfalls in research, and international and national bodies. So it's been a wonderful journey, which actually helps us to understand what these are and how these function. Now it is open for questions. There were a few questions in the chat box, but I think it got slightly deleted. So if Zoed can actually access the chat box, because mine actually had an issue whereby it seems to have been deleted.
So one of the questions that was actually raised was, are there any authentic source of suicide helplines which we can give to our patients?
Can I answer?
Yeah, please, sir. Please, to you.
In India, one of the authentic suicide prevention helpline is Befrienders India. If you can Google, you will get all the numbers of suicide prevention helplines that is regulated by Befrienders India. You will get all the numbers. There are so many centers in Kerala, in Delhi, Calcutta, Bombay. Most of the states, they have got suicide prevention lines. At least 2-3 suicide prevention centers are there in most of the states. You will get all these numbers from Google. Most of the government sector also, in Kerala, at least we can say that Kerala government also providing suicide prevention services free of cost. We have got toll-free number. I think most of the states, the concerned government also is providing toll-free suicide prevention helpline numbers.
So you would have to unmute, Rajman sir. Or do you, okay.
Could you get the other questions? I'm still unable to access my chat box.
One of the questions that was actually another question that was raised was, would the gatekeepers or the persons who are actually working as gatekeepers be afraid of legal consequences of anything untoward happening? How do we actually address that?
If Dr. Krishna Prasad is there, is he there? There is one question regarding gatekeeper.
So it would be I think he is unmuted. Dr. Krishna Prasad.
I think there are sometimes concerns that gatekeepers can have about falling into a legal trouble because of trying to help or helping somebody. I think one has to equip them to deal with some of the apprehensions that they may have, and suggest to them that they may need to err on the side of caution even in people with moderate risk of suicide, low or moderate risk of suicide. Despite that, they may have challenges sometimes, and of course, on a case-by-case basis, we might need to deal with such situations. Definitely, people express concerns about issues that they may fall into in terms of legal problems when dealing with people in crisis. But they are far and few.
And one of the questions that was raised was, if we would want to, how would we establish one of these telehelpline centers? If you would want to, how would we establish one of these telehelpline centers?
Okay, see, if anybody want to start a suicide prevention helpline, Befrienders India is ready to help those people to start centers anywhere in India. You can contact directly the headquarters. You will get the number of Befrienders India, the office number. It is already available in the web. You can contact them. So if you have a place, if you have adequate number of prospective volunteers, if you have a telephone line, definitely Befrienders India is ready to help them out to start center anywhere in India. You can contact them directly. Befrienders India, the number is there. Please contact. They are happy to start center anywhere in India.
Any further questions? Okay, in such a case, there are a few comments in the chat box saying that it's an excellent presentation, sir, and a very comprehensive and exhaustive presentation. Thank you all for joining in and listening to this excellent presentation, and thank you organizers for allowing me to chair this session. Thank you. Back to you, Zoeb.
Thank you, and that was like an excellent presentation by Dr. P. N. Suresh Kumar, and it was chaired by Dr. Raj Mohan, and thanks to both of you. And now we have actually come to the end of the CME section, and we would be breaking up for lunch, and that has been a lot of participants both in our YouTube live streaming as well as online, directly online. And now we break for lunch, and we are actually followed by a very informative as well as an excellent group of panelists and with a moderator coming back on suicide prevention. So all of you, I request you to actually come back at 2, since we are actually breaking out for lunch, and then we'll be joined by a very excellent and invigorating session on suicide prevention. And thanks to all of you. The panelists would be joining live from our center here at IMA Hall, Kozhikode. And so again, it would be mostly face to face, but then it would be telecast live to all our viewers back at home. So again, I request everyone to join back at 2 p.m. We are breaking out for lunch. Thank you, everyone. Bye. For anyone who have missed the previous sessions, we have already streamed the sessions live on YouTube, and if you could actually click on the link and go back, you can actually watch the sessions again.
ഇങ്ങോട്ടേക്ക് വരുന്നുണ്ട് കാരണം ഈ സ്ക്രീനിൽ ഒരാൾ വരും ഇവിടേക്ക് മോഡറേറ്റർ പിന്നെ ആയിഷ ദയാൽ പിന്നെ 4 പേരുണ്ട്.
ഇല്ലല്ലോ, വേണ്ടല്ലോ. ഓൺലൈനിൽ സെഷൻ അങ്ങ് തീർത്തിട്ട്
ഓൺലൈനിൽ വേണ്ടിയിട്ടുള്ള ആവശ്യമില്ല. അത് വേണ്ടല്ലോ, വേണ്ട അത് വേണ്ട. 4 പേര്.
ഞാൻ ആ അത് Greetings everyone. We'll be starting the afternoon session soon. We have been joined here at the center by our eminent panelists and the moderator. We'll be starting the session soon. Thank you everyone for actually bearing with us. we will be starting with a panel discussion in 15 minutes. We have had all our panelists coming here, so I request all the participants to re-log in. So in 15 minutes, we'll be starting with our panel discussion. Thank you all. Good afternoon, everyone. I welcome all of you back. This is CME primarily focusing on suicide prevention for primary caregivers, jointly organized by the Indian Psychiatric Society, Suicide Prevention Specialty Section, Indian Psychiatric Society, Kerala State Branch, Calicut Psychiatric Guild, and the Indian Medical Association, Kozhikode Branch. We have come to the afternoon session whereby we will be having the panel discussion which we actually talked about previously. And I welcome you all to the panel discussion. This is going to be an invigorating session, opening our minds to furthering the idea of suicide prevention in our community. So, Varunas Mehta. അത് മതി. ഇരിക്കും. See, we have 5 distinguished panelists and a moderator. So I'll be introducing our distinguished panelists for the day. We are joined by Dr. Dayal Narayanan, who is the Associate Professor in Psychiatry, Government Medical College, Kozhikode, Kerala. He is a faculty in medical education from 2006 onwards in the government medical colleges of both Kozhikode and Manjeri. Had been in charge of suicide prevention clinic of GMC Kozhikode for around 10 years now. He is the associate editor, Kerala Journal of Psychiatry from 2016. He is a member of the IPS Executive Committee, co-chair of the CME Committee, IPS South Zone, has research publications in the area of disability, perinatal mental health and community psychiatry. Is a very distinguished speaker in various national forums, authors of books and articles in public awareness. I welcome Dr. Dayal Narayanan to the forum. We are joined online by Dr. Shankar Mahadevan. Dr. Shankar Mahadevan is an ENT surgeon. He is the Executive Council and General Committee meeting of Rehabilitation Council of India under Ministry of Social Justice, Government of India. He is the President of AOI Kozhikode Chapter, Junior Vice President of the IMA Kozhikode. I welcome Dr. Shankar Mahadevan. He will be joining online through the Zoom. And another panelist joining online is Dr. Varun S. Mehta. Dr. Varun S. Mehta is the Associate Professor of Psychiatry at CIP Ranchi. He is a chairperson of the IPS Special Section of the Suicide Prevention. I welcome Dr. Varun S. Mehta. I believe that you are unmuted. Yeah. Again, we are joined by another distinguished panelist, Mr. Krishna Kumar. Mr. Krishna Kumar is a native of Ambalappuzha in the district of Alappuzha. K.C. Krishna Kumar holds a doctorate degree in Malayalam and has been working as a journalist for the past 23 years. He is currently serving as the assistant editor in charge of career and health section of the Madhurabhi. I welcome you, sir. And again, we are also joined by our distinguished panelist, Mr. Umesh A., who is the Assistant Commissioner of Police, Special Branch, Kozhikode City. I welcome you, sir. Thank you. So again, the moderator for today's discussion would be Dr. Harish MT, who is the professor and head of department, GMC Kozhikode, who has had a distinguished career and has been pioneering a lot of programs in and around Calicut. I welcome you, sir, as the moderator. Thank you. And over to you now, sir.
Hello. Hello. Yeah, okay. So, thank you, the organizers of this program, Dr. Varun Mehta, Dr. Deepan Sarkar, and Dr. Suresh Kumar, who are the office bearers of Indian Psychiatric Society Suicide Prevention Specialty Subsection. And I also thank our co-organizers, Calicut Guild and IMA Kozhikode branch for inviting us for this program on behalf of my panelists also. So I think we shall start with a brief keynote or introductory note by our chairperson, Dr. Varun Mehta, who is joining online from Ranchi. So I think we shall go to that first. So over to you, sir. Dr. Varun Mehta, sir. Please deliver your address to the audience and to the panelists. Thank you.
I hope I'm audible, sir. Okay.
Yes,
thank
sir,
you,
you're
sir. And thank you. And kindly accept my apologies for not being able to join you there on the table physically. And respected panelists, a very warm good afternoon to all of you. To all the mental health professionals, physicians, the print media personals, as well as everyone around, very warm good afternoon. This is, to my understanding, one of the most important parts of the CME, having a panel discussion. And the reason for having this panel discussion is actually to increase our scope of the particular aspect of suicide prevention. And we've discussed this a lot since morning, and I want to bring it forth again regarding the fact that suicide is not just a mental health problem, it's a public health problem. And it's not just mental health professionals who have to be concerned, and it's all of us who have to be equally working towards this particular area. The unfortunate aspect is that we do not really have a lot of people who are actively taking it up as an area of work or even as an area of clinical practice as well as research, partly because it's not a clinical diagnosis that we're looking at. There's one thing about all the aspects of suicide prevention that we've spoken about. There are 4 pillars by WHO, the World Health Organization, that stands important till date. That remains reducing the access of means, responsible reporting of media, imparting positive life skills to the youth, the students, as well as early detection and providing mental health services. So these 4 areas, they form the cornerstone for any aspect of suicide prevention. And I hope that all of us who have gathered today can channelize our discussion as to how we can invigorate as well as expand our efforts in this particular area. So I won't be taking much of your time, but there's one aspect that I wanted to highlight to everyone around. That's like, we do know that it is preventable, but then I've heard a lot of organizations as well as people talking about zero suicide policy, and that's not possible. As long as humans exist in the society, we are continuing to face it. But that doesn't mean that we would not put in our efforts to ensure that we can improvise upon our strategies to deal with this particular troubling aspect in a very burdensome scenario that the country is facing at the moment. So this is all from my end. Subsequently, like I've been informed, what has been that this discussion would be in bilingual mode and most of it would be in Malayalam.
That will be all from me. Thank you, and thank you once again for giving me.
Thank you, sir, for your address, and you have highlighted the key aspects that has to be discussed. So I also would congratulate you for choosing this month itself, as it is the September 10th is the World Suicide Prevention Day. So even though we could not have it on the same exactly on that day, we are in the same week. So that way, this is a commendable effort from the Indian Psychiatric Society specialty subsection. Okay. So I think we will start with our discussion on the topic. The topic is the role of society in prevention of suicide. So I would welcome our esteemed panelists to talk on this topic. I think we look at suicide as a biopsychosocial event. There's biological factors, psychological and social factors. But today's topic mainly is on the social aspect. So I would request the panelists to talk. As Dr. Varun was saying, we'll be having a bilingual sort of, because some of the panelists are maybe resorting to Malayalam in between. So if there is anyone wants to clarify, we can just try to sum up whatever is being said in the Malayalam or other languages. So please bear with us for that. And I think we'll talk about two aspects. One is, does society have a role in causation of suicide? Even though we say that there is a biopsychosocial, so what aspects of the society, or what all things or what all scenarios in the society leads to a suicidal act or a suicidal behavior? So that is one aspect. And then the next obviously is how to prevent or how to correct this kind of situation. So I would ask our panelists to address these issues. So first I'll ask Dr. Dayal to speak on this, both these aspects in mind, and we'll have a 3 to 4 minutes of talk from the panelists, and after that we'll go into the discussion. Okay, Dr. Dayal, please.
Thank you, sir, and a very good afternoon to all of you. First of all, I thank the organizers for giving us this opportunity to be part of this panel discussion and to discuss and deliberate on a very important topic. And as the moderator has initially pointed out, the role of the society in suicide. So we would know that the role could be, as he has rightly pointed out, in causation or contributing to suicidal behavior, and the role could very well be in preventing or mitigating or helping people having suicidal behavior. So in both these directions the role can be discussed, and from today morning onwards we have had various interesting sessions, both academically and informative sessions, dealing with very interesting aspects of suicidal behavior. We had a session on gatekeeper training in suicide prevention, which actually highlighted the importance and the impact of training the members of the society, public, in helping and assisting the activities aimed at suicide prevention. We had another session by a distinguished and senior clinician and a medical teacher who talked about the impact of various activities within the campus and in colleges, which can be of help in dealing with suicidal behavior, preventing suicidal behavior, enriching the campus life of students and helping them out in handling the various issues that they face. She also happened to mention about the importance of medical humanities in curriculum, in inculcating or including activities aimed at wellness of students or faculty or staff members of an institution. So that was a very interesting perspective. Then we also had deliberations on impact of telehelplines, other technical options available in facilitating the efforts targeted at suicide prevention. So all these things point out to the importance of involvement of various domains, of various facets of the society. So it is more of an interdisciplinary interaction and contribution that is required in this area. my role would be limited to that of a clinician and a teacher. I would think I would take that role basically because when we address the social determinants of suicide and suicide prevention, I would be more curious and eager to listen to our other panelists who will bring in their experience and expertise in the other domains of the social aspects of suicide, other than that of a psychiatrist or a medical professional. So it has its significant value. So I will restrict myself to my personal experience and professional experience with regard to dealing with this very complex and heterogeneous clinical issue. And as I was involved in a regular conduct of the suicide prevention clinic in a referral center, my involvement has mostly been with attempted suicides, most of which were not actually, we can say that suicidal behaviors, like which aimed at ending one's life. Rather, it were mostly self-harm behaviors or intentional self-harm or deliberate self-harm. So that again is another major subset of patients whom we cater to or we address with. And then we had a significant encounter with students and faculty members having significant mental health issues and having suicidal behavior. That again is a significant issue. And we have tried to address or handle these issues from various possible directions. Apart from clinical help, treatment help, or other such direct personal interventions, we have also tried involvement of platforms, various platforms in the campus, like the Students' Union or Parent Teachers Association, helplines, awareness programs, observing various days and things like that. But I'm not very sure how much and how far we have been successful in really making a huge difference in the prevalence and presentation of suicidality in with these activities. And I think these are a few initial thoughts that came to my mind when we talk about the and significant changes in the social realities through which the generation of students and teachers go through. And that again has a significant impact on the way the presentation of suicidal behavior, the possibilities of interventions. So with these few words of initial few thoughts, I think I would more eagerly listen to other panelists in this platform. Thank you.
And thank you, Dr. Dayal. I think I'll move forward with to Dr. Mr. Umesh. Umesh is the Assistant Commissioner of Police of Calicut Urban District, and he's been associated with mental health movements for quite a long time. I know him for so many years, right from the time when we started a effort to rehabilitate wandering mentally ill people in the city. The district collector had a vision of trying to find out all the wandering mentally ill people, all the wandering people in the city, and assessing them for whether they have mental illness and providing them some service, rehabilitation and housing kind of facilities. So from those days, I have been knowing him, and he's very much involved in this kind of, even though he's in the police, he's a very active person who works for the society and social cause. So over to Mr. Umesh.
Thank you, sir. First of all, thanks to Indian Psychiatric Society, Calicut Psychiatric Guild, IMA, and my friends. I'm sure we, the police, have the significant role in the suicide prevention. Most of the cases reporting to the friends, then they hand over to the teacher. Nowadays in Kerala, most of the Anganwadi teachers, Anganwadi workers, have also a significant role. Most of the information receive them, but they are not able to handle the issues. They are not able. They are not equipped with the psychological first aid also. There's need to psychological first aid training to them. And the police, we have conducted so many programs. So CHIRI is our major program. CHIRI means Children's Innocence and Children's Happiness and Innocence Rejoining Initiative on CHIRI. This CHIRI is there's a toll-free number 9497900200. Somebody in Malayalam also they needed both language we are using. In Chiri, if a student got into the Chiri, the psychologically trained person attending the call and they are addressing their issues. നമുക്ക് അവരെ വിളിച്ചു കഴിഞ്ഞാൽ അവർ കിട്ടുന്നത് അവർ പ്രോബ്ലം മനസ്സിലാക്കിയിട്ട് അവരെ ഐഡൻറ്റിഫൈ ചെയ്യുന്നു. തിരിച്ച് നമുക്കിവിടെ അറൗണ്ട് 52,979 calls received from the students. Out of this, 38,270 calls are general calls. Anxiety, small issues are there. Then 14,709 calls vulnerable and need the help. Out of this, phone addiction 2,216, game addiction 1,332, mental stress 4,384, study problem 2,136, family issues 1,196, electronic gadgets 860, issues, internal issues 1,800. Now HOPE is our project helping others to promote education. HOPE students problems also we are addressing 785 students. In this 14,709 calls, most of them there is a chance to suicide. ഇവിടെ നമുക്ക് കേൾക്കാൻ ആളുണ്ടാവുക. ബി എ ബെസ്റ്റ് ലിസണർ. ലിസണിങ് സ്കില്ല് നമുക്ക് പറയും പഠിപ്പിക്കുന്നല്ലാതെ നോബഡി ഹാവ് ലെവലിലേക്ക് ഇല്ല. അപ്പോൾ ലിസണിങ് സ്കില്ല് ഉണ്ടാക്കണമെങ്കിൽ, കേൾക്കാൻ ആളുണ്ടാക്കണമെങ്കിൽ അതിനുള്ള ട്രെയിനിങ് നമ്മൾ ബോധപൂർവം കൊടുക്കേണ്ടതുണ്ട്. ഒരു സ്ഥലത്ത് ഇഷ്യൂ ഞങ്ങളിവിടെ കണ്ടത്, ഈ ഇതെന്ന് ഞങ്ങൾ മനസ്സിലാക്കിയത്, ഒരു പോലീസ് ഇങ്ങനെ ഒരു നമ്പർ വെച്ചപ്പോൾ ഈ നമ്പറിലേക്ക് ആൾ വിളിക്കുന്നു. ആൾ വിളിക്കുന്ന ആ നമ്പറിൽ നിന്ന് ഇത്ര രീതിയിലൊരു ഇൻട്രാക്ഷൻ വരുന്നുവെങ്കിൽ നമുക്ക് മറ്റു മേഖലയിലുള്ള ആൾക്കാരും കൂടി ഇതുപോലെ നമുക്ക് ചെയ്യുകയാണെങ്കിൽ വലിയൊരു രീതിയിലുള്ളത് ചെയ്യാൻ പറ്റും. ഫ്രം മൈ എക്സ്പീരിയൻസ്, when I was in SHO in Koilandi police station, when there is an area, there is generally reporting more suicide cases from that area. നമ്മൾ ചെയ്തത്, one day I pasted all the wall one notice, easy way to suicide. Suicide ചെയ്യാൻ എളുപ്പ വഴികൾ, പ്ലീസ് കോൺടാക്ട്സ്. ഒരു നോട്ടീസ് അടിച്ചു, ഈസി വേ ടു സൂയിസൈഡ്, പ്ലീസ് കോൺടാക്ട് ദിസ് നമ്പർ. അപ്പോൾ ഈ ഇത് അടിച്ചപ്പോൾ ആ ഏരിയയിൽ മുഴുവൻ ഒട്ടിച്ചു കഴിഞ്ഞപ്പോൾ പിറ്റേന്ന് രാവിലെ നേരത്തെ തന്നെ വിളി തുടങ്ങി. ആ ഫോണിൽ കോൺടാക്ട് നമ്പർ വെച്ചപ്പോൾ ഈ ദോസ് ഹു ആർ കോൺടാക്ടിങ് ദിസ് നമ്പർ സംബഡി ഹറാസ്, ഫിൽത്തി ലാംഗ്വേജിൽ ഹറാസ് ചെയ്യാൻ തുടങ്ങി. ചിലർ ചോദിക്കുന്നത് എന്താ ഇങ്ങനെ ഒട്ടിക്കാൻ കാരണം, എന്തിനാണിത്? പക്ഷേ നമ്മൾ മനസ്സിലാക്കേണ്ടത്, സാധാരണക്കാരന് ഇത് കണ്ടു കഴിഞ്ഞാൽ സൈഡ് ഇഗ്നോർ ചെയ്യേണ്ടതേ ഉള്ളൂ. ഇഗ്നോർ ചെയ്യാതെ ഇത് കയറി പിടിച്ചവരൊക്കെ അറ്റൻഷൻ വേണ്ടവരാണ്. അപ്പോൾ അത് നമുക്ക് ആ ആളുകൾ മുഴുവൻ നമ്മളൊരു കൗൺസിലിംഗ് ടീമിനെ വെച്ചിട്ട് ഒരു കൗൺസിലേഴ്സ് വെച്ച് ഒരു സംസാരിക്കുന്ന രീതി എത്തിയപ്പോൾ ആ ഏരിയയിൽ സൂയിസൈഡ് കുറഞ്ഞു എന്നുള്ളതാണ്. ഇതൊരു ടെസ്റ്റ് ട്രയൽ നടത്തി നോക്കിയതാണ്. അപ്പോൾ അന്ന് എൻ്റെ കൂടുതലുള്ള മേഖല സുഹൃത്തുക്കളൊക്കെ നമ്മളോട് സഹകരിച്ച് നമ്മൾ ചെയ്തൊരു ട്രയലായിരുന്നു. ഇത് കാരണം സ്റ്റുഡൻ്റ് ആയിരിക്കുമ്പോൾ നമുക്ക് എനിക്കുണ്ടായിരുന്നൊരു അനുഭവമാണ്. എൻ്റെ കൂട്ടുകാരൻ എന്നോട് പറഞ്ഞു, ഒരു ദിവസം എൻ്റെ മുഖത്തേക്ക് സിഗരറ്റ് വലിച്ചു ഊതി. അന്നും ഇന്നും സിഗരറ്റിൻ്റെ സ്മെല്ല് ഭയങ്കര ഇറിറ്റേഷനാണ്. അപ്പോൾ ഞാനോട് കുത്തിന് പിടിച്ചപ്പോൾ പറഞ്ഞു, ഇല്ലടാ, ഓൺലി ടുഡേ ഞാൻ ലാസ്റ്റ് സ്മോക്കിംഗ്, ദിസ് മൈ ലാസ്റ്റ് സ്മോക്കിംഗ് എന്ന് പറഞ്ഞിട്ട് എൻ്റെ കയ്യിലേക്ക് സ്മോക്ക് ചെയ്ത് ഇത് ചെയ്തു. പിറ്റേന്ന് ഞാൻ കണ്ടത്, ഞാൻ അറിയുന്നത്, കോഴിക്കോട് റെയിൽവേ ട്രാക്കിൽ അവൻ്റെ തല വേർതിരിക്കുകയാണ്. അന്ന് എനിക്ക് അവനെ അഡ്രസ്സ് ചെയ്യാൻ അറിയില്ലായിരുന്നു. അവൻ എല്ലാവരോടും കാട്ടിക്കൂട്ടി ഇത് കണ്ടപ്പോൾ അത് മനസ്സിലാക്കാൻ ടീച്ചേഴ്സിന് പറ്റാതെ പോയി, കൂട്ടുകാർക്ക് പറ്റാതെ പോയി, അവൻ്റെ വീട്ടുകാർക്ക് പറ്റാതെ പോയി. അന്ന് ആരെങ്കിലും ഒരാൾ അവനെ അഡ്രസ്സ് ചെയ്തിരുന്നെങ്കിൽ, അവൻ്റെ പ്രശ്നം ചോദിച്ചിരുന്നെങ്കിൽ, നീ എന്താണ് ഇങ്ങനെ പറഞ്ഞതെന്ന് പറഞ്ഞാൽ ഞാൻ കൂട്ടിക്കൊണ്ടേ പിടിച്ചിരുന്നെങ്കിൽ ചിലപ്പോൾ ഇന്നും എൻ്റെ സുഹൃത്ത് ജീവിച്ചിരിക്കുമായിരുന്നു. ആ തിരിച്ചറിവുകൾ ഉള്ളതുകൊണ്ട് ചിലപ്പം പോലീസിൽ വന്നപ്പോൾ എന്നെപ്പോലെ കുറച്ച് ആൾക്കാർക്ക് അതൊക്കെ ചെയ്യാൻ പറ്റും തോന്നുന്നു. നമ്മളിതിൽ നന്നായി വർക്ക് ചെയ്യുന്ന കുറേ ആളുകളുണ്ട്. ഒരുപാട് വർക്കിൻ്റെ ഇടയിലും ഇത്ര ചെയ്യുമ്പോൾ ഞങ്ങൾക്ക് ഓരോ 174 ഒരു അൺനാച്ചുറൽ ഡെത്തും ഞങ്ങൾക്ക് ദുഃഖം തരുന്നതാണ്. അതിന് പിന്നാലെ അന്വേഷിച്ച് പോകുമ്പോൾ എല്ലാത്തിനും ഒരു കഥയുണ്ട്. ഇതിൽ ഭൂരിപക്ഷം കഥകളും നമുക്ക് അഡ്ജസ്റ്റ് ചെയ്യാൻ പറ്റുന്നതായിരുന്നു. 5744 രൂപയ്ക്ക് ലോൺ എടുത്തിട്ടാണ് ഇപ്പോൾ ആൾക്കാർ മരിക്കുന്നത്. 5714 rupees only the liability. Online loan is liability. Online loan is liability only 5714 rupees. പക്ഷേ അയാളുടെ അസറ്റോ എത്രയോ അസറ്റ് അവനുണ്ട് എടുത്ത് ചെയ്യാവുന്നേ ഉള്ളൂ. പക്ഷേ ഇതിലൂടെ അവന് ഉണ്ടാകുന്ന കെണികൾ. അപ്പോൾ ഇത്തരം സാധനങ്ങളിൽ നമുക്ക് പോലീസിനും ഒരു നല്ലൊരു റോൾ ചെയ്യാൻ വേണ്ടി പറ്റും. ഇതിന് നമുക്ക് ചെയ്യാൻ പറ്റുന്ന ഒരു കാര്യം കൂടി പറഞ്ഞ് ഞാൻ കൺക്ലൂഡ് ചെയ്യാം. ഞങ്ങൾ ചെയ്തൊരു കാര്യം, we introduced child friendly policing in all police station. In Kerala we are introduced child friendly policing. We given training to the policemen, child friendly policing training. Child friendly police training കിട്ടിയപ്പോൾ അതിലൊരു പോലീസുകാരൻ അടുത്ത ദിവസം കാക്കൂർ സ്റ്റേഷനിലുണ്ടായിരുന്നൊരു സംഭവം, ഒരു പോക്സോ വിക്ടിം coming to the police station with his family. After recording the statement, and പോകുമ്പോൾ that policeman knows that something different. ആ കുട്ടി ചിലപ്പോൾ എന്തെങ്കിലും സൂയിസൈഡ് ചെയ്യുമോ എന്ന് ഇയാൾ തോന്നലുണ്ടായി. ചൈൽഡ് ഫ്രണ്ട്ലെസ് ട്രെയിനിങ് കിട്ടിയതുകൊണ്ട് അയാൾ ആ കുട്ടിയോട് ചോദിക്കുന്നു, നമ്മളെന്താ ധൈര്യത്തിൽ നിൽക്കണ്ടേ എന്ന് പറഞ്ഞ് ഒരു വനിതാ പോലീസിൻ്റെ given the help of women police constable, and women police constable 10 minutes spent for hearing, listening her problem. Then last, that student says that if the ma'am not listening me, sure this night I may be suicidal. രാവിലെ തന്നെ നമ്മൾ എന്ത് ചെയ്തു, ഒരു കൗൺസിലർ അടുത്തേക്ക് അയച്ചു, ബാക്കി കാര്യങ്ങൾ ചെയ്തു കൊണ്ടുവരാൻ പറ്റി. അപ്പോൾ ട്രെയിനിങ് കിട്ടിയാൽ കുറേ കാര്യം മാറ്റിയെടുക്കാൻ വേണ്ടി പറ്റും. അപ്പോൾ നമുക്ക് പ്രോബ്ലം പറയുന്നതിനേക്കാളേറെ സൊല്യൂഷൻ ഓറിയൻറ്റഡ് ആയിട്ടുള്ള ചർച്ചകളിലൂടെ നമുക്ക് പോയി കഴിഞ്ഞാൽ, സൊല്യൂഷൻ എന്തെന്നുള്ള ചർച്ചകളിലൂടെ പോയി കഴിഞ്ഞാൽ, നമ്മൾ ഈ ചിരിയെ 4 ടയറായിട്ട് ഡോക്ടർ സുരേഷ് കുമാർ സാറൊക്കെ ഭാഗമാണ്, 4 ടയറായിട്ടാണ് നമ്മൾ ചെയ്യുന്നത്. ഏറ്റവും സാധാരണ പ്രോബ്ലത്തെ നമ്മൾ സാധാരണ അവിടെ സംസാരിച്ച് തീർക്കും. ദെന്ന് മെൻറ്റർ വേണ്ടതിന് മെൻറ്റർ ഇഷ്യൂ ചെയ്യും. അത് കഴിഞ്ഞ് സൈക്കോളജി വേണ്ടി സൈക്കോളജി ഇൻ്റർവെൻഷൻ കൊടുക്കും. സൈക്കാട്രി വേണ്ടെന്ന് അങ്ങോട്ടേക്ക് ഡീൽ 4 ടയറിൽ കൊടുക്കും. ഇത് പോരാതെ നമുക്ക് പിയർ ഗ്രൂപ്പ് ഇൻ്റർവെൻഷൻ ഉണ്ടാവും. ചില ഇഷ്യൂസ് കൂട്ടുകാരികൾ പറഞ്ഞു തരും, നിന്നേക്കാൾ വലിയ പ്രശ്നം അനുഭവിച്ചു കളഞ്ഞാൽ ഞാനിപ്പോൾ ഇങ്ങനെ നിൽക്കുന്നില്ലേ എന്നൊരാൾ പറയുമ്പോൾ മാറാൻ പറ്റും. അപ്പോൾ ഇത്തരത്തിലൊരു സോഷ്യൽ ഗ്രൂപ്പിന് സൊസൈറ്റിക്ക് തന്നെയാണ് സൊസൈറ്റിയുടെ വൂണ്ട് ഉണക്കാൻ വേണ്ടി പറ്റുക. സൊസൈറ്റിക്ക് തന്നെയാണ് സൊസൈറ്റിയുടെ വൂണ്ട് ഉണക്കാൻ പറ്റുക എന്നുള്ളത് വെച്ചുകൊണ്ട് ഞാൻ കൺക്ലൂഡ് ചെയ്തെടുത്തേ. താങ്ക് യു.
Thank you, Umesh. So he has given a very interesting perspective. Some of his experience in running a helpline by the police was shared with a huge number of calls, 52,000 calls, and he has given the details of that. But the most striking thing was his childhood experience, and when a friend committed suicide, he indirectly communicated the suicidal intent, but as a student and as he was not able to do anything, and that is one thing which made him interested. So I'm sure this is something which can be generalized to a lot of situations. And another social experiment they did was giving a poster, putting posters in a locality saying that if you are interested to commit suicide, there are easy ways and you call this number. And so a lot of people called, and these people were later counselors were engaged to talk to these people, and many of them really had. So what he says is that majority of the people just ignored this ad that suicide is easy or something like that. But those who had problems were specifically took note of this and called into that number. So that is one way of getting the vulnerable people in the society. But I am sure this can be done only by the police. If somebody else does this, they will be beaten up by the public. That is definitely going to happen. Police doing this, nobody will ask anything because they can do that. But if a mental health professional or psychiatric society puts up a notice saying that if there is easy way to commit suicide, I am sure we will be taken to task or even to the court. So I am passing on to our next panelist, Krishna Kumar. He is an eminent media person working in the Madhubhumi periodical and their health magazine section. So I think he also will contribute his experience and share views on this particular aspect.
താങ്ക് യു ഡോക്ടർ. എല്ലാവരും സമൂഹത്തിലെ പ്രശ്നമുള്ള ഏരിയകളെ ഫോക്കസ് ചെയ്തിട്ടാണ് സംസാരിച്ചത്. അതുകൊണ്ട് ഞാൻ സമൂഹത്തെ മൊത്തത്തിൽ ഒന്ന് ഫോക്കസ് ചെയ്യാമെന്ന് വിചാരിക്കുന്നു. കാരണം എന്ന് വെച്ചാൽ സമൂഹത്തെ നമ്മൾ അറിയണം. പൂർണ്ണമായിട്ടും സമൂഹത്തെ അറിഞ്ഞെങ്കിൽ മാത്രമേ ഈ പ്രശ്നങ്ങളിലേക്ക് നമുക്ക് കുറച്ചുകൂടെ ഇതായിട്ട് വരാൻ പറ്റും. സമൂഹത്തെ അറിയുന്നതിന് നമ്മുടെ ലോകത്തെ എല്ലാ സ്ഥലത്തും പല സ്റ്റഡികളും നടന്നിട്ടുണ്ട്. അതൊക്കെ ഭയങ്കര എക്സ്പെൻസീവാണ്. പക്ഷേ ഏറ്റവും എളുപ്പത്തിൽ ഇതുപോലെ പറഞ്ഞിട്ടുള്ള കാര്യമാണ്, ഒരു സമൂഹത്തെ അറിയാനായിട്ട് ഏറ്റവും എളുപ്പമാർഗം എന്ന് പറയുന്നത് റോഡിലേക്ക് നോക്കുക എന്നുള്ളതാണ്. ഒരു റോഡിൽ ട്രാഫിക് എങ്ങനെയുണ്ട് എന്ന് അറിഞ്ഞാൽ ആ സമൂഹത്തിൻ്റെ സംസ്കാരം അത് ഏറെക്കുറെ, അത് ഈ സയൻറ്റിഫിക് ആണോ എന്നുള്ളത് വേറെ കാര്യം, പക്ഷേ ഏറെക്കുറെ നമുക്ക് ആവശ്യമുള്ള ഡേറ്റ കിട്ടും. നമ്മൾ കേരളത്തിൻ്റെ കാര്യം തന്നെ എടുത്തു നോക്കിക്കോളൂ. ഒരാൾ നിയമം പാലിക്കുന്ന ഒരാൾ നമ്മുടെ കേരളത്തിലെ റോഡിലൂടെ ഇവിടുന്ന് തിരുവനന്തപുരം വരെ വണ്ടി ഓടിക്കുകയാണെങ്കിൽ ഉറപ്പാണ് അയാളെ ഹോസ്പിറ്റലിൽ അഡ്മിറ്റ് ചെയ്യേണ്ടി വരും. കാരണം അതായത് നമ്മൾ ഈ പറയുന്നത് മുഴുവൻ തെറ്റുത്തരവ് എഴുതിയിട്ട് നമ്മൾ തെറ്റ് വാങ്ങിക്കുന്ന ആളുകളെ കുറിച്ചിട്ടാണ് നമ്മളിപ്പോൾ ഈ പറയുന്നത്. പക്ഷേ ഇപ്പോൾ ഞാൻ ഈ പറയുന്ന സാധനം എന്ന് പറഞ്ഞാൽ ശരി ഉത്തരവ് എഴുതിയിട്ട് തെറ്റ് വാങ്ങിക്കുന്ന ആളുകളാണ്. എനിക്ക് ഉറപ്പായിട്ട് നിയമം പാലിച്ചേ വണ്ടി ഓടിക്കുകയുള്ളൂ എന്ന് പറഞ്ഞ് ഞാൻ ഇറങ്ങുകയാണെങ്കിൽ 5ാമത്തെ മിനിറ്റിൽ എന്നെ ഒരുത്തം ചീത്ത വിളിച്ചിരിക്കും, ഉറപ്പാണ്. കാരണം ഇന്ത്യയുടെ നീതി നിൽക്കുന്ന അവിടെ സീബ്ര ക്രോസോ കടക്ക് എന്ന് പറഞ്ഞിട്ട് നമ്മളെ പുറകിക്കുന്നവൻ ചീത്ത വിളിക്കും. ഇതാണ് നമ്മൾ ഏറ്റവും ആദ്യം നമ്മൾ ഫേസ് ചെയ്യുന്ന പ്രശ്നം. ഇതാണ് നമ്മുടെ സമൂഹത്തിൻ്റെ ക്രോസ് സെക്ഷൻ. ഇതാണ് നമ്മളിത് റോഡിലെ കാര്യം പറയുമ്പോൾ നമ്മളൊക്കെ ഇതിൻ്റെ ഭാഗമാണ്, നമ്മൾ തിരിച്ചറിയുന്നില്ല എന്നുള്ളതേ ഉള്ളൂ. നമ്മൾ ഓരോരുത്തരും, കാരണം എന്ന് വെച്ചാൽ ഞാൻ വണ്ടി ഓടിക്കുമ്പോൾ ഞാൻ ഇടതുവശത്ത് കൂടി കയറി പോകാനായിട്ട് ഒരു സാധനം ഉണ്ടെങ്കിൽ ഞാൻ അതുവഴി പോകും. പക്ഷേ അത് ഞാൻ എൻ്റെ ഒരു ബോധത്തിൽ വരുന്നില്ല ഞാൻ ചെയ്യുന്നത് തെറ്റാണെന്ന്. കാരണം എന്തറിയോ, കൂടുതൽ നമ്മൾ തെറ്റ് തെറ്റേതാണ് ശരി ഏതാണെന്ന് പറയാം. ഈ സെയിം ഇതിൻ്റെ ഒരു ബിഗർ വെർഷനാണ് നമ്മളുടെ മുഴുവൻ സമൂഹത്തിലും കാണപ്പെടുന്നത്. ഉറപ്പായിട്ടും അങ്ങനെ തന്നെയാണ് നമ്മൾ എല്ലാ സാധനത്തിലും. നമുക്കെന്താ വെച്ചാൽ പ്രത്യേകിച്ച് കേരളത്തിൻ്റെ സമൂഹത്തിൽ നമുക്ക്, ഞാൻ കേരളം എന്ന് പറയുന്നത് നമ്മൾ വേറിട്ടുള്ള ഒരു പെർസ്പെക്റ്റീവിലാണ് നിൽക്കുന്നത്. നമ്മൾ എല്ലാ കാര്യത്തിലും കുറച്ച് മേലെയാണെന്ന് നമ്മൾ അറിഞ്ഞോ അറിയാതെയോ കുറച്ചൊന്നിങ്ങനെ പറയുന്നുണ്ട് അല്ലെങ്കിൽ മനസ്സിലാക്കുന്നുണ്ട് എന്ന് എനിക്ക് തോന്നുന്നു. കാരണം എല്ലാ സമയത്തും ഇത് നമ്മൾ ഒരു ചെറിയ കുട്ടിയുടെ ഇപ്പോൾ ഈ സൂയിസൈഡൽ അറ്റംപ്റ്റ് ഉള്ള ആളുകളിൽ മാത്രമല്ല, ബാക്കി എല്ലാ ആളുകളിലും. ഇപ്പോൾ ഞാനൊരിക്കൽ എൻ്റെ വൈഫിൻ്റെ ഒരു പേപ്പർ കൊടുക്കാൻ വേണ്ടിയിട്ട് ഒരു ഇതിൽ പോയി, ഇവിടെ ഫ്ലാറ്റിൽ പോയി. അപ്പോൾ അതിൻ്റെ 5ാമത്തെ നിലയിലോ 6ാമത്തെ നിലയിലോ അവിടെ ചെന്ന് അത് കൊടുത്തു. അവിടുത്തെ കുട്ടി ഇപ്പോൾ സാധാരണഗതിയിൽ കുട്ടികൾ ചെയ്യുന്ന പോലെ ആ കുട്ടി വളരെ കൗതുകത്തോട് വണ്ടിയിലാണോ വന്നതെന്ന് ചോദിച്ചു. ഞാൻ പറഞ്ഞു അതെ. അപ്പോൾ ഇവൻ ഒരു ബനീനൊക്കെ ഇട്ട് ഇറങ്ങി താഴെ വന്നു, 5-6 നില ഇറങ്ങി താഴെ വന്നു. താഴെ വന്ന് എൻ്റെ വണ്ടി നോക്കിയ ഉടനെ ഇവൻ്റെ ആദ്യത്തെ മറുപടി അയ്യേ ആൾട്ടോ ആണോ എന്ന്. ഇതെന്താ വെച്ചാൽ ഈ നമ്മളൊരു കാർ ഉപയോഗിക്കുമ്പോൾ കാറിൻ്റെ ഉപയോഗമോ കാറിന് നമുക്ക് എത്ര പൈസ മുടക്കണമെന്നോ എന്നുള്ള കാര്യത്തെ എല്ലാം മാറ്റിക്കൊണ്ട് ഒരു ബ്രാൻഡ് നെയിമാണ് അതിൻ്റെ മുൻപിലേക്ക് വരുന്നത്. ഇന്നത് ഉപയോഗിക്കണം അല്ലെങ്കിൽ ഇന്നത് വേണം. ഇത് ഒരു കുട്ടിയുടെ കാര്യത്തിൽ മാത്രമല്ല, നമ്മളൊരു വീടുണ്ടാക്കുമ്പോൾ കേരളത്തിൽ ഒരാൾ നോക്കിക്കോളൂ, അത് വേണമെങ്കിൽ സയൻറ്റിഫിക് ആയിട്ടുള്ള പഠനം നടത്തി നോക്കിക്കോളൂ. ഒരാൾ ഒരു വീടുണ്ടാക്കുമ്പോൾ അവർ ചേർന്നിരുന്ന് ആ തീരുമാനം എടുക്കുമ്പോൾ നമുക്കൊരു സാധനം ഇവിടെ വെക്കാനൊരു തട്ട് വേണം, അല്ലെങ്കിൽ ഒരു സാധനം ഇവിടെ വെക്കാനുള്ള ഒരു കാര്യം വേണം എന്നുള്ളതിനേക്കാട്ടിലധികം നമ്മൾ വല്ലപ്പോഴും ഒരിക്കലും ഒരാൾ ഈ വീട്ടിലേക്ക് വരുമ്പോൾ ഈ വീട് നല്ലതാണ് എന്ന് പറയാനുള്ള ഫെസിലിറ്റിയെ കുറിച്ചിട്ടാണ് ഏറ്റവും കൂടുതൽ ചിന്തിക്കുന്നതെന്നാണ് ഞാൻ മനസ്സിലാക്കുന്നത്. അത് ഞാൻ പലരോട് സംസാരിച്ചപ്പോഴും അങ്ങനെയാണ്. ഇതുകൊണ്ട് ആവശ്യമില്ല. കാരണം പക്ഷേ അടുത്ത് കുറച്ചൊരു മാറ്റം വന്നിട്ടുണ്ട്. പണ്ട് നമ്മൾ ഷോവാൾ എന്ന് പറഞ്ഞിട്ട് സാധനം ഉണ്ടാക്കുക, അതിന് വേണ്ടിയിട്ടായിരുന്നു ഭയങ്കര. പക്ഷേ ഇപ്പോൾ അടുത്തതില്ല. ഇപ്പോൾ കുറച്ചുകൂടെ നമുക്കൊരു മാറ്റം വന്നിട്ടുണ്ട്. ഇതാണ് ശരിക്കും നമ്മളുടെ ഒരു സാമൂഹികമായൊരവസ്ഥ. ഇതാണ് ഈ അവസ്ഥയിൽ നിന്നുകൊണ്ടാണ് നമ്മൾ ഈ പ്രശ്നങ്ങളെ ശരിക്കും അഭിസംബോധന ചെയ്യുന്നത്. ഇത് എല്ലാ മേഖലയിലും. ഞാൻ തിരുവനന്തപുരത്ത് ഇതുപോലെ ഒരു വൈവ സെമിനാറിന് പോയപ്പോൾ വളരെ പർട്ടിക്കുലറായിട്ടുള്ള ഒരു സബ്ജക്റ്റാണ് ഒരു ലേഡിയാണ്, ഞാൻ ആ പേര് പറയുന്നില്ല, അവർ നടത്തിയെന്ന് വെച്ചാൽ നമ്മുടെ തെറി വാക്കുകളെ കുറിച്ചിട്ടുള്ള പഠനമാണ്. അപ്പോൾ അവർ അത് അവതരിപ്പിക്കുന്ന സമയത്ത്, വൈവയിൽ അവതരിപ്പിക്കുന്ന സമയത്ത് ആ ടീച്ചർ പറയുന്നതെന്ന് വെച്ചാൽ എനിക്ക് തമിഴ്നാട്ടിലൊക്കെ പോയിട്ട് ഭയങ്കര ബുദ്ധിമുട്ടാണ്. കാരണം എന്ന് വെച്ചാൽ ഈ ആളുകളെ ചെന്ന് കാണുമ്പോൾ അവരൊന്നും ആ തെറി വാക്ക് പറയുന്നില്ല. അവർക്കൊക്കെ ഭയങ്കര ഷൈനസ്സാണ്, അത് പുറത്തേക്ക് പറയാനുള്ള. നമ്മളുടെ സമൂഹം മാറണ്ടേ ഇത്. അപ്പോൾ കേരളത്തിലെ ഏറ്റവും അറിയപ്പെടുന്ന അക്കാഡമിഷ്യനായ NR ഗോപിനാഥുള്ള സാർ അവിടെ ഉണ്ടായിരുന്നു. സാറ് ചോദിച്ചു, ടീച്ചർ ഒരു കാര്യം ചെയ്യൂ, ടീച്ചറെ കേട്ടതിൽ വെച്ചിട്ട് ഏറ്റവും മുഴുത്ത, അങ്ങനെ ആ വാക്ക് തന്നെയാണ് സാർ പറഞ്ഞത്, ഏറ്റവും മുഴുത്ത ഒരു 5-6 തെറി ഒന്ന് ടീച്ചർ ഇവിടെ പറയൂ, നമ്മൾ കേൾക്കട്ടെ എന്ന് പറഞ്ഞു. അപ്പോൾ ടീച്ചർ പറഞ്ഞു, അല്ല സാർ അതിപ്പോൾ ഞാനിവിടെ എങ്ങനെ പറയാ എന്നൊക്കെ പറഞ്ഞിട്ട് പറയാൻ. അപ്പോൾ സാർ ഇതല്ലേ ടീച്ചറെ, ടീച്ചർ അക്കാഡമിക്കായിട്ട് ഇത് പഠനം നടത്തുന്ന ടീച്ചർക്ക് ഇവിടെ പറയാൻ പറ്റുന്നില്ല. ഇതല്ലേ ടീച്ചർ അവർ ചെയ്യുന്നില്ല എന്ന് പറയുന്നത്. അപ്പോൾ അതിലെന്താ കാര്യമുള്ളത്? ഇതേ അവസ്ഥ തന്നെയാണ് നമ്മുടെ കുട്ടികൾക്കായാലും നമ്മുടെ ആളുകൾക്കായാലും. അവർക്ക് നമ്മളോട്, കാരണം ഈ ആത്മഹത്യ എന്ന വാക്ക് തന്നെ ശരിക്കും പറഞ്ഞാൽ അത് ലാസ്റ്റ് ഡ്രോപ്പിൽ സംഭവിക്കുന്ന സാധനമാണ്. അകത്തൊരു ഗ്ലാസ്സിൽ ഇങ്ങനെ നിറഞ്ഞ് വന്നത്. പക്ഷേ ഈ ഗ്ലാസ് നിറയാനായിട്ട് നമ്മൾ വീട്ടിൽ നിന്ന് ഇറങ്ങുമ്പോൾ റോഡിൽ കുഴി കാണുമ്പോൾ ഉണ്ടാകുന്ന സാധനം കുറച്ചായിട്ട് നിറഞ്ഞു. ബസ്സിൽ കയറുമ്പോൾ ബസ്സിനകത്ത് തൂങ്ങിപ്പിടിച്ച് പിന്നെ നമ്മൾ ഫുട്ബോളിൽ നിൽക്കുന്ന ആളും സെയിം ടിക്കറ്റാണ് എടുക്കുന്നത്. അവനെ പിടിച്ചാലും ഇതേ പിഴ കൊടുക്കണം. അപ്പോൾ അവൻ്റെ മനസ്സിലുണ്ടാകുന്ന ഒരു സാധനമുണ്ട്, അതും അതിനകത്ത് നിറയാണ്. നമ്മൾ അവസാനം കാണുന്നതെന്ന് വെച്ചാൽ ഈ നിറഞ്ഞു നിൽക്കുന്ന ഗ്ലാസ്സിലെ ലാസ്റ്റ് ഡ്രോപ്പിനെയാണ് നമ്മൾ അഡ്രസ്സ് ചെയ്യുന്നത്. പക്ഷേ സമൂഹത്തെ അഡ്രസ്സ് ചെയ്യുമ്പോൾ ശരിക്കും ഈ ഒരു ഘട്ടത്തിലേക്ക് നമ്മളെ എത്തിക്കുന്നത്. അതെ, ഒരു പ്രധാനപ്പെട്ട നമ്മുടെ, എനിക്ക് തോന്നുന്നു കേരളത്തിൽ ഈ ഇത്തരം കാര്യങ്ങളിൽ ബേസിക്കായിട്ട് വന്നിരിക്കുന്ന ഒരു കാര്യം എന്ന് വെച്ചാൽ പലപ്പോഴും നമ്മൾ നേരിട്ടൊരു കാര്യം പറയാനായിട്ട്, എനിക്കിപ്പോൾ ഒരു കാര്യം ഒരാളോട് പറയണമെങ്കിൽ, ഇപ്പോൾ ഒരാൾ ഹോസ്പിറ്റലിൽ പോവുകയാണെങ്കിൽ നമ്മൾ നോക്കുകയുള്ളൂ, നമ്മളുടെ എല്ലാ നാട്ടുമ്പുറങ്ങളിലല്ല, ഇപ്പോൾ നഗരങ്ങളിലെ വീട്ടിൽ പോലും ഒരാൾ ഹോസ്പിറ്റലിലേക്ക് പോവുകയാണെങ്കിൽ ഹോസ്പിറ്റലിലേക്ക് അയാൾ എത്തിക്കഴിഞ്ഞ് കഴിഞ്ഞാൽ വീട്ടിൽ പ്രായമായവരുണ്ടെങ്കിൽ, അങ്ങനെയുള്ള ആളുകളുണ്ടെങ്കിൽ ഒരു 90% അവരോട് നമ്മൾ ഈ കാര്യം കമ്മ്യൂണിക്കേറ്റ് ചെയ്യില്ല. എന്താ പറ്റി? ഒന്നുമില്ല, ഒരു കുഴപ്പമില്ല. ഒരാൾക്കൊരു സർജറി നടത്തി ഒരാഴ്ച നിർത്തിയാൽ അന്നേരം നമ്മൾ പറയുന്നത് വെച്ചാൽ അവനെ ഒരു സ്ഥലത്ത് പോയിരിക്കുകയാണ്, അങ്ങനെ നമുക്ക് മറച്ചു വെക്കുന്ന ഒരു സ്വഭാവമുണ്ട്. അങ്ങനെ ആ ഒരു കാര്യം നേരിട്ട് അയാൾ ഹോസ്പിറ്റലിൽ പോയി, അയാളുടെ കാലിന് പൊട്ടലുണ്ട്, അത് പിന്നെ പ്ലാസ്റ്റർ ഇട്ടു എന്ന് പറഞ്ഞാൽ തീരുന്ന ഒരു പ്രശ്നത്തെ അൺനെസസറി ആയിട്ട് നമ്മളത് മാറ്റി മറിച്ച് ഇതിലൂടെ സംഭവിക്കുന്നത് എന്താണെന്ന് വെച്ചാൽ ഈ ഒരു ആളുകളുടെ ഡയറക്റ്റായിട്ട് പറയുന്ന കാര്യത്തെ വിശ്വസിക്കാനുള്ള ആ ഒരു കപ്പാസിറ്റി കുറഞ്ഞു വരും. പിന്നെ പോയിട്ട് ഒന്നും പറ്റിയില്ല എന്ന് പറഞ്ഞാലും ഇവർക്ക് സംശയമാണ്. നമ്മുടെ നാട്ടുമ്പുറത്തിൽ എല്ലാ സ്ഥലത്തും ഞാൻ എൻ്റെ വീട്ടിലത് നേരിട്ട് അനുഭവിച്ച ആളാണ്. കാരണം എൻ്റെ അമ്മ മരിച്ചിട്ട് 8 വർഷത്തോളം കാലം എൻ്റെ അമ്മയുടെ ചേച്ചിക്ക് അമ്മ മരിച്ചുപോയി എന്നറിയില്ലായിരുന്നു. അവരിങ്ങനെ ഭരിച്ചുകൊണ്ടിരിക്കുകയാണ്. അവർക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും കാണാനുള്ള ഒരു സാഹചര്യം ഇല്ല, അവർക്ക് ആ മൊബിലിറ്റി പ്രശ്നങ്ങളൊക്കെ ഉണ്ടായിരുന്നുകൊണ്ട് അത് സാധ്യമായി. പക്ഷേ ഇത് ഉണ്ടാക്കുന്ന ഇമ്പാക്റ്റ് ഭയങ്കരമാണ്. കാരണം ഒരാളെയും വിശ്വാസമില്ല. ഒരു പലപ്പോഴും ഈ പല സ്ഥലങ്ങളിലും നമ്മൾ ഈ സോഷ്യൽ വർക്കേഴ്സ് ഇടപെടുന്നതിനെക്കാട്ടിൽ നന്നായിട്ട് സ്കൂളുകളിൽ അധ്യാപകർ ഇടപെടുന്നുണ്ട്. അവർ ഉണ്ടാക്കുന്ന ഒരു ഇമ്പാക്റ്റ് ഭയങ്കര. പലപ്പോഴും ഈ കേസുകൾ ഐഡൻറ്റിഫൈ ചെയ്യുന്നതും ഇവിടേക്ക് എത്തിക്കുന്നതിലും അധ്യാപകർക്ക്. ഈ നമ്മൾ വിജയ് സാറിൻ്റെയൊക്കെ ഇതിൽ വർക്ക് ചെയ്തിരുന്ന സമയത്ത് ഒരു പ്രോജക്റ്റുമായിട്ട് ബന്ധപ്പെട്ടിട്ട് സീഡ് എന്ന് പറഞ്ഞാൽ നമുക്കൊരു പ്രോജക്റ്റ് ഉണ്ട്. അപ്പോൾ ആ പ്രോജക്റ്റുമായി ബന്ധപ്പെട്ടിട്ട് ഇപ്പോഴും നമ്മളത് വർക്ക് ചെയ്യുന്നുണ്ട്. അപ്പോൾ ഈ കുട്ടികൾ പറയുന്നതാണ്, നമ്മൾ പറയുന്നത് കേൾക്കാൻ ആളില്ല, ഞങ്ങൾ പറയുന്നത് കേൾക്കാൻ. നമ്മൾ ഓഫീസ് വിട്ട് വീട്ടിൽ ചെന്നാലും നമുക്ക് വേറെ ജോലികളുണ്ടാകും, അവരെ ഒരു 5 മിനിറ്റ് പോലും കേൾക്കാൻ നമുക്ക് ഇതില്ല. നമ്മൾ പിന്നെ കാർട്ടൂൺ കണ്ടാൽ കുട്ടികൾക്ക് ഇത് വ്യത്യാസം ഉണ്ടാകുന്നു എന്ന് പറഞ്ഞിട്ട് അത് ഓഫ് ചെയ്യുമ്പോൾ അതിനെക്കാട്ടിൽ 10 ഇരട്ടി സ്റ്റഡീസ് ഉണ്ട് കാർട്ടൂൺ കണ്ടാൽ ഗുണമാകുമെന്ന് പറയുന്ന സാധനം ഉണ്ട്. അത് നമുക്ക് നമ്മളുടെ ആവശ്യമുള്ള സാധനങ്ങൾ മാത്രം. അപ്പോൾ ആ കുട്ടി എങ്ങനെയാവുന്നു, എങ്ങനെ നമ്മൾ ഈ റോഡിൻ്റെ കാര്യം തന്നെ പറയാം. റോഡിൽ പോകുന്ന ആളുകൾക്ക്, ഹെൽമറ്റ് വെക്കാത്ത ആളുകൾക്ക് ഈ ഹെൽമറ്റ് വെക്കണം എന്ന് പറഞ്ഞിട്ടൊരു നോട്ടീസ് കൊടുക്കുകയും അല്ലാത്തവർക്ക് ഹെൽമറ്റ് വെച്ചവർക്ക് ഒരു മുട്ടായി കൊടുക്കുകയൊക്കെ ചെയ്തു. അപ്പോൾ നമ്മളോട് പലരും ചോദിച്ചിട്ടുണ്ട്, വിജയൻ സാറുമായിട്ട് ഞാൻ സംസാരിച്ചിട്ടുണ്ട്. അപ്പോൾ പലരും ചോദിച്ചിട്ടുണ്ട്, എന്തിനാ നിങ്ങൾ ഈ പിള്ളേരെ ചെയ്യുന്നത്? യുവമാരൊന്നും ഒരിക്കലും വെക്കാൻ പോകുന്നില്ല, അവർക്കറിയാം ഇത് ഹെൽമറ്റ് വെച്ചില്ലെങ്കിൽ ഇങ്ങനെയാണ്, അല്ലെങ്കിൽ ഇതിടണം, അല്ലെങ്കിൽ സീറ്റ് ബെൽറ്റ് ഇടണം എന്നുള്ളത് അവരിൽ നിന്നും വിട്ടുപോകുന്ന. പിന്നെ എന്തിനാ നിങ്ങൾ ഈ പിള്ളേരെ കൊണ്ട്? പക്ഷേ നമ്മൾ അതിന് വേണ്ടിയിട്ടല്ല ഇത് ചെയ്തത്. അവർ വെക്കില്ലെന്ന് നമുക്കും അറിയാം. പക്ഷേ ഈ മുട്ടായി കൊടുക്കുന്ന അല്ലെങ്കിൽ നോട്ടീസ് കൊടുക്കുന്ന കുട്ടി വളർന്നു വരുമ്പോൾ അവനത് വെക്കും. അപ്പം ഗ്രാസ് റൂട്ട് ലെവലിൽ നമ്മൾ ആ സോഷ്യലായിട്ടുള്ള ഒരു കൾച്ചർ നമ്മൾ പതുക്കെ വളർത്തിക്കൊണ്ട് വരികയാണെങ്കിൽ നമ്മൾ ഈ അഡ്രസ്സ് ചെയ്യുന്ന ഇഷ്യൂ പതുക്കെ ചെറുതായി വരും. ഇതാണ് ശരിക്കും നമ്മൾ, അതായത് ടോട്ടൽ ആയിട്ട് നമ്മൾ ആ സമൂഹത്തെ കണ്ടിട്ട് ആ സമൂഹത്തിൽ ഈ ഒരു കാര്യങ്ങളുണ്ട്, ഏറ്റവും പ്രധാനപ്പെട്ട ഒരു കാര്യങ്ങളുണ്ട്. ഇവരെന്താ വെച്ചാൽ, ഞാൻ എൻ്റെ ഡയറക്റ്റ് എക്സ്പീരിയൻസിൽ മനസ്സിലാക്കിയ ഒരു കാര്യം, എല്ലാ സ്കൂളുകളിലും അല്ലെങ്കിൽ ഇനി വരുന്ന കുട്ടികളോട് ചോദിച്ചു നോക്കുമോ, അവരെ അടക്കിയിരുത്തുന്നതിൽ ഇവർ പറയുന്ന, അധ്യാപകർ പറയുന്ന ഒരു കാര്യം, നിങ്ങളുടെ PT കട്ട് ചെയ്യുമെന്ന്. എല്ലാ സ്കൂളുകളിലും, അതായത് കേരളത്തിൽ ഇങ്ങേയറ്റം മുതൽ അങ്ങേയറ്റം വരെ എല്ലാ സ്കൂളുകളിലും. അതിൽ നിന്ന് നമ്മൾക്ക് മനസ്സിലാക്കേണ്ടത് ഇവരുടെ ആ ഗ്രൂപ്പ് ആക്ടിവിറ്റി എത്രത്തോളം കുറഞ്ഞു പോയിട്ടുണ്ട്. നമ്മൾ ജയിക്കാൻ മാത്രമാണ് ഈ കുട്ടികളെ പഠിപ്പിക്കുന്നത്, ജയിക്കാൻ മാത്രം പഠിപ്പിക്കുന്ന കുട്ടികൾ. പക്ഷേ കളി ഉണ്ടായിരുന്നെങ്കിൽ, അവർ 10 പേര് ഒരുമിച്ച് കളിച്ചിരുന്നെങ്കിൽ അവർക്ക് മനസ്സിലായേനെ ഇത് തോക്കാനും കൂടിയാണ്. ഒരു ദിവസം ഉണ്ടെങ്കിൽ അതിൽ 80% സമയം തോക്കുകയാണ്, 20% സമയം ജയിക്കുള്ളൂ എന്ന്. പക്ഷേ നമ്മൾ ആ കളി അവരിൽ നിന്ന് ഒഴിവാക്കി കളഞ്ഞു. ശരിക്കും പറഞ്ഞാൽ അത് ക്രിമിനൽ കുറ്റമാണ്. ശരിക്കും ഒരു ക്രിമിനൽ കുറ്റമാണ്. അത് അവർക്ക് കളിക്കാൻ, ഒരുമിച്ച് കളിക്കാൻ, അതെടുത്ത് മാറ്റിയിട്ടാണ് നമുക്ക് ഇവർ പ്രശ്നങ്ങളിൽ പെടുമ്പോൾ നമ്മൾ കൗൺസിലിങ്, അതായത് നമ്മൾ പണ്ട് ചെയ്തിരുന്ന ഒരു കാര്യമുണ്ട്, ടാപ്പടയ്ക്കണം, അത് ചെയ്യണം, ഇത് ചെയ്യണം എന്നൊക്കെ പറഞ്ഞ് വാട്ടർ കൺസർവേഷന് വേണ്ടിയിട്ട് പറയുന്നു. പക്ഷെ അതൊക്കെ ഇപ്പോൾ നമ്മൾ ഒഴിവാക്കി. നമ്മളിപ്പോൾ പറയുന്നത് നമ്മളുടെ ഗ്രൗണ്ട് വാട്ടർ സംരക്ഷിക്കണം എന്നാണ്. എന്ന് പറഞ്ഞ പോലെ സൊസൈറ്റിയെ ഒന്നായിട്ട് സംരക്ഷിച്ചെങ്കിൽ മാത്രമേ നമുക്ക് ഇത്തരം ഇഷ്യൂവിലേക്ക് നമുക്ക് എത്താൻ പറ്റൂ, അത് ഫ്രൂട്ട്ഫുള്ളായിട്ട് എത്താൻ പറ്റൂ എന്നാണ് എനിക്ക് തോന്നുന്നത്.
Yeah, okay. Our next panelist is, I think Mr. Krishna has raised a few interesting points. One is that stress, handling stress is one problem that society deliberately avoids, teaching how to learn stressful situations by unnecessarily shielding people. Another thing he said was about the consumerism which is rising in the society, and the difficulty in leading a law-abiding life. Leading life as a law-abiding citizen in the society is difficult according to his view. So these are some of the issues he raised, and also the need for sports and that kind of group activities among children and all those things. And also both of them narrated some organizations. Mr. Umesh was talking about the program called Chiri. Chiri means laugh in Malayalam, which is a support program, and Mr. Krishnamur was also saying about another initiative in this particular area. Now I think we'll move on to the next panelist, Dr. Shankar Mahadevan, who is joining online with us, and he is representing the Indian Medical Association and doctors of Kerala in general. So over to you, Dr. Shankar. Please give your comments on this particular topic.
Yeah, thank you, Dr. Harish. Am I audible?
Yes, you are audible, please.
Yes, thank you. First of all, I thank the Indian Psychiatry Society, the Indian Medical Association, Dr. Suresh Kumar, Dr. Harish, Dr. Dayal, and all of you for inviting me to this panel discussion. I will be mostly talking about the suicides among the healthcare professionals, or rather mostly the doctors as such. Kerala, interestingly, is having the highest suicide rates. According to the National Crime Records Bureau, they did a study, and they found out that mostly the South Indian states, especially the Kerala and Tamil Nadu, had the highest rates of suicide rates. Out of it, the Kerala had almost 27.7 per 1 lakh suicide rates. At the same time, when you compare with the many North Indian states, especially even Delhi, it is only around 7. So maybe much of might be underreported or something like that. But whatever it may be, the suicide rate among the general population in Kerala is very high. And even in doctor community is also very high. So I was rather amused. In my initial days, I thought that the suicides are mostly in medical students or even the postgraduate students because of the stress factors and a lot that is being handled. We all know that our postgraduate period is a bit hard, and almost it takes about 3 years of rigorous training. Maybe after that, senior residentship and all those will create a lot of hurdles, and that might actually produce a lot of stress in them. But interestingly, nowadays, it is not there are suicides happening. I don't disagree that. But even the doctors, who have practiced good practice, who have almost in the fag end of life, they also suicide. I was wondering, I was actually very much shocked when a doctor couple they suicided almost 1 month back. He was one of my colleague itself, an ENT doctor himself. Then his wife, who was from Thrissur, they came here. They were living in Calicut for the past 6 years. They were having retired life, enjoying their retired life. One fine morning, when the newspaper boy came, they didn't open up the door. Then all those neighbors came in. They saw these people. They had some phenobarbital tablets. They died. So why does this happen? Suicide happen more among the doctor community as such. We all know women of Kerala are the most educated in India. They enjoy, in fact, very high health standards, and everywhere even education system is very high. usually it is said that in all studies, it is said that the women up to after 25 years, the suicide rates usually reduces. And it goes on reducing even after 55 years, it still reduces. But in men, actually, the reverse happens. After 25 years, actually, the suicide rate increases. And maybe after only after 75 years, it comes down. There is many studies there depending about the age of suicide and all those. But the uh, doctor community as such is facing a crisis now. The stress is not due to a lot of factors are there. There is less peer group interaction is there in students and even the new generation people. The drug abuse, the alcohol, these are all very important. I must tell you that the although we generally state that he might have depression and all that, even a mild element of depression, when combined with alcohol and drugs, it is very lethal. It is very lethal to the individual, not only to the individual, to the entire society. See, the 99% of these suicides are actually preventable suicides. Maybe 1% we cannot prevent, but most of the 99% suicides among even doctors or any other professionals, whomever it may be, these are preventable suicides, but we cannot prevent it. Still, it is not preventable. Why? There is reduced peer group interaction is there. Especially during the last 4 years after the COVID and all, the interaction has very much reduced. And the organizational matters, many doctors, they are not coming to meetings. I know the IMA meetings, they are not coming. They are not going to their own association meetings. They are not even interacting with the neighbors. They are not going to anywhere, any public places. The public interaction in doctors is very much less compared to any other professional groups. Then the second point I would highlight is it's a very competitive field. We all know that doctor community, it's a very competitive field, and our aspirations are very high. We aspire to, tomorrow we aspire to become a lot of things. We aspire to become one of the best in the field, isn't it? We all aspire to become the best in our peer group. Whatever be the specialty, we all try to become the best. We all want to deliver the best from our side. So that creates one important stress among the doctors. And um, the third thing is, now the care rates face very important thing, like almost the less than 30 years population is moving out of Kerala. Kerala is largely become an old age community. Maybe after another 10 years, a lot of old age homes will come where we will have to accommodate all these people, all these old age people. Even the recent, for the IMA flats, actually, we are getting enquiries for old age homes. It is not the newer generation that is being coming and taking the flat. The old age people, they are asking for, so that, okay, they will get a common community there, they will get the breakfast there, they will have a common kitchen there. So the fact end of the life, they want to be there, someone who is supportive for them. So this is not happening as such here, because the children, many children, they are going outside the state, and if possible, they are going outside the country also. So this creates a lot of problems among the doctors as such. So the interaction is less, and their social intricacies, these are all the morale of the doctors, they are being reduced as such. Then the financial burden. I know with a lot of them who are having a lot of stress among the financial burden. Actually, the Umesh sir was telling that people are being they suicide for even for penny of 1,000 rupees. But the doctor community, they have got lots of loans are there. They take lot of loans. They, because we all expect, isn't it? A doctor means he should have a car. He should not go through the, you say, public transport system. That is how you define a doctor as such. He should wear this. He should wear shoes. He should wear coat. You should go by this car. You should have a 2-story building. Then only he is classified as a doctor. Then only he can be presented towards the public as a doctor. If not, he becomes a not much. You all go to see patients with, you don't go to see a doctor with very few patients. Listen, you all go and see for doctor
who is having 50 plus, 100 plus OPs, you queue up there again and again. So the lesser generations, what happens, the patients are less for them. Although some the financial disparity, I'm telling about the financial disparity among the doctors is very high also. Some doctors, they have got financially very high position. That is being continuing, still there, it is okay. But the others, especially the junior doctors as such, they are finding it difficult to cope up with the present financial situations in Kerala. So let us, that is about that. These are all my points. Let us discuss about this too.
Okay, thank you, Dr. Shankar. I think Dr. Shankar has spoken about the issues of faced by doctors, mainly loneliness, competition, emptiness issues, and financial difficulties, etc. And need to put up a kind of face before the society that you are well off or something like that. So these kind of pressures are leading to all this. So I think all the panelists have spoken, and maybe we can ask the audience also to join in with some comments or queries, so that we can take up these things as well. So are there any if there are any queries in the chat box, any comments also, you can just please read out so that we can go through that also. So on the whole, what has emerged is that we have had problems has been discussed, as well as some solutions also, like the helplines and the support programs which are run by Kerala Police and other groups also have been mentioned here. So it's not we are not talking about problems alone, also about the solution. So what it clearly stands out is that society has a role in prevention of suicide, and society can do a lot of things. Yes, any queries are there?
One of the queries raised was, please outline about Kerala-specific suicide prevention strategies.
Okay, I think Umesh has mentioned about the program called Chiri, which was a helpline started by the Kerala Police, the Calicut District Police. So the helpline with numbers were given, and he had mentioned about the number 52,000 calls were received, out of which 38,000 were general calls and 14,000 calls were around having specific issues, and those were addressed by counselors, and the next level interventions were given. Yeah, you can, Dr. Umesh will add more.
In Kerala, we are several segments to attend this problem, attend these issues. Police will conducting these programs, Chiri and Janamatri policing, social policing, etc. In another, ASHA workers and other team is there. Anganwadi workers is also there. Anganwadi workers attending the teenage issue problem, okay, Anganwadi workers attend ചെയ്യും. അമ്മമാരുടെ ഇഷ്യൂസ് അവർ അറ്റൻഡ് ചെയ്യും. ആശാ വർക്കേഴ്സിന് കുറേ കാര്യങ്ങൾ ചെയ്യാൻ വേണ്ടി പറ്റും. അതേപോലെ തന്നെ നമ്മുടെ സോഷ്യൽ ജസ്റ്റിസ് ഡിപ്പാർട്ട്മെൻറ്റിൻ്റെ കീഴിൽ വളണ്ടിയേഴ്സ് ഉണ്ട്. ഈ പല സെഗ്മെൻ്റായിട്ട് ഇവിടെ നമുക്ക് ഇത്തരം കാര്യങ്ങൾക്ക് വേണ്ടിയിട്ടുള്ള മൂവ്മെൻറ്റ് നടക്കുന്നുണ്ട്. കേരളത്തിൽ ഒരു വളരെ നല്ല രീതിയിൽ വിദ്യാലയങ്ങളിൽ നമുക്ക് അവയർനെസ് പ്രോഗ്രാമുകൾ കണ്ടക്ട് ചെയ്ത് വരുന്നുണ്ട്. കുട്ടികളിൽ തന്നെ ഇത്തരം കാര്യങ്ങൾ ഉണ്ടാക്കാൻ വേണ്ടിയുള്ള ഇത് ചെയ്യുന്നുണ്ട്. ഒരു തണൽ പോലെയുള്ള സംഘടനകൾ ഇത്തരം ഇത് സൂയിസൈഡ് പ്രിവെൻഷന് വേണ്ടിയുള്ള ആക്റ്റീവ് പരിപാടികൾ നടത്തുന്നുണ്ട്. ഈ ഓരോ സംഘടന നടത്തുന്നുണ്ടെങ്കിലും നമുക്ക് ടീമായിട്ട് ഞാൻ നേരത്തെ പറഞ്ഞതുപോലെ കേൾക്കാൻ ആളെ ഉണ്ടാക്കുക, ഒരു ഫസ്റ്റ് എയ്ഡ്, സൈക്കോളജിക്കൽ ഫസ്റ്റ് എയ്ഡ് കൊടുക്കുക എന്ന രീതി കുറച്ചും കൂടി നന്നായിട്ട് നമ്മൾ ഇംപ്ലിമെൻറ്റ് ചെയ്യേണ്ടതുണ്ട്. അത്തരം പരിപാടികൾ ഇംപ്ലിമെൻറ്റ് ചെയ്യുന്നതിന് വേണ്ടിയിട്ട് ഒരു നല്ലൊരു ഡിസ്കഷൻ നടന്ന് ഒരു ടീമിനുണ്ടാക്കി മുന്നോട്ട് കൊണ്ടുപോകുന്ന പരിപാടി കേരളത്തിൽ നടന്നുകൊണ്ടിരിക്കുന്നതായിട്ടാണ് മനസ്സിലാക്കാൻ പറ്റുന്നത്.
ഇതിനോട് കൂടെ ചേർക്കാൻ ഞാൻ ഉദ്ദേശിക്കുന്ന ഒന്ന് രണ്ട് കാര്യങ്ങൾ നമുക്ക് ഡിസ്കസ് ചെയ്യാവുന്ന കാര്യങ്ങളാണ്. ഒന്ന്, നമ്മളിപ്പോൾ സാമൂഹ്യമായ ഇടപെടൽ അല്ലെങ്കിൽ സമൂഹത്തിൻ്റെ സ്ഥാനം എന്ന രീതിയിൽ ഇതിനെപ്പറ്റി ചർച്ച ചെയ്യുമ്പോൾ ശരിക്കും ഒരു വ്യക്തി കേന്ദ്രീകൃതമായിട്ട് ഒരു ഇൻസിഡൻറ്റ് നടന്നു കഴിഞ്ഞിട്ട് അല്ലെങ്കിൽ നടക്കാൻ സാധ്യതയുള്ളൊരു വ്യക്തിയിൽ നേരിട്ട് ഇടപെടുക എന്നതിലപ്പുറത്തേക്ക് ചെയ്യേണ്ട കുറേ കാര്യങ്ങളാണ് നമ്മളിപ്പോൾ ചൂണ്ടിക്കാണിക്കപ്പെട്ടത്. അപ്പോൾ സൂയിസൈഡിലേക്ക് നയിച്ചേക്കാവുന്ന ഘടകങ്ങളെ ഇൻ്റർവീൻ ചെയ്യുക അല്ലെങ്കിൽ ഇടപെടുക എന്നുള്ളതിൽ തുടങ്ങിയിട്ട് വേണം നമ്മളൊരു സൂയിസൈഡിലെത്തി നിൽക്കുന്ന ഒരു വ്യക്തിയിലേക്ക് ചെല്ലുന്നത് എന്നതാണ് ഇതിൻ്റെ അകത്ത് എനിക്ക് മനസ്സിലാക്കാൻ പറ്റിയത്. അതോടൊപ്പം എനിക്ക് തോന്നുന്നു certain other points like what is the importance of training in life skills in children or in population in general, whether we are lacking in resilience or in our ability to tackle stress or handle setbacks. ആ ഒരു ആസ്പെക്റ്റ് ഒരു ഇമ്പോർട്ടൻ്റ് ആണെന്ന് തോന്നുന്നു. Addressing the need for a social support system, especially in the vulnerable groups. Like there are people who are more vulnerable, they might actually need a more well-established social support to be provided to them. അത് എത്ര കണ്ട് നമുക്ക് ചെയ്യാൻ പറ്റും എന്നുള്ളതൊരു ചോദ്യമാണ്. Another related, may not be directly related issue is the issue of legal status of attempted suicide, like how the society looks at suicidal attempt and അതിനെ എങ്ങനെയാണ് നമ്മുടെ ഒരു നിയമ സംവിധാനം അതിനെ എങ്ങനെ നോക്കിക്കാണുന്നു. അതിൽ റീസെൻ്റായിട്ട് ചില മാറ്റങ്ങൾ വന്നു തുടങ്ങിയിട്ടുണ്ട്. The media portrayal of suicide, how we discuss, describe or disseminate information regarding suicidal behavior, ഇതൊക്കെ എനിക്ക് തോന്നുന്നു സാമൂഹ്യമായ ഘടകങ്ങളെ ചൂണ്ടിക്കാണിക്കുന്ന ചില കാര്യങ്ങളാണ്. അപ്പോൾ അതിനകത്തും എനിക്ക് തോന്നുന്നു കുറച്ചൊക്കെ ഇൻപുട്സ് നന്നായിരിക്കുമെന്ന് എനിക്ക് തോന്നുന്നു. താങ്ക് യു.
One program which I remember is there was some initiative in the medical education and along with the mental health authority called Crisis, in which we used to conduct, I just remembered it when they all mentioned this life skill. So we used to conduct classes in school children, life skill education based on that WHO's 10 life skill modules. I myself had gone to lot of class, done lot of classes that was earlier. Now in initial after 3-4 years that program was not getting fund from the government and it has stopped. But I think such programs has a role, and I think Mr. Krishnamar will talk about the programs which he is aware of in this area in Kerala, as well as reporting, media reporting and issues related to that in suicide.
തീർച്ചയായിട്ടും നമ്മൾ കുട്ടികളിലാണ് ഇതുമായി ബന്ധപ്പെട്ട അവരിൽ ശരിക്കും നമ്മൾ സൂയിസൈഡ് എന്നുള്ള ഒരു സാധനത്തിൽ ആ വാക്ക് തന്നെ നമ്മൾ ഉപയോഗിക്കുന്നില്ല. അവരുമായിട്ടുള്ള ഒരു കമ്മ്യൂണിക്കേഷനും നമ്മളത് ഉപയോഗിക്കുന്നില്ല. ആ വാക്കേ നമ്മൾ ഒഴിവാക്കി നിൽക്കുകയാണ്. നമ്മൾ ശരിക്കും എൻവയോൺമെൻറ്റുമായി ബന്ധപ്പെട്ടിട്ടാണ് സ്റ്റുഡൻറ്റ് എംപവർമെൻറ്റ് ഫോർ എൻവയോൺമെൻറ്റൽ ഡെവലപ്മെൻറ്റ് എന്ന് പറഞ്ഞിട്ട് സീഡ് എന്ന് പറഞ്ഞ പ്രോഗ്രാമാണ്. അതിനകത്ത് നമ്മൾ ആദ്യം അത് 15 വർഷം മുമ്പാണ് തുടങ്ങിയ സമയത്ത് നമ്മൾ സ്കൂളുകളിൽ ഒരു കണക്കെടുത്തപ്പോൾ അവിടുത്തെ ഒരു 5% കുട്ടികൾ ഇങ്ങനെ ക്രിമിനൽ കേസുകളിൽ പ്രതിയായ, ഞാൻ ആ സ്കൂളിൻ്റെ പേര് പറയുന്നില്ല, അത് റെക്കോർഡുകളിലുണ്ട്, 5% കുട്ടികൾ ഇങ്ങനെ ക്രിമിനൽ കേസുകളിൽ ഏർപ്പെട്ട ആ സ്കൂളുകളിൽ ഈ ഇനിഷ്യേറ്റീവ് വന്നതിന് ശേഷം ആ സ്കൂളിപ്പം എഡ്യൂക്കേഷൻ ലെവലിൽ ഭയങ്കരമായിട്ട് മുമ്പിലേക്ക് വന്നു. എനിക്ക് ഈ രണ്ടാമത്തെ ഭാഗം പറയണമെന്നുണ്ട്, പക്ഷേ ആദ്യ ഭാഗം പറഞ്ഞുകൊണ്ട് ആ സ്കൂളിൻ്റെ പേര് ഞാൻ പറയുന്നില്ല. എന്തായാലും എന്ന് പറഞ്ഞതുപോലെ ഈ കുട്ടികൾക്ക് ഇവർക്ക് ഒരു ആക്ടിവിറ്റി, നേരത്തെ പറഞ്ഞതുപോലെ അവർക്കൊന്നും ചെയ്യാനിരിക്കുന്ന അവസ്ഥയിൽ നിന്ന് അവർക്കൊരു ആക്ടിവിറ്റി, അവരൊരു ചെടി നടുന്നു, ഒരു പയർ നടുന്നു, അത് പയർ നടലോ ചെടി നടലോ ഒരു തക്കാളി നടലോ അല്ല, അവർക്ക് അതിൽ നിന്നുണ്ടാകുന്ന ഒരു റിസൾട്ട് അതിലും വലുതാണ്. ഇത്തവണ ഈ വർഷം നമ്മൾ ഇത് ഏതാണ്ട് 8,000-ഓളം സ്കൂളുകളിൽ കേരളത്തിൽ നമ്മൾ ഈ പ്രോജക്റ്റ് വർക്ക് ചെയ്യുന്നുണ്ട്. അത് ഡോക്യുമെൻറ്റഡ് ആയിട്ടുള്ളത്, എല്ലാ വർഷവും നമുക്കതിൻ്റെ റിപ്പോർട്ട് കിട്ടത്തക്ക വിധത്തിലുള്ള. ഇത്തവണ നമ്മളത് ഈ മയക്കുമരുന്നാണ് ഒരു പ്രധാന ഇതെന്നുള്ള നിലയിൽ അതിനൊരു എക്സ്ട്രാ ഫോക്കസ് കൊടുത്തുകൊണ്ട് തനിച്ചല്ല എന്ന് പറഞ്ഞിട്ടൊരു പ്രോഗ്രാം, അതായത് മാതൃഭൂമിക്ക് ഏറ്റെടുക്കാൻ പറ്റുന്ന ഏറ്റവും വലിയൊരു കാര്യമായിട്ട് നമ്മൾ ഏറ്റെടുക്കുന്നത്. കാരണം ഈ നമ്മൾ ഒരു പഠനം നടത്തിയതിൽ ഇതിനകത്ത് ഈ ഇൻഫോർമർമാർക്കുണ്ടാകുന്ന ഒരു വലിയ പ്രതിസന്ധിയുണ്ട്. അവരെ ഈ മൊത്തം ആളുകൾ ചേർന്നിട്ട് പോലീസ് എത്ര സഹായിച്ചു എന്ന് പറഞ്ഞാലും ശരി, അത് പലപ്പോഴും ആരാണ് ഇൻഫോം ചെയ്തതെന്ന് പോലീസ് അറിയുന്നതോടൊപ്പം തന്നെ അവരും അറിയും. അപ്പോൾ ആ ഉത്തരവാദിത്വം മാതൃഭൂമി ഏറ്റെടുത്തു. നിങ്ങൾ ഞങ്ങളെ അറിയിക്കുക, ഞങ്ങൾ ബാക്കി കാര്യങ്ങൾ ചെയ്തോളാം, നിങ്ങൾക്ക് എന്ത് വേണമെങ്കിലും അത് വിളിക്കാനായിട്ട് എല്ലാ സ്കൂളുകളിലേക്കും നമ്മൾ ഈ പറയുന്ന ഈ കേരളത്തിലെ എല്ലാ സ്കൂളുകളിലേക്കും നമ്മളൊരു ബുക്ക്ലെറ്റ് അടിച്ചു കൊടുത്തിട്ടുണ്ട്. അതിനകത്ത് വിളിക്കാനായിട്ട് അത് നല്ല സോഷ്യൽ വർക്കിങ്ങിൽ എക്സ്പീരിയൻസ് ഉള്ള കുറച്ച് ആളുകൾ അതിനകത്തുണ്ട്. ആ കോളുകളെല്ലാം നമ്മൾ അറ്റൻഡ് ചെയ്യുന്നുണ്ട്. പക്ഷേ ഒരു കോളിനെ കുറിച്ചും നമ്മളൊരു വാർത്ത കൊടുക്കുന്നില്ല, ഒരു കാര്യങ്ങളും ചെയ്യുന്നില്ല. പക്ഷേ നമ്മൾ ആ കാര്യങ്ങളെല്ലാം അറ്റൻഡ് ചെയ്യും, മുമ്പോട്ട് പോവുകയും ചെയ്യുന്നുണ്ട്. അപ്പോൾ സീഡുമായി ബന്ധപ്പെട്ടിട്ട് ഈ പ്രവർത്തനങ്ങൾ വളരെ സൈലൻ്റായി മുമ്പോട്ട് പോകുന്നുണ്ട്.
ഒരു കാര്യം പറയുന്നത്, നമ്മൾ ഇത് കേൾക്കുന്ന മാധ്യമപ്രവർത്തകരുണ്ടാവുമല്ലോ, അതേമാതിരി ഓൺലൈനിൽ ഇപ്പോൾ മാധ്യമപ്രവർത്തകരേറെ ഓൺലൈനിൽ ന്യൂസ് അടിച്ചു വിടുന്നവരാണ് കൂടുതലുള്ളത്. അപ്പോൾ ഈ മാധ്യമത്തിൽ ചെയ്യേണ്ട ധർമ്മങ്ങളെ പറ്റിയിട്ടോ അതിൻ്റെ നിയമങ്ങളെ പറ്റിയോ പലതും അറിയാത്ത ആളുകളാണ് പലപ്പോഴും ഇത് ഓൺലൈനിലുള്ളവർ. അപ്പോൾ അതിൽ പ്രധാനപ്പെട്ട കാര്യം ഈ സൂയിസൈഡ് റിപ്പോർട്ട് ചെയ്യുമ്പോൾ ഒരു ഗൈഡ് ലൈൻ നമുക്ക് നിലവിലുണ്ട്. അപ്പോൾ സൂയിസൈഡിനെ ഒരു പർവ്വതീകരിക്കുന്ന രീതിയിൽ ഒരിക്കലും ചെയ്യാൻ പാടില്ല എന്നും സൂയിസൈഡ് അല്ല എല്ലാത്തിനും പരിഹാര മാർഗം എന്നും കൂടി ആ വാർത്തയിൽ നിർബന്ധമായി ഉൾക്കൊള്ളിക്കണം എന്നുണ്ട്. പക്ഷെ അത് പലപ്പോഴും പാലിക്കപ്പെടാതെ ഓൺലൈൻ ന്യൂസുകൾ വായിക്കുന്ന കുട്ടികൾക്ക് ഒരു വീര പരിവേഷം വന്ന് വരുന്നില്ലേ എന്നൊരു സംശയം കൂടി ഞാൻ ചോദിക്കുകയാണ്.
ഇത് തീർച്ചയായിട്ടും ഞാനിതിവിടെ പറയണമെന്ന് വിചാരിച്ച കാര്യമാണ്. കാരണം പലപ്പോഴും ഞാൻ നേരത്തെ പറഞ്ഞതുപോലെ ഇത്തരം കാര്യങ്ങൾ പറയുമ്പോൾ നമ്മളിതിൻ്റെ ഈ കോറായിട്ടുള്ള സാധനത്തെ കുറിച്ചിട്ട് ഇതൊരു സൂയിസൈഡ് വാർത്ത മാത്രമല്ല. കാരണം ഇത് നമ്മൾ മറച്ചു വെക്കുക എന്ന് പറയുമ്പോൾ ഇപ്പം എന്ന് വെച്ചാൽ പലപ്പോഴും എൻ്റെ കയ്യിലുണ്ട് ആ ഗൈഡ് ലൈൻസ് എല്ലാം, ഓരോരുത്തർ എല്ലാ ആളുകളും തന്ന ഗൈഡ് ലൈൻസ് എൻ്റെ കയ്യിലുണ്ട്. നമ്മൾ പത്രപ്രവർത്തനത്തിൽ ശരിക്കും പറഞ്ഞാൽ ഇപ്പോൾ ആ വാർത്ത ഈ ഗൈഡ് ലൈൻ വെച്ച് കൊടുക്കുകയാണെങ്കിൽ തിരുവനന്തപുരത്ത് ഒരാൾ ജീവിത നൈരാശ്യം മൂലം മരിച്ചു എന്ന വാർത്തയെ നമുക്ക് കൊടുക്കാൻ കഴിയും. അത് നമ്മൾ റീതിങ്ക് ചെയ്യേണ്ട കാര്യമാണ്. ഞാൻ ഈ അടുത്തിടെ ഒരു സിനിമ കാണുന്നതിനിടയിൽ ഒരാൾ പറഞ്ഞൊരു വാചകമുണ്ട്, ഇപ്പോഴും ഇവർ പുകവലിയെ പറ്റിയിട്ടാണോ കൊടുക്കുന്നത്, ഇനിയിപ്പോൾ MDMA പറ്റി കൊടുക്കണ്ടേ എന്ന് ചോദിച്ചു. വളരെ വാല്യുബിൾ ആയിട്ടുള്ള ഒരു പോയിൻ്റാണ്. കാരണം എന്ന് വെച്ചാൽ നമ്മൾ ഇന്ത്യ മുഴുവനുള്ള പരസ്യങ്ങൾ അല്ലെങ്കിൽ ഈ അവയർനെസ് പ്രോഗ്രാമുകൾ പരിശോധിച്ചാൽ ഒരു സ്റ്റഡി നടത്തുകയാണെങ്കിൽ അതിനകത്ത് ഏറ്റവും വലിയ ഇമ്പാക്റ്റ് ഉണ്ടാക്കിയ പരസ്യം എന്ന് പറയുന്നത് ശ്വാസകോശ സ്പോഞ്ച് പോലെയാണെന്നുള്ളതാണ്. ഉറപ്പായിട്ടും അങ്ങനെ തന്നെയാണ്. കാരണം എന്ന് വെച്ചാൽ ആ പരസ്യം ഉണ്ടാക്കിയ ഇമ്പാക്റ്റ്, ആ പരസ്യം കൊടുക്കുന്നതും അതുണ്ടാക്കുന്ന ഇമ്പാക്റ്റും മറിച്ച് നമ്മൾ സ്ക്രീനിൻ്റെ താഴെ ഒരു സ്ഥലത്ത് എഴുതി വെക്കുകയാണ് മദ്യപാനം ആരോഗ്യത്തിന് ഹാനികരം. ഇതൊരു തമാശയായിട്ടും ഇതൊരു നേരെ തിരിച്ചുള്ള ഒരു സാധനമായിട്ടാണ് പൊതുസമൂഹം എടുക്കുന്നതെന്നുള്ളതാണ് നമ്മളുടെ ഒരു ധാരണ. അതുകൊണ്ട് ഒരു ഫലവും ഉണ്ടാകാൻ പോകുന്നില്ല. നമുക്ക് വേണ്ടത് ഒരു ആത്മഹത്യാ വാർത്ത കൊടുക്കുന്നതിൻ്റെ കൂടെ നമ്മൾ താഴെ ഇങ്ങനെ ആത്മഹത്യ ഒന്നിനും പരിഹാരം ഇല്ല എന്ന് പറയുന്നത് എത്രത്തോളം ഇത് ചെയ്യും. നമ്മൾ അഡ്രസ്സ് ചെയ്യേണ്ടത് ആത്മഹത്യ ഉണ്ടാവാനുള്ള സാഹചര്യം ഇല്ലാതാകലാണ്. പലപ്പോഴും നോക്കുകയുള്ളൂ. കാരണം ട്രെയിനിൽ വെച്ചൊരാളെ ഒരു തരത്തിൽ അബ്യൂസ് ചെയ്തു എന്നുള്ള ഒരു വാർത്ത വന്നാൽ തൊട്ട് നമുക്കൊരു 10 ദിവസത്തോളം അതേ വാർത്ത തന്നെ കൊടുക്കേണ്ടി വരും. അതെങ്ങനെയാണ് സ്വാധീനം? അത് ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ ആശുപത്രിയിലെ കാര്യം നമ്മൾ മറച്ചു വെച്ചിട്ട് കാര്യമില്ല. അവിടെ പോയി കാലൊടിഞ്ഞിട്ടുണ്ടെങ്കിൽ കാലൊടിഞ്ഞ. പക്ഷെ ഒരു കാര്യമുണ്ട്, ഇതിനകത്ത് നമ്മൾ അഡ്രസ്സ് ചെയ്യേണ്ട ഒരു കാര്യമുണ്ട്. കൊല്ലത്തൊരു സ്ത്രീ, ഒരു വീട്ടമ്മ ആത്മഹത്യ ചെയ്തിട്ടുണ്ട്. അതിനകത്ത് നോക്കൂ, നേരെ തിരിച്ചാണ് സംഭവിച്ചത്. അവർ ആ വീട്ടിലിരിക്കുമ്പോൾ ഈ വാർത്ത അറിയുന്നു, അവരുടെ ഹസ്ബൻഡ് അവരോട് പറയുന്നില്ല. അവരെ പറയാതെ അവരെ വേറൊരു വീട്ടിൽ കൊണ്ടാക്കുകയാണ്. രാത്രിയിൽ ഏതാണ്ട് ഒരു 11 മണി 12 മണിയാകുന്ന സമയത്ത് അവർ ഫേസ്ബുക്കിൽ നിന്ന് ഈ വാർത്ത അറിയുകയാണ്, ഈ മകൻ ആദരാഞ്ജലി എന്നുള്ളത്. ആലോചിച്ച് നോക്കുക, അവിടെ നമ്മളുടെ അവിടെ നമ്മളായിരുന്നു ചെയ്യേണ്ടത്. അവരോടത് പറയണമായിരുന്നു. അവരോട് പറഞ്ഞിട്ട് അവരോടൊപ്പം ഇരിക്കേണ്ട ആളുകൾ ഇരിക്കണമായിരുന്നു. ഒറ്റയ്ക്കാകുന്ന ആളുകളാണ് ശരിക്കും ആത്മഹത്യ ചെയ്യുന്നത്. ഒറ്റയ്ക്കാവാതിരിക്കാനുള്ള അവസ്ഥ ഉണ്ടാക്കി കൊടുക്കുക എന്നുള്ളതാണ്. അല്ലാതെ നമ്മൾ പത്രത്തിലൊരു വാർത്ത കൊടുക്കുന്നതിന് താഴെ ആത്മഹത്യ പരിഹാരമാണെന്ന് പറയുന്നത് അത് നമ്മൾ നിരന്തരം നമ്മൾ ഈ മദ്യപാനത്തിൻ്റെ രംഗങ്ങൾ കാണിക്കുക, അതിൻ്റെ താഴെ എഴുതി കാണിച്ച് ഇതൊരു വൃഥ എക്സർസൈസാണ് സത്യം പറഞ്ഞാൽ. അതല്ല നമുക്ക് വേണ്ടത്. നമുക്ക് ബേസിക്കായിട്ട് അതിനകത്തെ പ്രശ്നം എന്താണെന്ന് അറിഞ്ഞിട്ട് അതിനെ നമുക്ക് മാറ്റിയെടുക്കേണ്ടത് എങ്ങനെയാണെന്ന് പറഞ്ഞാൽ അതിനെ അഡ്രസ്സ് ചെയ്യുകയാണ് വേണ്ടത്.
വാർത്ത കൊടുക്കുക എന്നതിലുപരി ആ ടോട്ടൽ വായിക്കുമ്പോൾ ആ വായിക്കുന്ന ഒരാൾക്ക് ഇതല്ലായിരുന്നു, അയാൾ ഒരു പരിഹാരവും ഇല്ലാതെ അയാൾ ആത്മഹത്യ ചെയ്തു ഇന്ന് ചില വാർത്ത നമ്മൾ മെയിൻ മാധ്യമങ്ങളല്ല ഞാൻ പറയുന്നത്. കാരണം ഇത് ഞാൻ ഓൺലൈൻ മാധ്യമങ്ങൾ എഴുതുന്നവർ കൂടി കേൾക്കുന്നുണ്ടല്ലോ എന്നുള്ളതാണ് ഞാൻ പറയുന്നത്.
തീർച്ചയായിട്ടും
അങ്ങനെ വാർത്ത വരുമ്പോൾ ഈ ഒരു മാർഗവും ഇല്ലാതെ ആത്മഹത്യ ചെയ്യും. ഒരു മാർഗവും ഇല്ലാത്ത പ്രശ്നമില്ല ഇവിടെ. മാർഗമുണ്ട്. ആ മാർഗം കാണിച്ചു കൊടുക്കാനും പറഞ്ഞു കൊടുക്കാനും നമ്മളൊക്കെ തോറ്റുപോയതുകൊണ്ടാണ്, സൊസൈറ്റി കൂടെ ഇല്ലാത്തതുകൊണ്ടാണ്. മുസ്ലിം സൊസൈറ്റി കൂടെ ഉണ്ടാവുകയും അത്തരം മാർഗങ്ങൾ കാണിച്ചു കൊടുക്കാൻ കഴിയുകയും ചെയ്താൽ മാർഗങ്ങൾ ഉണ്ടായിരുന്നു എന്നാണ് ഉദ്ദേശിച്ചത്.
വാർത്ത കൊടുക്കുന്നതിൽ നമ്മൾ കൂടുതൽ ശ്രദ്ധ, അതുപോലെ തന്നെ ഈ പറഞ്ഞതുപോലെ എത്ര ചെറിയ ഗ്രൂപ്പാണെങ്കിലും ശരി, ആ ഗ്രൂപ്പിനെ അഫക്റ്റ് ചെയ്യുന്നുണ്ടെങ്കിൽ അത് നമ്മൾ ഒഴിവാക്കേണ്ടത്. പക്ഷെ ഒരു കാര്യം എന്താ വെച്ചാൽ നമ്മൾ കുറച്ചുകൂടെ മിഠായി കമ്പനികളെല്ലാം മിഠായിയുടെ സ്വാദ് കൂട്ടുന്നതിനേക്കാട്ടിൽ കൂടുതൽ അവർ പൈസ മുടക്കുന്നതും അവരെ ഇനിഷ്യേറ്റീവ് എടുക്കുന്നതും അതിൻ്റെ കവർ ഡിസൈൻ ചെയ്യുന്നതിനാണ്. കാരണം കവറാണ് വിൽക്കുന്നതെന്ന് അറിയാം. എന്ന് പറഞ്ഞതുപോലെ ഈ വാർത്തകൾ വരുമ്പോൾ ഉണ്ടാകുന്നത് ഇതിൻ്റെ വളരെ പെരിഫറലായിട്ടുള്ള ഒരു സാധനമേ ഉള്ളൂ. ശരി, ഞാൻ പറയുന്നത് എൻ്റെ ഒരു വ്യക്തിപരമായ അഭിപ്രായത്തിൽ നമ്മളിതിൻ്റെ കോർ റീസണെയാണ് അഡ്രസ്സ് ചെയ്യേണ്ടത്. അവരതിലേക്ക് കാരണം എന്ന് വെച്ചാൽ അവരെ ശരിക്കും ഞാൻ പറയാം, ഒരു കല്യാണത്തിൽ 100 പേര് വരുന്നു. 100 പേര് വരുന്നതിൽ 4 പേർക്ക് ഡയബറ്റിക്സ് ഉണ്ട്. നമ്മളൊരു മാനസിക പരിഗണന വെച്ചിട്ട് നമ്മൾ പറയുകയാണ് എല്ലാ ആളുകൾക്കും നമ്മൾ മധുരമില്ലാത്ത ചായ കൊടുക്കുന്നു എന്ന് പറഞ്ഞാൽ ശരി, ആ മാനസിക പരിഗണന വെച്ച് ശരി. പക്ഷെ അങ്ങനെയല്ല അത് വേണ്ടത്. ശരിക്കും പറഞ്ഞാൽ ആ 4 പേർക്ക് കൊടുക്കാൻ പറ്റാത്തതുകൊണ്ട് നമ്മൾ ബാക്കിയുള്ള ആളുകൾക്ക് കൊടുക്കുന്നു എന്നുള്ള അവരെ ബോധ്യപ്പെടുത്തുകയാണ് വേണ്ടത് ശരിക്കും. അതായത് ഒരു ചെറിയൊരു ഗ്രൂപ്പ്, ഈ നമ്മളെപ്പോഴും പറയുന്നത് ഈ വാർത്ത കൊടുത്തു കഴിഞ്ഞാൽ, ഇങ്ങനെ നമ്മൾ ഒളിച്ചു വെക്കുന്ന വാർത്ത കൊടുത്തു കഴിഞ്ഞാൽ അപ്പോഴെന്താണ് സംഭവിക്കുന്നത് എന്നുള്ളത് നമ്മൾ ഇനി പഠിക്കാനിരിക്കുന്നതേ ഉള്ളൂ. ആ തരത്തിലുള്ളൊരു പഠനത്തിലേക്ക് നമ്മൾ പോയിട്ടേ ഇല്ല. ഞാൻ നേരത്തെ പറഞ്ഞ മറ്റേ കുട്ടികൾ കാർട്ടൂൺ കാണുന്നതിനെക്കുറിച്ച് പറഞ്ഞതുപോലെ നമ്മൾ എവിടെയോ നമ്മൾ ഒരു നേരത്തെ സെറ്റ് ചെയ്തിരിക്കുന്ന ഒരു പോയിന്റിലേക്കാണ് നമ്മൾ വീണ്ടും വീണ്ടും പോകുന്നത്. അതിനെയും കൂടുതൽ ഇപ്പോഴത്തെ കാലത്ത് അതിനെക്കാട്ടിൽ എത്രയോ നല്ല മാർഗ്ഗങ്ങൾ ഞാൻ പറയുന്നത് വെച്ചാൽ, ഇപ്പോൾ ഈ സോഷ്യൽ മീഡിയ വന്നിരിക്കുന്ന ഈ സാധനത്തിൽ, AI ഒക്കെ വന്നിരിക്കുന്ന സാധനത്തിൽ, ഇവരുടെ സോഷ്യൽ മീഡിയയിൽ നമുക്കൊരു ചെറിയൊരു സാധനം ഇട്ട് കഴിഞ്ഞാൽ ഇവരെ ഉപയോഗിക്കുന്ന സാധനം, ഇവർ നോക്കുന്ന സാധനം, ഇവരുടെ മറ്റുള്ള കാര്യങ്ങളൊക്കെ വെച്ചിട്ട് നമുക്ക് ഏതെങ്കിലും ഒരു സെക്ടറിലേക്ക് ഒരു മെസ്സേജ് നമുക്ക് വരുത്താം. കാരണം ഇയാൾക്ക് ഒരു ചെറിയ ഒരു ഡിപ്രഷൻ ഉണ്ട്, ഫീൽ ചെയ്യുന്നുണ്ട്. ഇപ്പം പിന്നെ നമ്മുടെ ഈ ആപ്പുകൾ, നമ്മുടെ പൈസ കൈകാര്യം ചെയ്യുന്ന ആപ്പുകൾക്ക് പെർമിഷൻ കൊടുത്താൽ ഏത് സമയം എൻ്റെ പൈസ കൂടുതലാണെന്ന് അപ്പോൾ എനിക്ക് ഇൻറ്റിമേഷൻ തരും, നിങ്ങൾ കൂടുതലാണ് ചിലവാക്കുന്നത്, ശ്രദ്ധിക്കണം എന്നുള്ളത്. അതിനകത്ത് സ്വകാര്യതയൊന്നുമില്ല. ഈ സ്വകാര്യത എന്ന് പറയുന്നത് നമ്മളിപ്പോൾ ഈ പറഞ്ഞതുപോലെ എന്തോ ഒരു വലിയ സാധനമാണെന്ന് പറഞ്ഞിട്ട് പറയുന്നത്, ഇതിലൊന്നും ഒരു സ്വകാര്യതയുടെ പ്രശ്നമില്ല. ശരിക്കും ഈ കുട്ടികൾ നോക്കുന്ന ആപ്പിൽ ചെറിയൊരു സാധനം ഇൻസ്റ്റാൾ ചെയ്താൽ അത് വരുമെങ്കിൽ അതിനെയാണ് നമ്മൾ നോക്കേണ്ടത് ശരിക്കും. കാരണം വെച്ചാൽ നമ്മൾ കൺവെൻഷനായിട്ടുള്ള കുറച്ച് കാര്യങ്ങളിലേക്ക് നമ്മൾ വീണ്ടും വീണ്ടും പോയിട്ട് ഈ പുതിയ സമൂഹത്തിൽ അത് എത്രത്തോളം പ്രാക്ടിക്കലാകും എന്നുള്ളത് നമ്മൾ ആലോചിക്കണം.
Okay, so that was an interesting point. We need to change the kind of targeting, whom we are targeting, and the methods we target to give these kind of messages about suicide prevention and awareness. So that is what he was saying generally. And any other question in the chat box? Yeah.
Another question in the chat box is ഇൻസ്റ്റിഗേറ്റിംഗ് a suicide punishable? അതെങ്ങനെയാണ് എടുക്കുക? അതായത് ഇപ്പോൾ ഒരാൾ കത്തെഴുതി വെച്ചിട്ടൊക്കെ അപ്പോൾ ആത്മഹത്യ പ്രവണത അല്ല അങ്ങനെ. ഓക്കെ,
തീർച്ചയായും ആത്മഹത്യാ പ്രവണത കുറ്റകരമാണ്. പക്ഷെ നമുക്ക് പ്രശ്നം വരുന്നത് വെച്ചാൽ അത് പ്രൂവ് ചെയ്യാൻ പലപ്പോഴും പ്രശ്നം വരാറുണ്ട്. ഒരാൾ കത്തെഴുതി വെക്കാണ്, എൻ്റെ മരണത്തിന് ആരും ഉത്തരവാദിയല്ല, ഞാൻ തന്നെയാണ്. ആ ഇതിൽ ഉത്തരവാദി പലരുണ്ടാവും. പക്ഷേ അവൻ വിചാരിക്കുന്നത് എൻ്റെ മരണത്തിന് ആരും ഉത്തരവാദിയിലൊക്കെ കത്തൊക്കെ എഴുതി വെച്ചു. പിറ്റേന്ന് നമ്മൾ രാവിലെ വന്നിട്ട് ഇന്നാൾ ഉത്തരവാദി എന്ന് പറയുമ്പോൾ നമുക്കത് പ്രൂവ് ചെയ്യാൻ ബുദ്ധിമുട്ടുണ്ടാവും. അതേപോലെ തന്നെ ചില കേസുകൾ നമുക്ക് കാണാറുണ്ട്, ഒരു സൂയിസൈഡ് കഴിഞ്ഞാൽ വേഗം മറച്ചു വെക്കും, സൂയിസൈഡൊന്നും കാണിക്കില്ല, കൊണ്ടുപോയിട്ട് ഡിസ്പോസൊക്കെ ചെയ്ത് ഒക്കെ കത്തിച്ചൊക്കെ കഴിഞ്ഞിട്ട് കുറേ കഴിഞ്ഞ് പറയും എൻ്റെ മകൻ ആത്മഹത്യ ചെയ്താണ്, അതിൻ്റെ ഒരു കാരണം ഇതായിരുന്നു പറയുമ്പോൾ നമുക്ക് പ്രൂവ് ചെയ്യാൻ ബുദ്ധിമുട്ട് വരുന്നുണ്ട്. പക്ഷേ ഒരാൾ സൂയിസൈഡ് ചെയ്യാൻ പ്രേരിപ്പിച്ചാൽ കൊലപാതകം പോലെ തന്നെ ആ കുറ്റകരമാണ്, അത് പണിഷബിളാണ്.
So the legal position is very clear. Abetment of suicide is punishable, but it has to be proved by the legal method, police inquiry or it has to be proved. So that is the point. Any other question? Okay, so I think we have had a good discussion on so many points. So one thing is, few things I want to catch up with the panelists is, one is the SEED program. Is it available? Website is there for this? So can you just give the website so that people from other states or outside Kerala can also? Okay. It is a social, what is the exact full form?
Student Empowerment for Environmental Development.
Student Empowerment for Environmental Development. So those who are interested to know, seed.com. This is a program running for 15 years in around 8,000 schools in Kerala, according to Mr. Krishnakumar's data. So, and this is working among students to empower them to handle difficult situations, stress and difficult situations using different methods. So that is the program which has been successfully running. I think if other states or people from other areas, if they are interested, they can take up this kind of models and start, because primary prevention, as we all know in mental health, primary prevention is a very debatable in many levels. Regarding, if you talk about primary prevention of schizophrenia or bipolar disorder, it may be difficult. We cannot say very much that it will be very effective, because we yet don't know many things about these kind of disorders. Whereas it comes to suicide and substance use, these kind of disorders and this kind of issues, definitely primary prevention has a big role. That is, we can do a lot of things to reduce the factors. Mr. Krishnakumar was saying about the last drop of water into a glass. That is causing the suicide, because already the glass is full of so many problems, and one last drop, the last straw on the camel's back, as they say, and that is what results in suicide. So how can we handle that situations? There are a lot of ways. Educating students, and models like giving, one model he explained was making the students give a sweet, a toffee to somebody who wears a seat belt and who wears a helmet, and giving punishment. What is the punishment given? They will be just given a paper saying that you have not obeyed the rule, you have violated this, you are not wearing a helmet, or you are not. So see, what the aim is not only to correct the person who is doing this, but the next generation. The student gets a very strong message that I should be doing these things correctly. And similarly, regarding cartoons also, he mentioned there are a lot of cartoons that teach good things to children, especially the younger children. And nowadays I hear from some of my friends who have younger children that there are good cartoons which teaches that gender neutrality, to behave in a gender sensitive way, that there is no discrimination between male or female, everybody has to do all kind. There are cartoons showing these kind of messages. And say, one of my friend was saying his daughter, after her play, she takes all the toys and keeps it in a place at night. So then they asked, so she says the cartoon, that man is doing that. The boy in the cartoon character, so the cartoon is influencing the child, a 3-year-old child. After the play, she tidies up the place and keeps all the toys in one corner, and then goes. She doesn't leave it like that and go. So this is the influence of cartoons. So if we can do these kind of exercises, this kind of cartoons in our regional languages, I think the rural people can also have access to these kind of small things that can give very good messages. So there are a lot of things that we can do for primary prevention, and already we have had models about that. So anything panelists wants to add more, we have little more time. So Umesh, anything you want to contribute more? Any other points regarding primary prevention and
നേരത്തെ ഞാൻ പറഞ്ഞാൽ സ്കൂൾ കൗൺസിലേഴ്സിൻ്റെ റോൾ ഞാൻ പറയാൻ വിട്ടു വരുന്നു. ഓരോ സ്കൂളിലും കൗൺസിലേഴ്സ് ഉണ്ട്. ആ കൗൺസിലേഴ്സിന് ഒന്നും കൂടി അവരെ ട്രെയിൻ ചെയ്യുക. He
was trying to emphasize on listening skills. Yes. That is the most important thing he was trying to repeatedly say, which I think I didn't highlight that again. Listening skill, training in listening skills.
അങ്ങനെ ഒരു ചെയ്യുന്നത് കുറച്ചുകൂടി നന്നാവുന്നുള്ള അഭിപ്രായമുണ്ട്. അതുപോലെ തന്നെ നമുക്ക് പോലീസിലായാലും ബാക്കിയുള്ള റിപ്പോർട്ട് ചെയ്യുന്ന കാര്യങ്ങളിൽ ഒരു ടീം വർക്ക്, ഓരോ സ്ഥലത്തും ഒരു ടീം ഉണ്ടാക്കുക. ഇപ്പം ഞാനും പറയാം, ഒരു വലിയൊരു മാറ്റം ഉണ്ടാക്കാൻ, ഇപ്പോൾ മാറാട് പോലെ സ്ഥലത്ത് മാറ്റം ഉണ്ടാക്കാൻ ഏറ്റവും കൂടുതൽ പറ്റിയത് ഇത്തരം ആളുകളുടെ കൂട്ടായ്മയാണ്. സോഷ്യൽ വർക്കേഴ്സും എല്ലാവരും കൂടി നമ്മൾ വർക്ക് ചെയ്തപ്പോൾ
നെയ്ബർഹുഡ് നെറ്റ്വർക്ക് കൈൻഡ് ഓഫ് തിങ്സ്.
അപ്പോൾ അത് നെയ്ബർഹുഡ് നെറ്റ്വർക്ക് ഒന്ന് ശക്തിപ്പെടുത്തുക. പിന്നെ അതാ ടൈംലി ഇൻ്റർവെൻഷൻ ഏറ്റവും പ്രധാനപ്പെട്ടത്. ഒരു മാറ്റിവെക്കപ്പെടേണ്ടതല്ല. ഇന്ന് കേട്ട വിത്തിൻ ഒരു 10 or 15 minutes ഒരാൾ അവിടെ എത്തണം. അയാളുടെ അടുത്ത് പോയി ഫിസിക്കലി അവിടെ എത്തുന്ന രീതിയിലേക്കുള്ള ടീം നമുക്ക് ഉണ്ടാക്കാൻ പറ്റിയാൽ അത് നമുക്ക് കഴിയുന്ന ഉറപ്പാണ്. കാരണം കേരളം, പ്രത്യേകിച്ചും കോഴിക്കോട് നിന്ന് നമുക്ക് ആരംഭിക്കാം. പിന്നെ കോഴിക്കോട് തന്നെ പല ഇനിഷ്യേറ്റീവ് സ്റ്റാർട്ട് ചെയ്തതാണ്. ഒരു 10 മിനിറ്റ് കൊണ്ടോ ഒരു 15 മിനിറ്റ് കൊണ്ടോ ഒരാൾ ഒരു ഇഷ്യൂ ഉണ്ടെന്ന് പറഞ്ഞാൽ അവിടെ എത്തിപ്പെടുന്ന രീതിയിലേക്കുള്ളൊരു നൈബർഹുഡ് നെറ്റ്വർക്ക് സിസ്റ്റം നമുക്ക് ഉണ്ടാക്കാൻ പറ്റിയാൽ ഏറ്റവും നന്നാവുന്ന കാര്യം അത് തന്നെയായിരിക്കും.
ഓക്കെ,
ഏതായാലും സൂയിസൈഡ് ഇല്ലാത്ത ഒരു നല്ല നാളേക്ക് ആശംസിച്ചുകൊണ്ട് ഇങ്ങനൊരു വേദിക്ക് തന്നതിന്, ശ്രമിച്ചതിന്, നിങ്ങളുടെ സമയം ചിലവഴിച്ചതിന് ഒക്കെ നന്ദി പറഞ്ഞുകൊണ്ട് എൻ്റെ നിർത്തുന്നു. താങ്ക് യു.
ഓക്കെ, എന്തായാലും any more comments regarding it? Okay, Shomar.
നമ്മുടെ സിനിമകളിൽ മനഃശാസ്ത്രവുമായിട്ട് ബന്ധപ്പെട്ടിട്ട് ഒരുപാട് സീനുകളുണ്ട്, ഒരുപാട് സിനിമകളുണ്ട്. പക്ഷേ എനിക്ക് പേഴ്സണലി, എൻ്റെ വളരെ പേഴ്സണലായിട്ടുള്ളൊരു കമൻ്റാണിത്. എനിക്ക് പേഴ്സണലി ഏറ്റവും കൂടുതൽ ഇഷ്ടപ്പെട്ടത് ഈ കുമ്പളങ്ങി നൈറ്റ്സ് എന്ന് പറഞ്ഞ സിനിമയിൽ ഒരു സൈക്കാട്രിസ്റ്റിൻ്റെ അടുത്ത് ശൗബിനി ഇരുന്ന് കരയുന്ന ഒരു സീനുണ്ട്. അപ്പോൾ അയാൾ പറയുന്ന 1-2 കാര്യങ്ങളുണ്ട്. ഇതൊക്കെ കേൾക്കാനല്ലേ കരയണം തോന്നുന്നുണ്ടോ, കരഞ്ഞോ എന്ന് പറയാൻ. ഇപ്പോൾ പറഞ്ഞതുപോലെ നമുക്കത് പറയാനൊരാളില്ലാത്തതിൻ്റെ ഒരു വിഷമം മുഴുവൻ ആ സീനിലുണ്ട്. കൃത്യം ആ സമയത്ത് ഒരാളിനോട് പറയാൻ പറ്റിയ പല ആത്മഹത്യകൾ ഈ പറഞ്ഞ പോലെ ആ ലാസ്റ്റ് ഡ്രോപ്പ് നമുക്ക് തട്ടിക്കളയാൻ കഴിഞ്ഞാൽ സത്യത്തിൽ വലിയൊരു കാര്യം എന്ന് വെച്ചാൽ ഈ ആത്മഹത്യ ചെയ്യാൻ ആവശ്യമുള്ള ധൈര്യത്തിൻ്റെ എത്രയോ കുറച്ച് മതി നമുക്ക് അതിനെക്കാട്ടി നന്നായിട്ട് ജീവിക്കാൻ. ആ ഒരു ഇതിലേക്ക് ശരി അത്തരം ഒരവസ്ഥ നമുക്ക് ഉണ്ടാക്കി കൊടുക്കാൻ, കേൾക്കാൻ, നമുക്ക് അവരെ കേൾക്കാൻ, ആ കുട്ടികളെ എന്നല്ല ആരെയായാലും ശരി, നമുക്ക് കേൾക്കാനുള്ള ഒരു സമയം നമുക്ക് അവർക്ക് കൊടുക്കാൻ പറ്റുക എന്നുള്ളതാണ്. പിന്നെ കൂട്ടായിട്ടുള്ളത്, അത് തീർച്ചയായിട്ടും ഈ കുട്ടികൾക്ക് ഒരുമിച്ച് കളിക്കാനുള്ള ഒരു അവസരം ഉറപ്പായിട്ടും ഉണ്ടാക്കി കൊടുക്കണം. കാരണം ഇപ്പോൾ നടക്കുന്ന സ്റ്റഡികളിലെല്ലാം ഇപ്പോൾ അതായത് കളിച്ചു വളർന്ന ആളുകളിൽ 70% പേര് ഈ പറഞ്ഞ ജീവിതശൈലി രോഗങ്ങൾക്ക് അടിപ്പെട്ടിരിക്കുന്നു. അപ്പോൾ കളിക്കാത്ത കുട്ടികൾ എത്രയാവും എന്നുള്ളത് നമ്മളറിയണ്ട, പക്ഷെ അവരെ അറിയിക്കണ്ടേ, അവരോട് പറയണ്ടേ നിങ്ങൾ ഈ രീതിയിലാണ് വരുന്നതെങ്കിൽ ഞങ്ങളെക്കാട്ടിൽ മോശമായിരിക്കും നിങ്ങളെന്നുള്ള അവരെ, അവിടെയാണ് ബാലാവകാശം വേണ്ടത്. അത് അവർക്ക് കൊടുക്കണം നമ്മൾ. അവർക്ക് കുറച്ചുകൂടി ഒന്ന് ഒരുമിച്ച് കളിക്കാനും തോക്കാനുള്ള അവസരം കൊടുക്കണം അവർക്ക്. അവർ ജയിക്കാൻ മാത്രമല്ല, ഒരേ ക്ലാസ്സിൽ തന്നെ എനിക്ക് നേരിട്ടറിയാവുന്നു 99 മാർക്ക് വാങ്ങിച്ച കുട്ടിയും 1 മാർക്ക് വാങ്ങിച്ച കുട്ടിയും. ആ 99 മാർക്ക് വാങ്ങിച്ച കുട്ടി തെറ്റിച്ച ചോദ്യമാണ് 1 മാർക്ക് കിട്ടിയ കുട്ടി എഴുതിയത്. അപ്പോൾ എങ്ങനെയാണ് നമ്മൾ കമ്പയർ ചെയ്യേണ്ടത്? അപ്പോൾ ആ ഒരു തരത്തിലേക്ക് നമ്മൾ മാറണം ഉറപ്പായിട്ടും. കുറച്ച് അവരെ കേൾക്കാനുള്ള ഒരു സ്പേസ് നമ്മൾ സമൂഹം ഉണ്ടാക്കി കൊടുക്കണം. അതാണ് നല്ല സമൂഹം.
So broadly we will conclude at that note that society has to change. There are so many things that society can do to reduce suicide, and general education, general awareness among public, and that catching that message at that point. When somebody communicates a distress, the person should be sensitive and should understand that yes, he is communicating something like that may lead to a suicide, and be with him and talk to him and just be with him and be supportive and spend some time, because that will help him to open up, and he may postpone the decision, he or she may postpone the decision, and that is the success of this listening. Okay, with that I think hand over to the organizers. Yeah, Shankar, please, sorry, Shankar, please.
No, I just want to say this. കരയുമ്പോൾ കൂടെ കരയാനും ചിരിക്കുമ്പോൾ കൂടെ ചിരിക്കാനും നമ്മുടെ കൂടെ ഒരു കൂട്ടുകാരനോ കൂട്ടുകാരിയോ ഉണ്ടെങ്കിൽ തീർച്ചയായും നമുക്ക് എത്രയോ ആത്മഹത്യകളെ നമുക്ക് പ്രിവെന്റ് ചെയ്യാൻ പറ്റും, ആത്മഹത്യകൾ നമുക്ക് മാറ്റിവെക്കാൻ പറ്റും എന്നുള്ളതാണ്. അതിനോടൊപ്പം തന്നെ I just want to say that being an organization, being a very big organization, Indian Medical Association should also come up with something which is very concrete, should take up a concrete steps against suicides among doctors. We should have IMA Kozhikode has been working closely with Tanal. We do have the suicide prevention number and all those things. But IMA Kerala as such should come up, each and every branch should come up with something, maybe some programs, or just like what we did today, we should also have a statewide programs, and also we should have some sort of interventions keep happening so that we should prevent doctors from doing suicides. Thank you.
Yeah, okay. Thank you, Dr. Shankar. I think we will all try to do this kind of activities. IMA Calicut has been running this tunnel suicide prevention telephone program for quite so many years, and there are so many other initiatives as the panelists have already discussed, so we will definitely work toward. So with that I conclude this discussion. Thank you. Back to the organizers.
And extremely sensitive issue, and we have been fortunate enough to actually have panelists from all walks of life, and I thank the panelists right now. And to the end of the session, I also thank our moderator for the panel discussion, Dr. Harish MT. Thank you all for being here, and thank you all the viewers once and again for being very patient and being with us for all through the presentations. Thank you everyone. Meeting adjourned. Thank you everyone. Bye.